Hello, everybody. A very good morning to one and all present here. I welcome you all to the 6th International Conference on Nursing Science in Healthcare, ICNSH, with the theme Nurses Together for Global Health Advancements. I'm confident that you had a great session yesterday with us, and I hope to see the same enthusiasm and participation from all the participants and attendees today. On that note, I would like to welcome our honorable dignitaries for today and our eminent keynote speakers. Dr. Shobna Gangadharan, Associate Professor, Department of Nursing, College of Health Sciences, University of Buraimi, Oman. AP Dr. Chong Mei Chang, Head of Department and Associate Professor, Gerontology, Department of Nursing Science, University Malaya, Kuala Lumpur, Malaysia. Dr. Benjamin Joel Bravoneria, DNS, MA, MSN, RN, CNE, NEA, BC, Program Director and Chair for BSN and MSN, Department of Nursing, King Faisal University, Board of Commissioner for Certifications, NLN, CNE, CNECL, CNEN, National League for Nursing, Vice President, Sigma Theta Tau International Honor Society of Nursing, Saudi Arabia. Dr. Bimala Ramu, Senior Lecturer, Department of Nursing Science, Faculty of Medicine, University of Malaya, Kuala Lumpur, Malaysia. Petroid Haria, TMD, Chairman, Quality Improvement and Patient Safety, Charisma Hospital, West Java, Indonesia. Mr. Abdullah Ali Ngara, Chief of Nursing Affairs, Eastern Health Cluster, Brand Ambassador, Nurses for Future Project, Saudi Arabia. I welcome you all to the 6th International Conference of Nursing Science and Healthcare. I hope you have a great day with us today. We can move on to the much awaited keynote lectures for today. I would like to welcome our first keynote speaker, Dr. Shobna Gangadharan, who is currently working as an associate professor in the Department of Nursing, College of Health Sciences, University of Buraimi, Oman. She has more than 24 years of experience in the field of nursing education and clinical and community nursing practice, and has done publications in national and international journals to her credit. She has completed her PhD at the PhD Center Apollo, College of Nursing, Chennai. She is recognized as a life member of the Trained Nurses Association of India, Indian Association of Palliative Care, Indian Association of Occupational Health, Society of Midwives India, Indian Menopause Society, attached to Chennai, Global Ambassadors of Sustainability, Omar Cancer Association, Sultanate of Oman, and Sigma Theta Tau International, and she's received Certificate of Appreciation from the Vice Dean, College of Nursing, King Khalid University, Khamis Musher. And she's the editor of books, Dr. E. Vijay's Textbook of Community Medicine, Community Health Nursing for Elsevier publication. She's the official reviewer of Ward Procedures 7E, published by Elsevier, contributory editor of Tamil Nadu Nurses and Midwives Council's Journal of Community Health Nursing, and official reviewer of Curious Journal of Medicine, and she has been in the panel of inspectors for Indian Nursing Council, the Tamil Nadu Dr. MGR Medical University, and Tamil Nadu Nurses and Midwives Council. Ma'am, I welcome you and I invite you for your lecture.
Thank you, Pauline, for this warm welcome. Happy morning to everyone over here. Can you hear me now? Can you hear me?
Yes, doctor. Yeah, it's very clear, doctor.
All right.
I see that you're not on mute, but I cannot hear you, ma'am.
I heard from others that they can hear me. Can you hear me, Pauline? Because someone said they can hear me.
Yeah, I think someone is sharing the screen. Just give me 1 second.
Yes, I can hear you clearly.
Okay. Madam Chong is saying that she can hear me. You want me to wait or shall we continue, yeah?
Oh, I can hear you now, ma'am. I can hear you now. Yes.
All right. So thank you once again, Pauline, for this warm welcome. And I wish everyone a warm morning wishes. Shall I share the screen?
Yes, please, ma'am. Yes, please.
Okay. Can you see my screen?
Yes, ma'am. We can see the screen.
All right. I'm very happy to present this topic as a keynote address for this conference. The topic is on nursing and sustainable development goals, optimizing the contribution through education, research, and practice. So as you all know that we had Millennium Development Goals, which is further developed into Sustainable Development Goals. And as nurses are learning much about these MDGs and SDGs, we should know much about our role in what role do we play in this. Nurses and midwives provide a wide range of activities or services. May it be prevention, caring, diagnosis, treatment, or in many aspects or in many specializations like improving maternal, newborn care, and child health. It could be in caring for patients with any diseases, say communicable or non-communicable disease. Especially we nurses are there in difficult to reach or hard to reach areas like communities. It could be hills or tribal areas where no other health services are available. So nurses constitute a major workforce in the globally, and we make significant contributions to improve health outcomes, and we save lives through the delivery of wide range of nursing and midwifery services. Now about SDG. In September 2015, world leaders from 193 states of United Nations came out with an agenda called 2030 Agenda for Sustainable Development to replace the Millennium Development Goals. So till then it was Millennium Development Goals. This agenda outlines 17 Sustainable Development Goals and 169 targets that we all need to work towards. So when we say we all need to work towards, as nurses, our effort should be to improve the whole world's progress towards health and other aspects which are related to health, which are totally interwoven into the 17 Sustainable Development Goals. But they go much further and tackle issues that affect people, planet, prosperity, peace, and partnership. I mean the SDGs. Now, when I say we have to work towards these goals, what are these goals? These are the 17 Sustainable Development Goals, which is aimed to or targeted to be reached by 2030. Now, coming to why nurses have to work towards these goals. Already, you may be thinking, are we expected to go out and solve all the world issues out there? Or when we are overworked and underpaid, we are already exhausted. Why do we have to do all these world-related, world development tasks? So do we have to do this or not? So the answer is quite a simple yes. But before saying yes, you're already doing it as nurses. We are giving care to patients 24/7, may it be community, may it be hospitals, but Apart from that, what the UN says is, the UN Sustainable Goals says is, when you provide care, you just focus on these 17 goals. Whenever possible, you focus on these 17 goals. And nurses can do lot in education, research, and practice with regard to these goals. So let's see these goals quickly one by one. First goal is no poverty. Just a moment, I get some other screen here. Okay, the first goal is no poverty, goal number 1, and we are going to see goal number 1 and 4 together, because they are often referred to as the social determinants of health. When we learn the determinants of health, maybe students across the world in nursing, we learn what are the various determinants, where it comes as poverty, education, all these are related to health, or they work as determinants. So what is the work of nurses? The work of nurses also has a great impact on delivering these determinants, these social determinants, like education and poverty, to attain SDG. Coming to second goal, zero hunger. When we say zero hunger, there are still hunger-driven communities in India, in many parts of the world, especially Africa and many other countries too. So here the main thing what nurses have to do is to work towards nutrition, improving the nutrition. Say, when we say nutrition, malnutrition affects 1/3 of people, and it has estimated to be the underlying cause of 45% of child deaths. It affects all age groups, and malnutrition can lead to impairments like physical and cognitive impairment. Say, for example, when there is malnutrition, it can a child or a school-going adolescent, when they go to school, they will have they cannot concentrate on their studies, things like that. And about physical, of course, you all know about the physical impact of malnutrition. They may be underweight, they may have nutritional deficiencies, things like that. So we can play a role. We are already playing a role, as I said, in this, but still more activities have to be conducted. This perpetuates a cycle of poverty and economic stagnation. So when there is hunger, malnutrition, and it's all related to poverty, and finally the economy of the nation or the region gets stagnated. Coming to goal 3, which is a very important goal for nurses, that's good health and well-being. Health has a central place in Sustainable Development Goal 3, especially. It ensures healthy lives and promoting well-being for all age groups. And we nurses, we have a clear and very important role to play in this SDG 3, which is health and well-being. We play a role in all aspects, maybe prevention of diseases, promotion of health, what else? Cure, maybe we give care, and then even in rehabilitation, palliative care, in all these phases. Okay, so coming to gender 5 is goal 5 is gender inequality. Gender equality is the fundamental human right. When we say equality, most of the times what happens is there is gender inequality in many parts of the world. Say more specifically, when we have to say, men are given more importance whether it comes to regarding food. Say, for example, when there are children in a family, male children are given first preference for a meal, and then female children, or the remnant meal is given to a female child, things like that. And of course, the young girls and women in many communities across the globe, they are vulnerable to illnesses like HIV, discriminatory feeding pattern, I already mentioned. Then violence among girls and women are there, lack of access to resources and opportunities, and a lack of decision-making power over their own health. Women don't have, or they have very less decision-making power on their own health for some or the other reason in many parts of the world. Women currently make up the vast majority of the nursing workforce. So here, when I have to quote about nursing, by becoming a nurse, many girls are empowered becoming a nurse, accessing formal education and training programs, obtaining an income, decent income, I can say, and gaining respect with their communities. So this sets them free from poverty cycle. So we'll have to encourage more people entering nursing, giving them empowerment. Coming to goal 6, clean water and stagnation. There are a lot of programs to provide clean water and prevent stagnation. So access to clean water, sanitation, and hygiene in healthcare facilities is very critical to deliver quality services and advance in health. So when we are in the hospitals, when nurses are in the hospitals or healthcare sectors, clean water is required, because say for example, a basic procedure, hand hygiene, although it's a most cost-effective intervention, it has to protect the health of the nurse and the patients. So whenever we use water, it has to be a clean water. Of course, other measures like hygiene, sanitation in hospitals has to be given importance. Coming to goal 7, it should be affordable. It's affordable energy and clean energy. Indoor air pollution is one of the very common factor, but it is rarely noticed or given importance. This affects mostly people in low middle income countries, which represent 82% of the world's population. Especially we have to say there are a lot of case reports with regard to this, which is submitted by WHO, International Council of Nurses. Say, I read through, when I was preparing this, I read through one case report in a remote place in Uganda. A woman is cooking food all through the day, and the kitchen does not have adequate ventilation, and she has 6 or 7 children all around her. So what happens is when she is constantly sitting there and cooking, the pollutants she breathes in, and finally it has caused her chronic obstructive lung disease. What happens is, when such patients come to us, we treat them, maybe doctors and nurses collaboratively we treat them. But when these patients are returning back home after discharge, they are going to the same place, same home, where they do the same routines. So we'll have to do a thorough assessment. What is the existing problem? What is the cause of the problem, and how can we remove? Maybe nurses are learning epidemiology very much and trying to identify the cause, removing the cause. All those are very important aspects. Goal 8 is decent work and economic growth. So a number of strategies will need to be implemented to attract people into nursing profession. It is not just attracting the students into nursing profession. Once we attract, we have to retain them forever. So what strategies are we going to follow matters, and how much importance or how much we are going to explain them the goodness of nursing, things like that. Here there are some problem areas like education. In education, we have We have mostly attrition among undergraduate courses students. Access to postgraduate education, again, is not possible, although they complete undergraduate education. Then career pathway progression, they may not know how to progress in the career pathway. That guidance and the counseling is required. Continuing education opportunities. Many of them, they complete their undergraduate education. Once they go into hospitals, they don't know. Even they do a graduation project as a part of research, but they are so motivated when they are in the education side, in the college. But when they go to hospital, I'm getting my echo. So there should be more opportunities given for continuing education. And the remuneration is very important. Many nurses are given less salary. They are salaried less and their conditions of employment are poor. So all these areas we'll have to work on. The goal 9 is industry, innovation, and infrastructure. Here, when it comes to infrastructure or innovation, we'll have to consider these 3 aspects: quality, efficiency, and access. So we have adequate hospitals which can give jobs for more nurses, but the quality matters a lot. We have very few quality hospitals hospitals or healthcare sectors which give quality care. And efficiency and access is very important. Access is the number of nurses who graduate, they don't have access to better work environments. May it be nurses, may it be patients. Patients also may not have good infrastructure when they have illness to transport to the hospitals. Say, I remember one of my own students saying her mother had cancer. So she'll have to take her mother to the hospital every time, travel for 3 hours because the central cancer hospital is far away from her home. So she'll have to take leave and she'll have to take her mother to the hospital. So things like that. So what happens is sometimes they may feel frustrated. They may not go to the hospital because may not be, the support system may not be there, things like that. Goal 10 is reduce inequalities. So equality is very important. And there are a lot of disadvantaged. So the most disadvantaged people are less likely to receive healthcare. So they may not open up and say their health problems, and when it becomes worse or when they go to the end stage of the disease, people around them, their family members or well-wishers come to know, then the disease might have got worsened. So standing up for the people, we as nurses, when we no other healthcare professionals go to community like nurses. So we know more about these inequalities or the disparities. We have to stand up for the people who are disadvantaged and help to enrich the heritage of the profession. Say, for example, nurses who are in the forefront, like in policy making, they can speak in the forum about such people in their own communities or regions and try to get equality for those disadvantaged. Goal 11 is sustainable cities and communities. It includes nowadays, when you see decades back, there were only very few cities in any country. Which were you can count popular cities in a country, but now a lot of cities are growing up. But the problem is, again, when those cities are there, are they having good wastewater management, building standards? Good schools for the children, or accessible? Are the schools accessible to this? Children in workplaces? How about the workplaces? Are they better, things like that. So the quality of the city, the town planning, all those matters, and is it managed well, coming under the standards. Coming to goal 12, it is responsible consumption and production. So when it comes to each point, each goal has got so many aspects, so many things to discuss, but I have picked only very important aspects, and which is regarding mostly relevant to nursing. Healthcare facilities to contribute on sustainability of resources. So very important is we'll have to focus on sustainability of resources. The resources, what are we having adequate resources? And are we may have sometimes resources, but are we using it appropriately? And are we using it or wasting it? Are the resources sustainable? Say, for example, especially in healthcare industry, we have so much of waste, biomedical waste. Is it managed well? Are they disposed well? Things like that, we have to be very mindful. As nurses, most of the time nurses are very mindful of this, but an emphasis have to be made time and time. Goal 13 speaks about climatic action. So when we say climatic action, all of us know that there is climate change or global warming taking place. So what is our role here, nurses' role? Already many countries or many regions in a country, say for example, they go for environment, protecting environment, like say no to plastics. I come from a place in India where we don't use plastic bags anymore. So things like that, small steps to be taken. Maybe as nurses, when we find small things which is affecting the climate, we can introduce that into the to the government to make policy changes, things like that. What are the roles of nurses here is an adaptation and mitigation strategies. So when there is climatic action, there are good things happening in because of climate change. Of course, the bad things are also happening. So good things in the sense, it is not nowadays. It's not because of global warming. There is not too much of cold weather nowadays. That's good again. But the bad things are again pollution and all those things. Goal 14 is life below water. So you may wonder, what are we going to do as nurses for this life below water? So we'll have to show concern for our oceans and waterways. Why nurses have to play a great role in all this is the strength of nurses is more. Our voice, when we raise a voice, it will be heard through many forums. So that's the reason you can raise your voice from your small regional level, then you may, which can finally go to international level. I will speak about all those later. So care for our oceans and waterways. They provide natural. Why do we have to care? Because they provide natural resources like food, medicine, biofuel. Sometimes when we throw a lot of plastics into the oceans, what it can cause is the fishes inside or the undersea marine living beings, they all tend to die, they all tend to become sick, things like that. So we'll have to make sure the community is much aware of the reason why we have to take care of the life below water. Coming to goal 15, life on land. So biodiversity is very important and ecosystem. The problem is we are slowly getting, there is a decline in this biodiversity, and there's a lot of changes happening in the ecosystem. So there is, what happens when this loss of biodiversity and ecosystem happens? There is risk for food and nutrition security. When we don't get good food, say there is something called seasonal food. In a particular season, a particular food is available. That was there earlier, but nowadays you get 24/7 apples. All through the seasons, you get apple, papaya, anything, Goa. And the natural disasters again can happen when we don't take care of the biodiversity. Already it's happening around the world. More places we have. Someone's mic is on, I believe. Speaker is on.
Yes, no, I was looking. Sorry.
Okay,
Yes,
goal
ma'am.
16 is about peace, justice, and strong institutions. So here we have to address poverty, inequality. Already one of our goal is poverty. So inequality, chaos, and when we address all these components, the existing poverty, inequality, and chaos has to be replaced with peace and justice. So now here, nurses can provide solutions. We have seen the damage to the nation or the globe happening because of all this. We are seeing so much of all the impact of all this in the world. But one positive thing what we nurses have is we have the public trust, the community. Major healthcare workforce who visits the community is nurses, and they warmly welcome you. You have the great trust received from the public or the community. So that's the reason you understand the day-to-day problems of the community. So it's easy to address to the policymakers about it. Goal 17 is partnership for the goals. Healthcare sector has to work in collaboration with other industries and other governmental sectors. We cannot work alone and achieve all these goals. When we have to work, we'll have to work in collaboration with many sectors like education, industries, and other governmental sectors. Only together you can achieve the goals. So here, I will go in brief about how can we contribute through education and practice and research. So we'll have to do an academic and clinical partnership. Most of the time what happens is we may be doing good in the academics. Like in the colleges, you may be teaching well, but when a student goes from the classroom to the clinicals, there may not be a connection. So we'll have to have a strong partnership between our academics and clinical facilities. So this acts as an important mechanism for strengthening nursing education, practice, and research. This also helps nurses become well positioned to lead in change and advance in health. So when you have a good connection with the clinical facility, definitely more researches can be conducted, which you can collaborate every time when you do research with the government or governmental nurses or the nursing heads, so that you will be able to do better data collection, better studies will be published. And furthermore, if you want to do researches, they may be of help. Now, when we say, when we address this, we'll have to address about some of the challenges faced in nursing education. What are they? One is aligning education with the practice environment. We need to know our curriculum may be totally different from the practice environment. So in that case, we should know what is happening in the practice environment. In some countries or in some places, the technology might have grown, the medical, the hospitals or healthcare sector might have developed so well, but in the education side, because of the funds, many reasons, the college may not be utilizing or following the same standards And the students may find it difficult, they may find a big gap between what they learn and what they practice in the environment, in the clinical settings. So hence curriculum enhancement is very important. Nursing as a part of an integrated healthcare workforce. So when there is a healthcare workforce for the country or the region, so nurses have to represent it. Is there good representation from nursing? There should be so. To have this, we may have to become members of international societies, various boards, associations. See, always we should not expect somebody to push us. Maybe you may see some people who have come to that level. They might have put a lot of effort and come to that level. It's not that easy. So find out what is happening around the world. Now everything is very easy at the click of the mouse. You can sit down and browse and find out. Earlier, those days, it was not like that. When we were growing up, it was so difficult. We'll have to go to people, ask. Sometimes people may tell us, and sometimes they may not say everything. There could be some hidden agenda, things like that. Now, faculty development challenges do happen in educational settings. So faculty may be getting very busy with their regular routine lectures, but they may not have development like continuing nursing education or medical education. They may be interested in doing researches, but they may not be given opportunity, things like that. Technological challenges do happen for nurses, especially in the education sector. They may not be aware of various things which has come, a lot of growths have happened in technology, which maybe nursing educators are less aware. So they have to keep abreast of knowledge in all these areas. Cultural diversity is one very important aspect in nursing education, especially nurses who work abroad from other countries. They may know. So there is when you take a particular university or a college, there will be people from different countries working in a nursing college. So understanding the different culture, it may take some time, but understanding would be very essential. Of course, economic challenges are there. Nurse educators are less paid sometimes. Most of the time it happens in many places. So identify, work for your career growth, identify the challenges and then work on it. Coming to strengthening the education, nursing education to support research and evidence-based practice. So quality nursing and midwifery education is a very important key driving force for improving the quality of health services. So when the education is improved, the quality of health service definitely improves. We remember we didn't have a baccalaureate or a master's or doctorate those days. We had hardly diploma or associate nursing degree, but now we have so many, even till postdoctoral people have achieved in nursing. So definitely the quality of nursing education has improved. But the problem with this is there is more quantity. When the quantity is expected more, the quality is again going down. So people, whoever does a higher education or career development, like doctoral or postdoctoral, they'll have to be passionate about it. Passion is very important. Just getting a degree and I will be one among anyone, I just wanted a degree. No, it shouldn't be like that. Work towards your passion, so that your interest, whichever field of specialization, do more activities in that. So there's a great critical need for competent educators to develop and implement evidence-based curricula that are in line with local needs. Yes, we'll have to understand what are the local needs, what's happening in the region we are working, and try to develop. So the educators are available, but are they competent matters here? So training them, giving them more, orienting them to more things happening around the world. It's a task. Education, research, and evidence-based practice, they are all interwoven or interrelated. Together, they promote lifelong learning. So, a nurse who is in a hospital or a healthcare setting, she also can be in education. She also can do several researches. Yes, there is a struggle. They have targets they have to reach, say, for example, but still there are nurses in the clinical side doing a lot of projects, researches. Yes. So learning from what others are doing, getting into many forums, becoming visible in the present day, internet community. Already the young nurses are using internet, but how do you use is very important for your career, for your profession use. Be in the professional connecting forums like LinkedIn, ResearchGate, things like that, so that you will know what developments are happening in the profession. That helps you in lifelong learning. Recent literature reveals that weaknesses and gaps in countries like African region where research evidence is needed to address the hefty burden of disease all across all health priorities. When we say there is a large burden of disease, say it's more of infectious diseases like HIV and non-communicable diseases also are available. So the situation strongly suggests that there should be more research among undergraduate and post-basic nursing education, which has to be strengthened and scaled up to produce good, efficient, quality researchers who are prepared to lead research projects. Leading the projects very important. There's a need to facilitate utilization of research evidence and evidence-based practice. So already published evidences should be utilized for practices. So those who are in the clinical settings have to use the best practices. So effective universal health coverage and evidence-based practice. This should apply to the spectrum of health, which includes health promotion, prevention of disease, treatment, rehabilitation, and even palliative care. So when we say this, it should apply to the spectrum of health. It should encompass the 4 important domains, which are triple AQ domains. What is this triple AQ domain? Availability, accessibility, acceptability, and quality of health services. So all these, they have implications for research, education, and evidence-based practice in nursing and midwifery. Nurses and midwives must be prepared to work in teams. Yes, that's very important, which is lacking many at times. So working in collaboration with different members is essential. Say, for example, when we take research, some people, they publish or they conduct research with only one group of members. So you will not know what's happening outside with others. So trying to develop or progress by doing different types of researches with different variety of people collaborating. So this is a simple table which shows the levels of engagement in evidence-based practice. As an individual nurse, paying attention to clinical problems from everyday practice, then read more professional journals regularly. They get it online now. They can get access to it. May it be Sigma, may it be through any international societies, or they can go to PubMed. They can access these journals and critique the research evidences. When it comes to ward or unit clinical nurse, they have to identify clinical problems through quality improvement activities. They can also develop EBP guidelines, protocols, procedures. Coming to organizational level, building a culture of EBP, mission and vision statement are important. A regional, national, and international level, promoting evidence-based practice and sharing them among multiple organizations, professional bodies are important. So I'm done with this. These are my references. Someone's mic is on. So one of my references, see, I had many references, but these two are I have used mostly, which are very important ones. You can go browse up, or you can download the PDF of this. International Council of Nurses, a voice to lead, achieving the Sustainable Development Goals, and another one is from WHO, Nursing and SDG, optimizing the contributions of nursing and midwifery workforce to achieve universal health coverage and sustainable development goals. Thank you all. I thank Society for Nursing Practice for giving me this opportunity to present in this esteemed conference at Indonesia. Thank you so much for all of you for the patient listening. And if you need to contact me, you can contact me anytime from in this mail ID, shobna@uob.edu.om. It's .uob.edu, sorry.
Thank you so much, ma'am. Thank you so much for taking out the time and doing the lecture. I'm sure it was very useful presentation for everybody. Thank you so much, ma'am. And participants, just a couple of things. Ma'am has been very generous. She has told me we can contact her. If you have any questions, you have the email ID on the screen right now. So you can make a note of it and you can contact ma'am for any future correspondence. And just a few etiquettes that just a reminder, gentle reminder, please make sure you're on mute because it will be disturbing for everybody, and just to ensure that the conference is going on smooth. So when you join a meeting or you leave and you come back, just make sure that you're on mute so that it will be convenient and it will not be a disturbance candidate. Okay, on that note, we'll go to the next keynote lecture.
I'll stop sharing, Colin.
Yes, please. Yes, please, ma'am.
Thank you.
I welcome Dr. Benjamin Joel Raponeria Obenjo. Sir is a nursing education specialist, leader and coach. His passion is to use the power of grit, authenticity, kindness, and gratitude to influence the lives of people by helping them see the heroes that lies within themselves. He is the program director of the top BSN program in Saudi Arabia in terms of licensure outcomes. He also spearheaded the first NSM nurse educator track and developed the RN BSN bridging program that is expected to serve more than 3,000 plus nurse technicians in the eastern region. To serve the nursing profession, he also works as an item writer and is the current board of commissioner for certification in the National League for Nursing in the USA. This July 2023, he will serve as the president-elect from 2023 through 2025 and as a president from 2025 through 2027 with the Sigma Theta to International Honor Society of Nursing Phi Gamma chapter. His current projects involve ACEN accreditation of the BSN and MSN programs at King Faisal University, where he is the nurse administrator. From January 2023 to June 2023, he also sponsored and organized with the St. Paul University, Philippines, a global webinar series titled Higher Education in Focus, Discover, Visualize, and Reimagine that explored the challenges, opportunities, and lessons that educational institutions around the world need. This series also involved cutting-edge thinking in today's higher education. The series was attended by more than 3,000 participants from 22 countries. Sir, I warmly welcome you for your presentation.
Hi, so first of all, thank you so much for that introduction. So I am really grateful for the kindness of the nursing professionals who organized this event. Actually, I have very limited sleep because I have been doing a lot of things because I will be traveling tomorrow, and and after 3 days I will be coming back and then traveling again. I truly appreciate the invitation, and it was really such a pleasure to be given this platform to always use my voice for a cause. I really hope that the participants of this conference will benefit from this short keynote. But this time, the focus of this presentation will revolve around the topic that I am currently engaged and the fact that I'm also currently in the field of nursing education. So I really appreciate the presentation a while ago because it talked about the sustainable development goals as well. So I really learned from the previous presentation, also from Dr. Shobana. Additionally, also, I will try my best to deliver it as light as possible because since this is a keynote presentation, I want to make sure that, how can I say it? Because you will be engaged and involved in a lot of scientific discussions. And I will just let you to be looking at pictures and some illustrations, and I will also try to explain what's behind each of them. So the title of this presentation is Transforming Nursing Education Through Integration and Application of the United Nations Sustainable Development Goals, or the UN Sustainable Development Goals framework in nursing programs. But before I do that, I just would like to ask all the participants that we have here if, wait a minute. Okay, I just want to ask the participants if you may want to participate in the link that I posted in the chat box because I really want everybody to be at least somehow engaged. So if you can please try to take a look at the link that I have posted, and I want the participants to hope. Can you hear me? Is it clear? Is my voice clear?
Yes, doctor, your voice is clear. Maybe someone has unmuted.
Okay. So if you may want to please, how can I say it? Try to start to participate with the link that I shared to everyone. This is actually a word cloud, so I'm trying to, how can I say it, to make sure that everybody will be engaged, and I want to make sure if our participants are active in this presentation. So, you may want to access the link that I have posted, please, or probably I will be using a different link. Can you access it or no?
I'm just checking, sir. I think we may be able to do it if we are able to copy and paste the link in a separate tab. I'm just checking if that's possible.
Yeah, I will do it this way. So maybe it might work this time.
Yeah, I think it's asking us to sign up and.
Oh.
Yeah.
Okay, so not to keep it longer, I will just try to navigate on how can I solve this these glitches, and I will try my best to continue with the presentation so that I will not be running out of time because this is a very short. I will be doing it later. Actually, Dr. Shabana mentioned about the Sustainable Development Goals a while ago, which includes 17 goals, and the 2030 agenda for this Sustainable Development Goals is actually a 15-year action plan to achieve the following goals, which was unanimously adopted by all United Nations member states in September 2015 and took effect on January 1, 2016. The agenda consists of 17 SDGs addressing social, economic, and environmental determinants of health and 169 associated targets. That includes people, planet, peace, prosperity, and partnerships. So my question now is, what are these goals? I mean, why is it necessary for nurses like us to be able to like understand or get to know about all these goals? So if you will try to take a look, it's kind of interesting, right? Because this this sustainable development goals is actually goals that hopefully nurses like us, particularly nurses around the world, whether you are in the field of education, whether you are in the field of in practice or also in research, it is our responsibility, being one of the largest healthcare workforce, to be a part of it. And the reason why I would like to mention my organization, to which I am involved, because Sigma is an organization with more than 100,000 members in 100 countries around the world. However, I am serving the Pi Gamma chapter, and one of the advocacies of our organization is actually advancing global health. So, aside from that, it also includes celebrating nursing excellence in the area of leadership, in the area of scholarship, and also in service. And a part of the vision of the organization is to be bold. It's actually the organizational call to action from 2021 to 2023 that we, as nurse leaders or a member of this organization, we need to be bold, particularly when it comes to interprofessional partnerships that includes, involvement with stakeholders. When it comes to advocacies or different advocacies that are related to that 17 Sustainable Development Goals. And what I want to say is that this is more of like, how can I say it, a social responsibility as nurses or being a nurse. This is actually also our responsibility as a part of being a global citizen, because nowadays, if you may want to, if you may come to think of it, nurses are not only being prepared in nursing schools to serve the vulnerable populations in areas where they are residing, but nurses nowadays should be trained and educated also, as I mentioned a while ago, to be a part of the global society and as a global citizen. So, again, why they are important to us? Why do you think this is important to nurses like us? Because approximately, and this data is according to the World Health Organization, there are 27 million men and women that make up the global nursing and midwifery workforce. And this actually accounts, if you will try to take a look at that figure, 50%, 50% of the global health workforce. And this is according to the World Health Organization. And being one of the largest, just like what I've mentioned, one of the things that we learn from nursing schools is leadership, right? Leadership. And a part of leadership is advocacy. And advocacy is such a very important aspect in the nursing profession, particularly also on how we are educating the students in nursing schools of today, particularly in this contemporary era or contemporary period. Meaning, on how are we going to use our voices for a cause? And how are we going to utilize or use our collective voices as nurses with all the causes that was mentioned even in the previous presentation by Dr. Shabana as well? And how are we going to not only utilize our voice, but basically how to contribute to each of those goals? How can we impact change in our own society without, how can I say it, by being assertive or being courageous? Should I say courageous? So when it comes to nursing education, it is very crucial that early in the nursing students training, in the bachelor's level, as an example, there are competencies that are needed to be taught with, to nursing students as they progress into the nursing curriculum and as they gradually develop all those competencies, although it varies in different countries, right? In Saudi Arabia, there are different sets of clearly defined competencies by the Saudi Commission for Health Specialties. It is also different in the United States. It depends on the organization. It can be from the American Association for Colleges of Nursing. They have different set of competencies as well. Probably in India, there are also different sets of competencies. So when nurses graduate, they are not only tasked to serve vulnerable populations, as I mentioned a while ago, in the country in which they are serving, but being a part of the global society and as a part of the what we call the global citizen. And I think it was also mentioned from the previous presentation a while ago that being one of the most trusted professions, nurses must boldly leverage its power because it is our responsibility to protect not only the health of the people, but as well as our communities and also the planet, right? So if you will try to take a look at the picture now, you will see different goals. And these goals, okay, since it was already discussed a while ago, which is actually great. So there's really no need for me to look at them and discuss them one by one. These goals are linked and connected to everyday global issues in which nurses like us are significantly exposed. Like, for example, climate change. How can we do something to impact climate change in a positive way? Hunger, for example, which is SDG number 2. Inequalities or inequities that are happening around us. How can we advocate with other people for them to be able to receive, should I say, equal rights and opportunities, all right, in whatever society they are, currently residing or living. So the most important in this presentation is because we're talking about nursing education in our own little ways as nurses, and also on how, also on when we are preparing student nurses in our own little ways, how can we contribute? And how can we also educate the students to be a part of that contribution? How can we develop or produce, okay, nurses whose passion is advocacy, and how are we going to make that advocacy alive, right? And collectively involve themselves to become a part of the solution in terms of this global goals that was mentioned. So I will just give an example because recently I am working on a project that involves advocating for advocates. So even if our responsibility in nursing education is actually to educate the students through their curriculum for these sustainable development goals to be interwoven in the curriculum or probably integrated or threaded across the curriculum. On my end, as a nurse leader, I have a responsibility also to empower or to advocate for the advocates. Okay, this is actually a part of the project that I'm currently doing that will be involving nurses in some countries. But the thing is, the reason why I had to embark on that particular project because I am thinking that who will be the one to empower these advocates? Who will be the one to support these advocates? Who will ignite their passion? Who will be the one to give education to those who are already interested to become a part of this movement? And who will educate these nurses in terms of health and social policy? Like, for example, in terms of, students who are studying in nursing schools. And aside from that, the reason why it is very important for nurses like us, because there are a lot of national or global public health emergencies that are happening all the time, right? Not all the time, but it happened. Like, the biggest is like the COVID-19 pandemic, right? That is such a global, multi-dimensional situation that had a strong impact, but negatively, all right, negatively, not only on the people who have died, but also in many different professions, such as our profession, which is nursing. And we all know that during that time, during the global COVID-19 pandemic, a lot of people died, and definitely it resulted to the need for more nurses. Okay, so really it impacted global nursing shortage, or there is an extreme shortage around the world. So another thing, if I may think of, because as I told you, I will not be talking about one by one, is issues such as climate change or war in between countries that just happened like recently between Russia and Ukraine, and systemic racism that happened in the United States. That's why they have this campaign about Black Lives Matter. These are just some of the complex challenges that created disruption and multiple uncertainties around the world. Okay, now, our responsibility in nursing education is really to integrate, to how can I say it, to find ways on how are we going to strengthen our curriculum. And there are a lot of things that will be mentioned later, but I want to mention that we as nurses, our main role here is to how to say it, to use our voice, all right, to utilize or use our voice or collective voices to impact change in many different ways, in multitude kind of ways. So, can you please mute your microphone? To those participants whose microphones are turned on, if you may want, please mute your microphone. Okay. So, wait a minute. I can hear some, okay. So now here, quality education. So I'll be talking about quality education. So as you can see, quality education is one of the key sustainable development goals. Okay. Quality education itself, okay, is a specific target and a key priority of these sustainable development goals. The educational landscape itself aims to provide awareness of the SDGs themselves. So it is like a question of, do nurses know this, like UN Sustainable Development Goals? Because according to UNESCO in 2015, it is at the heart of our efforts both to adapt to change and to transform the world within which we live. However, it was mentioned in this statement, the awareness of these SDGs across to nursing education is sporadic, and gaps remain where these global challenges are neglected. So this is the reason why I had to concentrate on this area, because what are we going to do now, right? What are we going to do? What will be our responsibility? Is there anything that we can contribute to all the nurses or particularly leaders in this event, for example? How can you become a part of this? Especially those who are in nursing education, nursing schools, who are preparing nurses of the future. So now let's talk about opportunities. What are the opportunities? There is a huge number, or rather a huge number of opportunities and recommendations to make this possible. Okay, so I will be naming a few, or I will be mentioning a few, although there are a lot. But number one, most of the countries, or probably some of the countries, have its own accreditation arm, right? Accreditation arm. Accreditation is a review process to determine if educational programs are meeting the defined standards of quality. So I will give an example in the United States. So I will try my best to make the how can I say, the examples global as possible. Like for example, Accreditation Commission for Education in Nursing. Okay. So nursing programs who are embarking in this kind of how can I say, accreditation, who are embarking in this kind of accreditation, it is actually the leading authority for nursing education accreditation in the United States. Even in a level of a faculty member, it's actually one of the criteria that faculty or full-time faculty members should develop and maintain current expertise. And one of the criteria is about the principles of diversity, equity, and inclusion, right? So I'm just giving an example. So now it is becoming a part of nursing education. It's becoming a part of the criteria in accreditation. So what does it mean? It means that on the faculty level, the educators themselves who are working in nursing schools, they need to know these concepts, diversity, equity, and inclusion. Because as a global citizen, how can we ensure that the nurses that we are educating or the student nurses that we are educating are mindful of the biases towards other people of different race or of different nationalities, as an example, right? Or do faculty members have trainings on health equity? Do faculty members have training on implicit bias or the science of our brains? How can I say it? When it comes to these issues, right? So it makes sense. I mean, another thing that we need to look into nursing. Okay, please mute your microphones. Another thing that we need to look into is the nursing curriculum, right? Because the nursing curriculum, all nursing programs around the world have what we call end of program student learning outcomes or the program learning outcomes. And when we are drafting our end of program student learning outcomes, particularly for nursing education leaders, it needs to be based on contemporary professional nursing standards that are, up to that standard in our own countries, guidelines and competencies. So nursing students of today and nursing programs of today need to have competencies related to the same concepts that I mentioned a while ago, such as, diversity, equity, and inclusion. And additionally, do our nursing programs have program outcomes that are related to these concepts? Or are the students taught about social policy or health policy so that in the future they can advocate and impact change system-wide or system-wide policy level? You got me? Or healthcare system level. So, okay, honestly speaking, this topic is quite comprehensive, but I will just be mentioning one of the most important that I feel like educators and nursing schools can easily integrate in their programs or in their curriculum. So when it comes to teaching strategies or educational models, it's very important, I will tell you, service learning is actually one of the most, should I say, how can I say it? A philosophy of education that emphasizes active learning. It is actually a form of active learning that meets learning outcomes both in the program level and also in the course level, while also redirecting the learners or the students to be able to gain, how can I say it, competency when it comes to social responsibility, to become responsible to the world around them, okay? Or for them to how can I say it, to have the ability to become engaged on what is happening around them.
Wouldn't have it. I don't.
All right. Okay, there are a lot of, how can I say it, action. Okay, please mute your microphones. Okay, service learning also, okay, is a way of connecting learning with service, okay, that needs actual community needs. Because if you may want to try to think of, we have courses such as community health nursing, right? And and this is such a course wherein we are serving the community. We are doing something to the community, or we are, you got me, supporting vulnerable populations, doing projects that are related to, let's say, nutrition, related to education, related to climate change. However, service learning it provides a concrete opportunities for the students to learn new skills, okay, and to test new roles that encourage risk taking and reward competence. Okay? And another thing, because you might be wondering if volunteerism is same as service learning. Or you might be wondering if service learning and experiential learning are the same. Okay? Because sometimes they are used interchangeably. Okay? But they are distinct entities. Experiential learning, it actually involves hands-on work. Okay? But I will just try to summarize this one. But what is unique with service learning is its reflective component. Okay, so basically, after the student engage themselves in a form of a community service, let's say they conducted a mother's class, or probably they are involved in project related to nutrition of the elderly population, and they are going to the community, for example, like how can I say it, feeding the elderly, to that things like this. It's like, what's different about service learning is its reflective component. Okay, so this educational philosophy is actually, how can I say, it touches the heart. Okay, it makes nurses and it makes nursing students more grounded. Okay, more grounded. It basically includes structured time for reflection. So this is actually what's different. Because when you are doing community service and then after that you will go home, that's a totally different story. With service learning, there is a structured way, or how can I say it, reflective means for the students to reflect on what they have done and to reflect on what they have learned and reflect on what they felt all throughout that experience of providing service to different, to vulnerable populations, basically. All right? So colleges and universities, they may want to engage in service learning differently because we all know, like different schools have different educational, how can I say, missions or institutional missions and traditions. And some universities, they embrace service learning as a part of their philosophy, right? Or probably in some schools, it's a part of their spiritual mission, okay? But regardless of how the universities embrace service learning, it must do the following. So basically, it is also a structured, how can I say it, pedagogy or a structured educational philosophy, okay? So, of course, it can be interwoven within the, how can I say it, across the curriculum. It can even start after the first, semester of the program and threaded across the curriculum. Okay, so it's just a matter of how are you going to make sure that even if you are implementing it in your curriculum, it's connected to the program and the course learning outcomes, and you will ensure that it promotes learning. Okay, so systematically also, you need to evaluate it. Okay, for you to be able to assess its effectiveness and you thread it in the curriculum, it needs to be, how can I say it, rationally evaluated, okay, for you to know its effectiveness. So it is really more of experiential, okay, but not observation. All right. You also allow the students to use skills and knowledge, okay, when engaging in activities that address human and community needs via structured and unstructured opportunities. All right. So I've already mentioned about the reflective component. The good thing about service learning is that you are assisting and helping the student to develop that sense of caring, cultural awareness, social responsibility, health advocacy, and global awareness. And what I mentioned a while ago is civic responsibility. So basically this, how can I say, this framework is actually quite a good one. And through the years of being involved when it comes to community service, I got to learn service learning through literature and actually because of LLM. I got to know service learning because of the National League. All right. So now let me talk about quickly, because I'm about to end the presentation very soon. So I just want to mention about the benefits. What are the benefits to the students? Okay, it benefits the students in many different ways. So direct participation in many different kinds of activities that addresses and socializing themselves. Okay, can you please mute your microphone? Okay, and to be socialized in the profession, you're also introducing the students to new technical and professional skills. Right? It actually promotes, and this is according to Polly and also to Taylor, that we are promoting the preparation of nurses who are capable of serving as advocates for social justice. Okay, so this is actually what's good about service learning. Okay, what about to the faculty? What's the benefit to the faculty? Even though the faculty may not be on the site with the students, the faculty supervising the activities involving surveys, and how can I say it, or significant faculty time commitment is required to plan the assignment, to obtain community partners, read the student journals, because really the role of the faculty here is really to, how can I say it, to listen to the reflective experiences and reflective vulnerabilities of the students from what they felt all throughout that experience. Faculty who link service learning activities in their courses, okay, with their research and service interests have increased commitment to continuing its use. And this is according to research. What about the benefits to the community and to the institution? So for example, one of the research according to Rising, way back 2006, it is found that as a result of service learning project in which nursing students conducted hypertension screening and health counseling, 1 year later, the community recipients had made modifications in their health management behaviors, such as diet and weight loss. So basically, it has a positive impact. And there are a lot of examples that I will not be explaining anymore. All right. So, so now, these are just some examples, because there are a lot of examples in my work. Okay, like in a year, we have like maybe more than 40 service learning activities. And these are actually old ones. Okay, what I will be showing you. Okay, so these are just some of the activities that were done by the students. This is actually something related to breast cancer awareness. Okay, so this is actually more on empowering nursing students, okay, or student nurse empowerment. Okay, so this is something related to health and wellness. Actually, these are all related to SDG 3, which I showed a while ago. This is actually related to blood donation, or the importance of blood donation, okay, CPR, okay, promoting the World Hand Washing Day, all right? These are actually some projects through the years that were done in our school. This is about vaccination, okay, this is about patient safety, and these are done in many different places, okay, and done through the years. As I told you, we have been very active with this, and it's like we are doing it maybe like a minimum of, as I said, as I told you, minimum of around 40, more than 40. So now, to end my presentation, I just would like to mention that there is such a call to action when it comes to this initiative. Okay, so in view of the current and the future of nursing education, this United Nations Sustainable Development Goals framework offers a variety, or a wide variety, of opportunities that can be capitalized in preparation of the next breed of nurses, or the future nurses, with strong health policy, global advocacy, and leadership skills. Okay? Undergraduate programs, even in the graduate program level, I will tell you, can offer these opportunities to enculturate future nurses on the important role that they play as a member or a part of the global society that I've mentioned a while ago. Diverse educational strategies such as critical pedagogy or service learning, just like what I've mentioned, may influence a paradigm shift towards a more consistent global action. So integration of the Sustainable Development Goals into nursing education positions us as leaders, particularly someone like me, to become a thought leader, okay, in the field and provides opportunities for new areas of research, teaching, and service, same as with what was mentioned a while ago by Dr. Shabana. Okay? And to end this presentation, I just want to say something. We have to remember that um, we have been challenged, nurses have been challenged across the world in many different levels and in many different situations. And the resiliency and the resilience of nurses were tested, okay, in its, how can I say, highest level of capacity. And the good thing about nurses is that we continue to be strong, we continue to be resilient, we continue to be mindful, we continue to be advocates, we continue to be, how can I say, grateful, okay, because we are in a profession that we are serving others and that we are serving vulnerable people. We are serving the community and we are serving our planet. All right. So to end this presentation, I just would like to mention this quotation. Okay, one of my favorite quotes. You have to remember, all the registered nurses here and the leaders here, you always need to remember that you are the light. Never let anyone, any person, any force dampen or diminish your light. So at the end of the day, all of us, all the registered nurses who are in this group, who are in this presentation, you always carry that light with you. And that light can be making a significant difference to the people around you, being kind to the people around you, how can I say it? Infusing joy to the people around you, spreading gratitude to the people around you. And you always carry that light with you to illuminate that path for others to follow. So always remember to, how can I say it, that to never let any person, any force dampen, dim, or diminish your light, because that light will always be with you and you always have that opportunity and space, significant difference to the world around you. Thank you. I'm done with the presentation. Thank you.
Thank you so much, sir. I just had a technical network issue here, so I had to go and come back. Thank you so much for your presentation, sir, and for taking the time out from a busy schedule. On that note, I would like to welcome the next keynote speaker, Dr. Chong Mei Chan, who currently works as the head of the department and associate professor, gerontology, Department of Nursing Science, University Malaya, Kuala Lumpur, Malaysia. She obtained her BNSC degree in nursing from University of Malaya in 1995 and MS Community Health 2005 from University Putra, Malaysia, and PhD in nursing from the Monash University, Australia 2014. She has been active in the area of gerontology, nursing, maternal and child health, and e-learning for over 20 years and has been a frequent contributor to community on health promotion and social participation activities. Her international experience includes programs and collaborations with Australia, China, and Indonesia. Her current research understanding is of food truck handler perception on food safety and nursing education during COVID-19 pandemic. She is active in nursing education and a frequent speaker in nursing research workshop for Malaysia Nursing Association. She is currently supervising 15 PhD candidates and 2 master research candidates, of which 12 PhD candidates completed and 2 master students have completed as well. She has supervised more than 20 master student project papers. She has published more than 40 articles in peer-reviewed journals, more than 20 articles in Web of Science, ISI listed journals, and 4 nursing books. I welcome for your presentation.
Very good afternoon, and thank you very much, Ms. Pauline, for your kind introduction. I should share my slide. Can you see my slide?
Yes, ma'am. Yes, ma'am.
All right. A long day, yeah, after 2 speakers. Yeah, hopefully everybody is still okay. Right. Very good morning, good afternoon again. Thank you very much for the organizer for inviting me to present in this 6th International Conference on Nursing Science and Healthcare, right, with the title Nurses, the Future of Healthcare. In fact, the earlier speaker, Professor Prashvnath and Dr. Benjamin, yeah, have covered some of the things. Yeah, the future of healthcare is actually very much related. Yeah, very much closely related to the sustainability development. Yeah, so let's move on to my slide. Right, this is my content outline. Yeah, so I will cover the introduction, the changing healthcare landscape, the evolving role of nurses in response to these changes, and nursing leadership and innovation, harnessing technology in nursing practice, and ensuring a sustainable nursing workforce, and with conclusion. Right. I'm sure all you still remember, because this had just over last month, the International Nurses Day, 12 May 2023, actually have come up with the theme, Our Nurses and Our Future. So this topic is very much relevant, yeah, for this morning, yeah, to remind us, yeah, on our nurses and our future, how our future has to be, right? So, and I'm sure this is still deep in your mind. Yeah, all of us still haven't come up from the shocking global emergency of COVID-19 pandemic, right? This pandemic actually means a lot to us. Yeah, we learned a very good lesson from this pandemic, right? So there are a lot of very severe impact, yeah, in terms of life, in terms of morbidity and mortality, right? And we have never suffered this yet globally, and the healthcare system is almost collapsed. Yeah, but however, everything goes well because we have superhero nurses. During the pandemic, more people actually appreciate nurses, yeah, and because nurses are the frontliner, yeah, of this pandemic, and we actually nurses actually sacrifice so much, yeah, for the patient, yeah, and actually neglected their own family and also themselves, right? So I hope these superhero nurses will sustain, yeah, forever, for the future of better healthcare and for the future a better quality of life. Right, we have actually undergoing, yeah, a transition of nursing from the era of Florence Nightingale to the era of COVID-19 pandemic, and not forgetting, yeah, our fight and our transition period will go on, yeah, for the future of the healthcare. Right, how do nurses affect, yeah, the future of healthcare? Wow, don't underestimate, yeah, the ability of nurses. Yeah, we are actually very powerful, yeah, in terms of controlling or monitoring or make the future of healthcare better. Yeah, we must believe we actually have the power to do so. Right. So before we go on with what we are supposed to do, we need to understand, and I'm not going to go through very much on this because the earlier two speakers have actually gone through very much in detail, yeah, as they go along this, right? So the changing healthcare landscape, it actually needs some action from us, yeah. Shifting demographic and increasing healthcare demand. We know aging population, we can't stop, yeah, aging from happening in this world. And aging population actually will create a lot of healthcare demand. I will go through this later. And ethnic and racial composition, in other words, the diversity, yeah, of the population will cause a lot of problem as well in terms of cultural perspective, in terms of sensitivity, right? So, and lifestyle and health behavior is also a very strong determinant, yeah, to determine the healthcare status. Right, let's see what happened, yeah, in the changing, shifting demographic, yeah, increasing healthcare demand. So the first one will be burden of chronic diseases. We know, yeah, what are the chronic diseases that bothering us, yeah, for time being, from those days, for now, and maybe for future. Cardiovascular disease is the number one, yeah, problem that we face. Diabetic, cancer, and respiratory condition are one of the on the rise globally. Yeah, nobody can, no any country can escape from this. This condition require long-term management, not easy, right? Regular medical intervention and increased healthcare resources, right? So when we look at technological advance, yeah, technological advancement in healthcare lead to availability of new diagnosis to treatment and therapies. While this advancement improve healthcare outcome, at the same time, they also increase the demand of specialized healthcare services and resources. Yeah, still we need resources again. And health awareness and expectation. People are more educated now, the public are more educated. So as health awareness and expectations among individuals increase, this is the highest demand for healthcare services, right? Preventive care and early intervention to maintain and improve overall health, right? So, and with this shifting demographic, it is also increased the number of mental health needs. Yeah, this is a growing recognition and understanding of mental health issue, resulting in increased demand on mental health care services and resources to address the condition such as depression, anxiety, and substance abuse, right? So do not underestimate this problem happens just in patient or in the underprivileged population. But yeah, if we are not taking care, we are not concerned about this, it also will affect our healthcare provider, especially nurses. During the COVID pandemic, we see a lot of nurses is actually under tremendous depression, anxiety, and substance abuse may happen as well, right? So public health emergency, as the example that I showed just now, yeah, one of the most emergent public health emergency was our COVID-19 pandemic. Yeah, it significantly increased healthcare demand, including screening tests, right? Treatment, vaccination, and healthcare infrastructure. You see how demanding is this, yeah, shifting demographic affect us, right? So with this, yeah, with aging population, lifestyle factor, environmental factor, genetic predisposition, actually contribute to chronic diseases such as heart disease, cancer, chronic lung disease, stroke, Alzheimer's disease. It is also growing as the older population is growing. Diabetic and chronic kidney disease. This is also another concern, right? So what are we supposed to do, right? With this, are we going to let it go on like that? Or we are doing something to stop this from happening? And as a nurse, are we able to do this, right? So the need for holistic care, holistic care is very important, right? The comprehensive treatment, patient-centered care, prevention care, collaborations and coordination, patient education, and self-management and quality of life. When I go through this subheading, yeah, I'm sure all of you, all the nurses Yeah, especially those nurses are doing their continuing study. Yeah, a lot of people have take all these subtitle as their research title, right? So you as a nurse, you are doing research, yeah, to overcome a problem, to improve the holistic care of the patient. When I talk about comprehensive treatment, holistic care address not only to physical symptom, right? When we say wellness include psychological, yeah, physical, emotional, and social aspect of the person's health. I'm sure all of you still remember that. You recognize that these dimensions are interconnected and influence overall well-being and the management of chronic diseases, right? So we need to give a very comprehensive treatment. As regards to patient-centered care, holistic care places the patients at the center of the healthcare journey. Yeah, we must be focused on individualized care, or we call it a patient-centered care. It emphasizes effective communication. Communication skill is very important in nursing. Share decision-making. We are not giving instruction to patient. We have to share decision with them and consider a patient value, preference, and goals and the treatment plan. We have to plan together with the patient. Gone with the day that, yeah, we are giving instruction to patient, but now we are sharing decision with the patient. Preventive care obviously is very important. We have to move from illness to care for the well-being. Yeah, illness to well-being care. So holistic care emphasize preventive measures such as health screening, lifestyle modification, yeah, live a healthy lifestyle, and early intervention to mitigate the progressions and complications of chronic diseases. It promotes a proactive approach to maintain health and preventing diseases, right? So we also need to collaborate, yeah, collaboration and coordinating care. As a nurse, we need to collaborate with other disciplines, such as physician, right, pharmacy, radiographer, and so many others, yeah, partner, yeah, in the healthcare provision, maybe mental health professional and social worker. We have to work collectively with them. Yeah, so this interdisciplinary approach ensure coordinated care and address the diverse needs of individuals with chronic diseases. And obviously, patient education is the core business for us as a nurse. And with good education, we could empower the patient. And when we empower them, they will be able to carry on with their self-management, right? They could monitor their own condition, their progress of the disease. So this is very important. Yeah. So, and if we could manage, yeah, 1, 2, 3, 4, and 5, obviously we will be, yeah, providing a better quality of life for patients. By considering broader aspect of person health, holistic care aims to enhance the overall quality of life for individuals with chronic disease. It focuses not only managing symptoms, but also promoting well-being and functional ability. We are not just treating symptoms. Yeah, we are going to make the patient more functional and to make them, yeah, have regain their better quality of life, right? So not only that, while doing everything for patient, the nurses also need to take care of themselves very well, right? So let's move on to the next vision, the changing landscape. Also, no, I'm not going to talk very much about this because the earlier speaker have touched on this, and then the subsequent speaker will elaborate more on this. So with all this technology advancement around us, can we resist all this? We can't, right? We have to go on, yeah, together with the advancement of technology. If you are not updating yourself, if you are not bothered about this technology, yeah, you will be outdated and you cannot, yeah, provide a very good quality of care for patients. Yeah, for instance, telemedicine, yeah, health information exchange is very important. Yeah, electronic health record or electronic medical record. I prefer to call it electronic health record because it covers more discipline. In medical record, people might relate it to only clinician. Yeah, nurses are going to use the pharmacy. Everybody need to use this, right? Then artificial intelligence technique, yeah, we cannot escape from this. Yeah, we have to face the ever changings of IT, and we need to learn and be part of them, be part of the progress. And robotic have been evolving now, especially during the COVID-19 pandemic. Yeah, especially in China, they use a lot of robot, yeah, to help in
meeting launch பண்றேன்
meeting launch பண்ணேன்.
okay, by delivery diet to patient, yeah, or by the sending laundry services, okay, and then diagnostic tool is very important in the era of technical advancement. Your diagnostic tool also need to be improved, yeah, and catch up with the latest technology. Right. So with all these landscape changes in the healthcare setting, are we going to sit there and doing nothing? No. As a nurse, you are the main task force of the healthcare system. So you have to do something, yeah, to overcome all this. So the first thing we do, we have been mentioned about this expanded role, expanded scope of practice of nurses. Yeah, well said. Yeah, but we need to have the support. What expanded role that we are going to get involved in? The nurses have seen expansions of their scope of practice, allowing them to take more advanced role and responsibility, right? So with this, you need to have training and education to support you. Yeah, this include performing tasks traditionally carried out by the physician. Whatever some of the tasks, yeah, done by the doctor, the physician, or clinician, the nurses should be able to take over, such as prescribing medication, ordering diagnostic tests, and providing primary care services. Yeah, and one practice nurse, yeah, such as nurse practitioner, midwife, nurse midwife, and clinical nurse specialists have gained increasing autonomy and are playing a crucial role in delivering comprehensive care. Yeah, so nurses should be given autonomy. Of course, autonomy and empowerment should come with knowledge and education. Leadership and care coordination is very important. Yeah, leadership. Nurses are assuming leadership position and playing a vital role in their care coordination, right? So they are involved in developing care plan. Yeah, we plan our care plan. Nobody plan for us. The nurses plan together with the patient, managing interdisciplinary team and coordinating patient care across various healthcare settings. Nurses' expertise in managing complex patient needs, effective communication, and advocacy skill make them essential, contributing to ensuring seamless and patient-centered care delivery. You trust me or not? Yeah. If you don't trust me, you have to trust yourself. Nurses are a very good leader in care coordination. Yeah, we can do a lot of coordination work. Yeah, which other discipline may not be able to do so. Right. And patient education and health promotion is very important. I have mentioned earlier. Right, this is our core business. Yeah, so we need to always be in the forefront of patient education and health promotion, and our role in this area continue to grow. Right, with the increasing focus of preventive care, chronic disease management, and lifestyle modification, nurses play a critical role to educate patients, not doctor. Yeah, not specialist, but we nurses doing all this job, and we are the most important person to conduct health promotion, disease prevention, medication adherence, and self-care strategy. That we nurses are empower. Yeah, we empower patients to take an active role in their own health and well-being. We are good in doing that for patients, right? Because nurses are a very patient group of people who can help the patient, teach the patient patiently, right? Technology proficiency, we cannot run away from the advancement of technology. Yeah, so we need to take the advantage of technology, which I have mentioned earlier, right? So, and patient advocacy and health equity. The two speakers have been talking about have talked so much about health equity, right? I will not repeat here so much. And nurses will have long-standing traditional advocating for their patient right. We always fight for the patient right, fight for the patient safety and the patient well-being. Yeah, in response to even health landscape, nurses are increasingly involved in promoting health equity, addressing health disparity as what mentioned earlier, and advocating for vulnerable populations, and they play a crucial role identifying, addressing social determinants of health and ensuring culturally sensitive care and advocating for equitable access to healthcare services. You can see how important a nurse play a role in advocacy and to improve the health equity, right? So do not underestimate our power, right? So research evidence, so much have been talking this morning. I will go through again. So research and evidence-based practice is a very, very crucial area. Nurses, high time nurses should carry out research, right? And improve, added all this research output into the nursing-based knowledge, and improve the nursing care. Yeah. So, and we also must be good in, I'm sure everybody have heard about evidence-based practice, but how good are you practicing evidence-based practice? God knows, right? We've been talking, but not many nurses actually good in that. So perhaps the nursing leader should encourage the nurses to do so, right? Collaborations and teamwork, obviously, is also very important. As I mentioned earlier, we cannot work in silo. We have to work in collaborations with the other team member in the healthcare setting. Right. So those days we are working closely with doctor, with pharmacy, with radiographer. But now you have to work. There is extra team member that we have to work to. That is IT personnel, right? So the IT people, we need to work closely with them to discuss what we need, what kind of IT solution we need for nursing care, right? So with this in mind, you can see how important and how heavy your role is, how heavy your responsibility is as a nurse, in this ever-changing landscaping of the healthcare, right? So having said nurses have a role, but if you don't have the good nursing leader to lead the nurses, it will not move on. So we need nursing leadership and innovation in improving our nursing care, in improving the nurses' competency and ability to move forward a better healthcare system for the people and for the nation and for the world, right? So nurse-led initiative and research. Gone with the day, nurses are the data collector. Nurses are the research assistant for the doctor. No, now we have to lead the initiative and we lead the research, whereby the research are for nursing care, to improve nursing care and to improve patient outcome, right? So you have to lead the research yourself, right? Now, not just survey, not just a cross-sectional survey. Now, nurses also can go on to RCT research as well. You also do clinical random, clinical control trial, right? So, and as I mentioned earlier, we need to practice evidence-based practice in the nursing care. No, not everybody must carry out research. If you already have very good evidence around, you can make use of the evidence to improve the nursing care, right? So you will be looking for best scientific evidence, and then you also consider the patient value and what is the clinical experience you have encountered, right? Not just taking up any information from the journal and then you use it. You must evaluate and appraise the article content and see whether this is suitable for us to use or not, taking in consideration the patient value and the clinical experience, right? So what other thing the nurse leader have to do? Quality improvement and patient safety. This has mentioned by the previous two speakers as well, right? Quality improvement and patient safety, obviously, the nurses can do the best job compared to other category of healthcare provider. You need to set some indicator, and then you need to have a goal, right? So when you have the goal indicator, you need to measure whether you have achieved the safety measure goal or not. But two most important example for patient safety will be what? User guess whether you run the wild gas or not. So the most prominent one will be risk of fall. We used to have risk of fall guideline for adult. Now people are moving to risk of fall for pediatric as well, right? So risk of fall is a very important indicator. If you continuously have patient fall in your ward every day, then you can close the ward can close down already. You're no more safe to manage that ward, right? So it's very important. And the other one will be pressure injury, right? We do not want to see patient come into the ward without pressure sore, but discharge with pressure sore. That is a very, very bad indicator. Yeah, you can buy 1 free 2 for any shopping, but not for patient. Yeah, right. So then nursing leadership and innovation also include addressing healthcare disparity through nursing leadership. Yeah, we have to advocate. Yeah, be the advocacy for the vulnerable population. Yeah, nursing leader have the opportunity to advocate. Yeah, we have the opportunity to do this for vulnerable population, include racial and ethnic minority. Yeah, we have to protect the minority group. Yeah, low income individual and immigrant. Okay, so and those living in underserved area is our priority to help them. Yeah, so they can raise awareness. Yeah, nurses can raise awareness about healthcare disparity, promote policy, yeah, to the government, to the Ministry of Health that address social determinant of the health and advocate for equitable resources allocation and access the healthcare services for this population. Yeah, we have this problem as what mentioned by the earlier two speaker. Yeah, so we really need to maximize resources, right? And then cultural competence and patient-centered care. Yeah, so nursing leader can promote cultural competence within the healthcare organization. Yeah, they can encourage education and training program that increase awareness and understanding of the diverse cultural background. So far, nurses will go for a lot of one diploma course to enhance their skill as a midwife, to enhance their skill as a critical care nurse, but we hardly hear any courses to do with cultural diverse. I'm not too sure the other in India or Indonesia, but in Malaysia, we hardly have this cultural diverse course for nurses. I think high time we should think about this, yeah, to have more curriculum, yeah, which is very inclusive with culture, as what Dr. Benjamin have also touched on this just now. Yeah, I'm not going to go through this again. So this is very important. We have to alert the nurses. Right, they have to be very sensitive, especially like in Malaysia, we have different cultural race and we have a very rich culture in Malaysia. So nurses have to understand all this culture, right, to help reduce healthcare disparity related to cultural and linguistic barrier as well, right? So developing cultural diverse and competency in nursing workforce is very important also, right? We need to recruit nurses from different cultural perspective so that they can understand the patient better, right? Of course, it's not easy, but we need to try on this. Just like in Saudi also, they have different cultural perspective nurses there, right? So and like in UK also, even though they are not like multicultural, multiracial, multicultural in Malaysia, but they have a lot of immigrants from different countries. So that the nurses also, I guess, they also have different nurses from different cultural perspective, which is very, very important, yeah, especially to overcome the marginalized population. Again, health education and community outreach is very important. Yeah, nurses leader can initiate and support health education program and community outreach effort, yeah, aimed at undeserved population. They can collaborate with community like NGO, right, school or local healthcare provider and provide health screening, preventive care, health promotion initiative, and education on disease management. Right, this effort help to bridge the gap in healthcare access and empower individuals to take control over their health. We have to empower the community. How to empower? We have to teach them. Yeah, had to teach them, had to provide knowledge to them, and had to train. Yeah, teach them the skill, train them, so they can take care of themselves. Right. So quality improvement and data-driven decision making, right? So nurse leader can lead quality improvement initiative that focus on reducing healthcare disparity. They can help to analyze data to identify disparity in healthcare outcome, access, and utilization, and work towards implementing evidence-based practice, as I mentioned earlier. that address this disparity, right? So the nurse leader role is very, very crucial. Yeah. They also serve as a role model to the young nurses, yeah, in terms of overcome the disparity. Right. So having said that, we have a very good nurse. We have a very visionary and missionary nurse leader who can lead the nurse. Yeah. We cannot run away from technology. Yeah, I have mentioned. Yeah, technology is also a change in landscape in healthcare system. So nursing, yeah, have to work, yeah, to welcome this new technology in our career, right? So in terms of technology, initially I mentioned in the other slide, I say EMR. That's why I prefer, yeah, electronic health record, which inclusive nursing and other discipline as well. So in terms of nursing, we need to integrate, yeah, our nursing process in the EHR. Whatever we record, we used to record in the paper, right? We have to transfer all this paper information into the system, right? So you as a nurse, you only know what you want from the record. That's why you have to provide information to the IT personnel to integrate whatever you need to use for the patient care. Right? So we do not want other people to decide, not the doctor decide for us, not the director or hospital decide for us what is in the EHR. We are the one who use it. Then you have to contribute, yeah, to whatever information you need to put there. And then you have to monitor as a nurse. Right? So another one is clinical decision support system. Whereby, yeah, the patient data will be integrated with the medical knowledge. I will add here nursing knowledge as well. Yeah, and then inference engine, they will analyze, yeah, analyze all this data, both data, and then come up with a specific advice to patient, right? So, and this have been some of the hospital has used the clinical decision support system to monitor deteriorations of the patient, yeah, especially in critical care. Yeah, where patient symptom, yeah, sign and symptom, and all these vital signs may drop quickly, yeah, may drop suddenly. So it would be good to have a system to actually monitor this, yeah, other than just relying on the nurses' observation, right? And telemedicine, or we call it tele-nursing now. Yeah, when we say tele-nursing, doesn't mean that you must have all these gadgets. Yeah, you can start small by using just a WhatsApp group, yeah, to disseminate knowledge to patients. It's also considered as tele-nursing, right? To create a social media to share with patient, it's also considered tele-nursing. And then you can provide health education through upload some information in the maybe in WhatsApp or WeChat. Yeah, different countries have different have their own preference on using all these social media. Some places they use in Instagram or Telegram or whatnot. Some use Twitter. There are so many social media that you can fully make use of all these social media to help, yeah, help you to ease your nursing care to patient, right? And sometimes all these social media can reach a patient very fast, right? Other than you send email, it will take a long time. Some people don't even look at email for a few days, right? So with this harnessing technology in nursing practice, you also can learn more about maybe most of it not very well with this predictive analytic, yeah. So this artificial intelligence, they will capture a lot of data, and people are talking about big data, right? So all these data can be analyzed, yeah, and become a predictive, yeah, predictive to future treatment for the patient, right? So all this look very complicated, yeah. So high time the nursing, as what Dr. Benjamin say, yeah, we have to look into our nursing curriculum, yeah, based on all these advancement. We have to integrate all these, yeah, so that the nurses will understand better, right? So many of us, we are exposed to all these ICT, but we don't know what the background behind. So that's why you will not appreciate it very much, even though you are the end user. Yeah, you need to understand what are the background, yeah, that support all this information, then you will appreciate it better. right? So medication management system, in my hospital, we have started this barcode system, yeah, using electronic prescribed and medication administration record system help nurses verify and administer medication accurately, minimize risk of medication error, which is very good, yeah. But obviously, yeah, nurses have to send for training before they can use this system, right? And this system, yeah, medication system also will allow automate alert and reminder further supporting adherence to medication schedule and reduce adverse drug event. And then there are so many people have actually coming up with prototype, yeah, when they carry out research on mobile app. Now a lot of people have been talking about mobile app, and then a lot of PhD students actually when they are planning for their research project, they are looking at mobile app as well. Yeah, so mobile app it is not just for us to disseminate sharing knowledge with patient, but mobile app also can act as a tool to monitor the patient, right? And then to look at the patient progress. Yeah, so we cannot run away from this reality. You have to, because I guess most of the people, especially I think all nurses here who are attending this conference, you will have a mobile, right? If you don't have a mobile, you can't access this link already. Okay, so take advantage of the mobile phone. Yeah, so most of the patient have this. Gone with the day, you want to give patient hard copy information, like giving leaflet and all that, or pamphlet, right? Trust me, yeah, they will just hold their pamphlet until the door, yeah, the exit door of the hospital. After that, they will throw in the dustbin. Yeah, so nobody like to read hard copy. Yeah, maybe mobile is more user friendly, right? Right. So, and I don't have to talk very much on this. The wearable devices, I guess some of you also have this what you call smart watches. Yeah, smart watch. Yeah, where you can check your BP. You can look at one day how many steps you have. Now become very obsessive already. Every now and then you want to check your smartwatch, how many steps I'm walking. Even the mobile phone. I have become addicted with that kind of behavior, right? How to say how many steps I'm moving. Actually, it's good, yeah. And some app there, you can compare with your friend, see who is the champion of the day. Then you will keep moving, right? So in a way, it encourages people to exercise, yeah, by walking, and then you can check your blood pressure, you can check your pulse rate, yeah. Now some even can check temperature, and even more, you can even check your oxygen saturation. Right? Maybe you're working in the ward for too tired, you check your oxygen saturation. So suddenly your oxygen saturation drop to 80, then you tell your nurse manager, you can go home early, right? Just a joke, yeah. It shouldn't be like that, right? Okay. So, and robotic and automation, yeah. So in future, if you are very short on nurses, yeah, maybe we can invest in robotic, yeah, to check patient, monitor patient vital sign, right? So of course, it will be very costly to start anything, yeah, in terms of ICT, yeah, it's costly, but if everything goes well, I think using ICT to monitor vital sign, it can be more accurate, yeah, than human, yeah, because human tends to have a lot of variation, yeah. You might have some other things to affect the reading and all that. Okay, so perhaps using technology, you can get a better, more accurate result. Yeah. So obviously, nobody born unless the later generation, all the young nurses, they are very good in all these gadgets. Anything new came out, TikTok came out, they know how to use. They know how to do video and all that, right? Not like baby blooming. Maybe I'm one of them. Baby blooming, it take effort to learn something, right? But of course, education and training very important. You are using a lot of ICT. You must know what are the ethics of ICT, and then what are the fundamental of all these ICT technology. Yeah, it's good to do that, right? So and what are the I will not say complication, side effect kind of thing, So, but if you are using it just for your work, then okay, but not hanging on too long, it will have a lot of problem. It may be ergonomic problem or whatnot, right? So education and training is very important, and education can make easy. Later, the subsequent lecturer, subsequent speaker will also talk about education. I'm not going to touch very much on this. So education can make easy, because you don't have to leave your workplace. You can work and at the same time study, online, right? So, right, having said that, you identify the landscape changing, you need to do something, and then the nurses have their role to play, and then how to make the nurses role goes better. You have a good leadership to guide them, and then you are good in ICT, so you have all this with you already, right? Then how are you going to ensure sustainable nursing workforce? So you need to address the nursing shortage. This is nothing new. I'm not going to explain very much on this. Everywhere face shortage of nursing workforce, right? And maybe migration of nurses to a better country, which they can get higher pay, then they will move on, right? So, and promoting education and professional development opportunity is very important, right? When you are providing opportunity for nurses to go further study, they are happier, they are more satisfied, then they are more willing to stay in the hospital. And by sending them for professional development opportunity, then you will upgrade their knowledge. Then you can empower your nurses to do better care and improve the patient quality of life. And obviously, if they are very happy, they are very satisfied, they have work satisfaction, then the tendency they will retain, they will stay in the hospital, right? And creating positive work environment, then everybody happy and stay back. When all the nurses happy, who will happy then? The patient also will be very happy. The patient carer also happy. The family member also will be happy, right? So why not? We create such environment, and we must recognize the value of nursing and advocating for the profession. And I mentioned earlier, right? We are nurse. You must accept, even though we are nurse, we are professional nurse, we are just a normal human being like others. We do have emotion. We do feel sick. We do have anxiety. We also can face depression if nobody cares for us, right? So as a nurse, we have to care for each other. We must love each other, right? So that we can move on, we can sustain the nursing workforce, right? So other people can bully us, other people can make us strength, but not among us. Among us, we must help each other. You have to identify if your friend is not feeling good, if your friend have signs and symptoms of anxiety or depression, you have to help them. And then the nurse leader must be able to capture all these signs and symptoms among your staff. And then in the hospital, there must be a system or a unit to provide counseling for the nurses, right? This is very important. This happened. All this happened especially during the COVID pandemic. So many nurses is actually under huge depression, very severe depression. From there, then only we realize nurses do face stress, nurses do face anxiety. It is okay to feel unwell. So if you think you are not well, you should talk to your friend. You should look forward to get help. Not suffering silently. Right. I hope this message can reach you very well, and I hope the best for all the nurses. And we hope we have a very healthy nurses and very sound nurses in terms of technology, in terms of competence, in terms of value, right? Then we will be able to make the future of healthcare system a better world, and build up a better quality of life for patients. With that, thank you very much.
Thank you so much, ma'am, for your presentation. On that note, I would like to welcome our next keynote speaker, Dr. Vimla Ramani. She's a senior lecturer in the Department of Nursing Science, University Malaya School of Medicine, Kuala Lumpur, Malaysia. She received her Bachelor of Nursing Sciences, Master of Education, Planning and Management, and PhD in Nursing from University Malaya. She has over 25 years of teaching and supervision experience in nursing education. Kindly make sure you're on mute. All the participants, just keep an eye on that. Thank you. She holds the position of research coordinator in her department and is involved in the supervision and examination of postgraduate research students, as well as being actively involved in clinical research. She has received several awards for excellence in her performance. She has contributed to curriculum development for diploma, advanced diploma, bachelor, and master degree programs. Her specialization and research interests include critical care, nursing leadership and management, and nursing education. She serves as an external examiner and assessor at various universities. She has several publications in international health and nursing journals. She is also a member of the editorial board and reviewer for international nursing journals. She was also as adjunct professor at Universitas Erlangga, Indonesia. Ma'am, I welcome you for your keynote presentation.
Hi, thank you. Let me share the screen, yeah?
Yes, please.
Yeah.
Are you able to share the screen, ma'am?
Yeah, I'm trying. Just hold on.
Okay.
Yeah?
Oh, sure, no problem.
I don't know why I couldn't share the screen.
Do you see the option, ma'am, that says share screen?
I couldn't go to my desktop. I don't know why.
Okay. Probably on full screen on Zoom. Maybe you can try to hit the escape button.
लोग एक सारी बुआएं थी, दोनों दादियां।
Hello, hello.
Ma'am, am I audible, ma'am? We are able to see the screen that says that you have started screen sharing.
घर का कर्म क्यों?
I'm sorry, I'm still trying, but something happened to
Sure,
me.
okay. Okay.
I tried another computer, so it's jammed.
Okay, okay, ma'am.
It shows that someone is sharing.
Okay, ma'am. I'll just look into that. Ma'am, is it possible that probably your other account is still on? Because for me it just says Vimala Ramu has started the screen sharing. So in the other devices, probably you're still on. Maybe that's the reason it's showing that.
Just let me try and see. Yeah, it shows someone is sharing, yeah. The other device is jammed. I cannot do anything.
Oh, okay. So I think that's the device that says the screen is still sharing. Just give me 1 minute, ma'am.
Can you reject the sharing one?
Yes, ma'am. Yes, ma'am. I can do that.
You reject that one?
Yes, ma'am.
Yeah.
Yes, ma'am. It has been done, ma'am. The
Okay.
screen sharing option has been removed.
साइन इन करना ही पड़ेगा ना.
3 एवरेज को अटकाओगी तो पर स्पीड में भी हैंग होगी कि ये?
Ma'am, are you able to share the screen now? We've stopped it on the other device.
I still cannot. I don't know what's wrong. When I click the share, I cannot go to the screen. This screen appears. The unwanted screen appears.
Ma'am, I have given you the co-host access, ma'am.
Can give a 10 minutes break, then we start back.
No,
Is it
ma'am. I'm just trying to mute the person who's having their mic unmute for no reason. Yes, ma'am. So I'm giving you the co-host access, ma'am. It should be easier for you now, probably.
Doing what?
I've given you the co-host access, ma'am, for the Zoom meeting. So you may be able to share the screen a little bit easier. Can you try? You can try and see if this works.
Just give me 1 minute.
Sure, ma'am. Sure, ma'am.
My the other computer jammed, so I cannot do anything.
आएगा
Would it be okay if I just give you some time to sort this out when we finish the other keynote and come back so that you won't have any pressure to, rush through this? Would that be better? Vimla ma'am, are you there?
Yeah, I'm trying, but I still cannot. I don't know what's wrong.
Okay,
But just give me a minute. I try to share the slide with you.
Okay. Or if you need like a bit more time, we can finish the other presentation and come back so that we can have your
Yeah,
proper
can.
presentation.
What
You
time
do
should
that?
I come back? Yeah, what time I should?
Like in 20-30 minutes, ma'am? We
Ah,
just have
can,
like
sure. I'll come back
Okay.
this time.
Yes, ma'am. By the time you will have time to figure out
Yes,
the
yes, sure.
Yes. Okay. Wonderful. Yeah. Thank you, ma'am. Okay. Thank you to all the participants for your patience. We are going to the next keynote session. I welcome Dr. Patriot Haryu, TMD, who's currently a chairman, quality improvement and patient safety, Charisma Hospital, West Java, Indonesia. He has completed his undergraduate medical doctor at General Ahmad Yani University and also pursued Master of Hospital and Administration at University of Indonesia. His previous experiences, he has worked as a medical service manager at Karisma Hospital, a medical doctor at Hermina Hospital, and medical doctor at Sikalong Vedan Regional Public Hospital. He has published many papers in international Scopus Index and PubMed journals, and he has also presented papers and been a keynote speaker for various national and international medical and nursing conferences. Sir, I welcome you for your presentation.
Okay, thank you, Ms. Pauline, for introducing me. I hope Ms. Vimola can clear the technical error so she can come back into this speaker. Okay, first of all, I would like to thank to all of the committee in here, especially Ms. Susmita and Mr. Kartik Raja that invited me as a speaker from Indonesia. Please allow me to share screen, Miss. Can you see my PowerPoint?
Yes, sir, we're able to see the PowerPoint.
Okay, thank you. Okay. I would like to bring to session. The first is health information technology, and the second one is health communication. I know the time is not quite long, so I will make it fast, and I hope all of the audience can take the benefit from my presentation. Greetings from Indonesia for all the audience, and especially for first, I would like to talk about the role of artificial intelligence in health service. Artificial intelligence applied to medicine is expected to have a significant impact on clinical practice. Healthcare companies and academic groups around the world have recognized and studied the potential of AI technology to improve healthcare, and research firms are now racing to produce a growing number of AI systems, or even to replace doctors. For example, in the health sector, there has been a surge in investment and interest in applying AI to analyze medical photos, amounting to $152 million in 2017, and an increase from 80 million in 2016. I know all of the health information technology is a lot. There is a electronic medical record, electronic health record, and then telemedicine, but I want to narrow it into an AI because it's still hot in public. An AI in medicine can be divided into two subtypes, visual and physical. Virtual AI includes applications such as electronic medical records and neural network-based technologies that serve as guides for treatment decisions. Virtual AI involves robots assisting in surgical procedures, smart prosthetic for individuals with disabilities, and elderly care. It is unlikely that the application of AI will completely replace doctors. However, it is very likely that the application of AI will acquire multiple roles and generate new tasks in medical care. Moreover, it seems inevitable that artificial intelligence models for diagnostic and recommended will eventually reach a point where they outperform doctors. Just as antibiotics are replacing some drugs to treat infections, the superior performance of these models will force them to adopt AI system too. The speed of technological development in the world of health is increasingly evident. The potential for AI to contribute in supporting the diagnostic process to replace the role of doctors is getting bigger. Not only that, AI also has the opportunity to provide an easy-to-access experience, such as electronic medical records, providing drug recommendations as a warning for the safety of falling patients, and so on. The following discussions covers the challenges of implementing AI, perceptions of AI from the view of doctors and patients, the potentials of AI in the development of the world of health, both the benefit and risk that will be generated. It will be, first, is AI a good investment or not? 2, friend or threat? 3, is there any hesitation for all the healthcare providers to use AI? 4, the spirit of youngsters that still open their mind into a new technology and still exciting to welcoming more and more about the technology. And 5, is it improving patient safety in hospital? Okay. Is AI a good investment or not? In the integration of artificial intelligence in the field of health services, there are several important considerations that need to be considered. First, the level of necessity and added value that AI can provide. 2, workplace readiness in adopting and using AI technology. 3, stakeholder acceptance and engagement regarding the use of AI. 4, alignment between AI technology and existing business plans and organizations. 5th, the financing and investment required to implement AI. 6, address the complexities of AI and understand the challenges that arise in its implementation in healthcare organizations and systems. Is it friend or threat? In this study, a doctor's perceptions and sentiments towards AI-assisted diagnosis are discussed. The current form of AI assistance may not be directly related to efficient decision making, as AI algorithms do not align with subjects' human reasoning in clinical diagnosis. From the study suggests that the recommended diagnosis should still be under the supervision of doctors, as advanced as the technology may be with its specialized algorithm, the touch of a doctor still determines the final outcome. Developers and policymakers in the healthcare field can gather behavioral data from doctors across various disciplines to help align AI algorithms with the unique subjective reasoning patterns used by humans in clinical diagnosing, ultimately leading to more accurate results. The third is hesitation. The study conducted by Richardson J. explains that the patients still have many concerns, including concerns about AI safety, threats or patient choices, potential increase in healthcare costs, that source bias, and data security. This is normal as the technology is still relatively new and its implementation is not yet comprehensive. Whereas decisions made by doctors involve various factors, it is crucial for the development of ethical innovation and ensuring the long-term success of AI implementation in healthcare. Spirit of youngsters. While there are still debates surrounding AI, a study conducted by Tang Mem explains that there is significant acceptance of AI among medical students for the young generation. Although they have concern about potential threat to their future careers, they are willing to support AI if its goal is to achieve more effective and efficient healthcare services. So they will make AI as a partner in this industry. They also express the hope that discussions on AI technology will be included in their curriculum to keep them informed. The last thing is improving patient safety. AI can play a crucial role as a tool to enhance patient safety protocols. There is a significant opportunity to leverage AI and new sources of data to reduce the frequency of hazards. By improving patient safety measures with more accuracy, the potential for incidents can be reduced, and even potential risks can be identified beforehand, enabling precise preventive actions. The rapid pace of technological advancements necessitates healthcare providers to keep us with the latest information to avoid falling behind. So, how is the conclusion? AI plays a significant role in the advancements of technology in the healthcare field. Sooner or later, the full potential of AI will have a positive impact, driven by aggressive improvement and support from stakeholders and practitioners. The effectiveness and efficiency levels, including human resources, healthcare costs, and the convenience for healthcare professionals, particularly doctors, will create more extensive opportunity for AI technology to contribute in the healthcare world. Ultimately, research and development in AI technology and the exploration of its potential role in healthcare are still crucial for enriching knowledge and information. This is for the information about AI, and I took this from my own journal that published on April 2023. I hope all of you can get the benefit from my presentation about AI. So I will go to the next theme about communication. I know maybe almost of the audience in this virtual meeting is a nurse. We are partner. All of the healthcare provider is a partner. Without nurses, without doctors, without radiographer and others, there is no healthcare that will give a good service quality. What is the service quality? The first thing that I think it will be important for us, for all this industry, is communication. Communication in health that needs an empathy, responsiveness, and reliability. As healthcare professionals, we understand the importance of delivering high-quality care to our patients. However, one crucial aspect that we often overlook is the impact of linguistic diversity on healthcare. In a culturally diverse country like Indonesia, my country, where numerous languages and dialects are spoken, it becomes essential for us to recognize and address the linguistic differences that exist. Today, we will explore how these variations in language and communication style can significantly influence patient care and the overall quality of healthcare services. There is a lot of theory about communication that I know all of you will maybe more knowable than me. So I would like to sharing about my country. I want to sharing about the hardest of language in our country, because we have 700 languages in our country. So the communication will be so important for us to communicate with the patients. Here is the country, Indonesia. There are 700 languages and about 17,000 islands in this country. In Indonesia, we encounter a rich tapestry of languages and communication styles due to its diverse cultural heritage and regional differences. With over 700 languages spoken across the archipelago, including Bahasa Indonesia as the national language, it is crucial for healthcare professionals to acknowledge and accommodate this linguistic diversity. The use of different language and dialects by patients and their families can pose challenges in delivering effective healthcare services. Language barriers can hinder effective communication between healthcare providers and patients, leading to misunderstanding, misinterpretation, and potentially compromising the quality of care. Additionally, variations in communication style, such as tone, nonverbal cues, and cultural nuances, can further impact the patient-provider relationship and the delivery of patient-centered care. I would like to give an example for all the audience. For example, eat. It means makan in my bahasa Indonesia, but in English, it, right? Okay. But in Sundanese, the name of it is called tuang for the soft word, and they can say dahar with the same meaning for it, but it's more rougher. And if someone in Sundanese say dahar, it will looks like, oh, he's not polite when they talk to others. But dahar in Javanese is the soft version for it. So When people from Japanese come to Sundanese and say dahar, it will sound rough for Sundanese people. And there's a lot other languages that has the same meaning, but there is a soft style and rough style. That's the hardest part of the language in our country. To ensure high quality healthcare services, it is important to healthcare professionals to address the linguistic diversity and adapt their communication strategy accordingly. This includes employing languages interpreters or translator, providing multilingual healthcare materials, and etc. By recognizing and respecting the diverse languages and communications need of our patient, we need to respect all of the language that came into our healthcare industry, our healthcare provider, our hospital, and others. We can bridge the gap and ensure that healthcare services are accessible, effective, and tailored to each individual needs. In the context of serve-qual dimension, namely empathy, responsiveness, and reliability, acknowledging and accommodating linguistic diversity plays a vital role. Empathy involves understanding and relating to the emotional and cultural backgrounds of patients, which include recognize their language preferences. How about responsiveness? Responsiveness requires timely and appropriate communication, considering the linguistic differences and ensuring that patients' concerns are effectively addressed. Reliability encompasses consistency in providing accurate and reliable information, taking into account linguistic variation and ensuring clear communication channels. By embracing addressing the linguistic diversity in our healthcare practices, we can enhance patient satisfaction, improve health outcomes, and foster a more inclusive and patient-centered healthcare system. Let's explore strategies and best practices to effectively navigate the challenges posed by linguistic diversity and provide equitable and high-quality healthcare services to all individuals in our diversity society. What's the impact? The impact of language diversity on healthcare cannot be underestimated. It directly affects the delivery of healthcare services and the overall quality of care provided to patients. Language barriers can lead to various challenges, including miscommunication, misunderstanding, and reduced patient engagement. Firstly, language barriers can hinder accurate medical history takings and symptom description. When patients are unable to effectively communicate their symptoms or provide a complete medical history due to language limitation, it can impede the diagnostic process and potentially result in error or delays in treatments. Secondly, language diversity can hinder the provision of patient education and informed decision-making. Effective communication is crucial in explaining medical conditions, treatment options, and potential risks to patients. When language barriers exist, patients may struggle to understand vital healthcare information, leading to a lack of information consent and reduced patient autonomy. Moreover, language differences can impact the establishment of trust and rapport between healthcare providers and patients. Effective communication and building a strong patient-provider relationship rely on mutual understanding and empathy. When language barrier exists, patients may feel marginalized, misunderstood, or excluded, leading to decreased patient satisfaction and engagement. So what is the strategy for enhancing language diversity in healthcare? To address the challenges posed by language diversity in healthcare settings, it is crucial to implement effective strategies that promote inclusivity and improve communication with patients from diverse linguistic backgrounds. Here are some key strategies for enhancing language diversity in healthcare. First, language interpretation services. Healthcare organizations should invest in professional language interpretation services to facilitate communication between healthcare providers and patients who speak different languages, especially for the country that have a lot of nationality, such as maybe America, Indonesia, or Europe, and other countries. Trained interpreters can ensure accurate and culturally sensitive communication, allowing patients to express their concern and healthcare providers to understand their needs effectively. Multilingual staff. Hiring healthcare professionals who are proficient in multiple languages can greatly enhance language diversity in healthcare settings. Having staff members who can communicate directly with patients in their preferred language builds trust and improves the quality of interactions, leading to better patient outcomes. 3. Cultural competency training. Healthcare professionals should receive cultural competencies training to develop an understanding and appreciation for different cultural norms, beliefs, and practices. This training helps healthcare providers navigate cultural differences, avoid misunderstanding, and deliver cultural appropriate care. By implementing these strategies, healthcare organizations can create an environment that embraces language diversity, promotes effective communication, and enhance the overall quality of healthcare services. Ensuring language access not only improve patient satisfaction, but also contribute to better health outcomes and patient safety. And for the good communication to all the healthcare provider, we need to have an empathy in ourselves when we treat the patients whenever they come to us. Because if we don't put the empathy for them, we will not give the best treatment for them, and they will not receive the best treatment for them. And it will be a hardest part, especially for the patient. Now I want to share something, some videos. Maybe you all can find it too on YouTube, so you can access it too later. I want to show that when we meet a patient in hospital, or when we meet friends, partner in our works, they have all their own problems. They have on their own problems for daily, weekly, monthly, or even they will, or maybe they can depress too. So we need to respect others, give an empathy. So we hope we can reach a great potential of healthcare outcomes. After this, I want to play the video. It's about 4 minutes. And shout out to Cleveland Clinic that I took the video from YouTube. This is the slogan from my university in University of General Ahmad Yani. Treat patients as we would like to be treated. Thank you, and please enjoy the video. Wait. I'm sorry, is the sound is out?
Yes, sir, you can hear it with the audio.
Okay.
Yeah.
Okay, that's the video, and this my end of presentation. Thank you.
Thank you so much, sir, for the wonderful presentation. And the video was certainly very, very heartwarming. Thank you so much, sir. And I would like to welcome again Dr. Vimla ma'am to see if the presentation can go on. Is the issue sorted out?
Thank you. I'll try now.
It's visible.
It's working now. Thank you.
Yes.
So sorry for the earlier technical error.
No, it's
I think
okay,
my
ma'am.
computer, my computer got heat up, I think. I on it from the
Ah.
beginning. Yeah. Okay. Okay. Okay, good afternoon, ladies and gentlemen. Thank you for the opportunity to share my presentation in this conference. Yeah. Okay, my title will be Transforming Nursing Education to Meet the Future in Nursing. I think this title sounds very familiar with the first few the presentations earlier. Okay, if you see my theme, also almost the same. Okay, I also started on a Nurses Day's theme, which is Our Nurse, Our Future. Okay, this is to rephrase the Nurses Day's celebration the other day, which focuses on our nurses, our future. This phrase emphasizes the importance of investing in nursing profession for the benefit for our future health system. Nurses play a vital role in healthcare delivery, and their contributions are critical to achieving the best possible health outcomes for patients. In addition, the theme is also a global campaign that sets out what and how nursing in the future should address global health challenges and move global health for everyone. If you see what is global health is about ensuring health future for everyone, no matter where we live. It refers to the area of study, practice, promotion of health and well-being on a global scale. It places priority on improving health outcomes and address health challenges that transcend national boundaries. Global health focuses on the health of populations and communities worldwide, with a particular emphasis on addressing health disparities, promoting equity, and addressing the social and economic and also the environmental determinants of health. If you see what are the elements in the global health, there are a few key aspects about global health, which includes health equity. Global health aims to achieve health equity, which means ensuring all individuals, regardless of their geographic location, socio-economic status, or other social determinants of health, have equal opportunity to attain good health and well-being. It focuses on reducing the health disparities and promoting equitable access to healthcare and essential health services. The second component is transnational health issues. Global health, we could recognize that health challenges and disease does not respect national boundaries. Involves addressing transnational health pandemics. We've seen the COVID-19, yeah, how it spreads from one to another country without any. So the non-communicable disease, okay, as what the earlier presented mentioned, okay.
1 second.
Environmental health risk, social determinants of health, which includes poverty, education, and gender equality. Another aspect is multidisciplinary approach. Global health requires a multidisciplinary approach involving collaboration among various sectors, including healthcare professionals, public health experts, policymakers, researchers, social scientists, economists, and community leaders. It recognized the interconnection between health and other sectors, such as education, environment, government, social economy, and development. Global health efforts often involve strengthening the health systems in resource-limited settings to ensure the delivery of quality healthcare service. This includes improving infrastructure, workforce capacity, healthcare financing, access to essential medicines, and health information systems. Another component is internal cooperation. Global health relies on the international cooperation and partnership among governments, non-governmental organizations, academic institutions, and other stakeholders. It involves sharing knowledge, expertise, and resources to address global health challenges collaboratively. Organizations such as WHO, United Nations agencies, and Global Health Initiative play a crucial role in coordinating and facilitating global health efforts. The last component is research and evidence-based practice. Global health emphasizes the importance of research and evidence-based practice to inform decision-making and intervention. It involves conducting research on global health issues, evaluating interventions, and translating evidence into policies and programs that can effectively improve health outcomes. Global health recognizes that health is influenced by factors beyond individual behaviors and healthcare services. It considers the social, economic, political, environmental determinants of health, aiming to address the root causes and systemic factors that impacts health and well-being on a global scale. The goal of global health is to achieve sustainable improvement in health outcomes and promote health equity for all people worldwide. However, global health faces numerous challenges that requires attention and collaborative efforts to address. Some of the key global challenges include infectious disease, non-communicable disease, mental health, health equities, antimicrobial resistance, maternal and child health, climate change and environmental health, and also the health system restraining, whereby we have problems like shortage of staff, infrastructure, financial, and many others. Okay, so some of these issues are already been discussed in earlier presentations, so I won't be touching in details. A profession such as nursing, with the millions of providers worldwide, has the opportunity to positively impact these global health challenges. However, a big question to ask: have we prepared nurses for the roles in global health? How do we match nursing roles and competency to face the global health challenges? As the healthcare landscape evolves and the global health challenges persist, the preparation and development of future nurses become increasingly important. Some of the key qualities required for our future nurses are: they should be adaptable and lifelong learners. Future nurses need to embrace a mindset of continuous learning and adaptability. They should be open to acquiring new knowledge, skills, and competency throughout their careers to keep pace with the advancement in healthcare, evolving health needs, and also emerging global health challenges. They should be culturally competent and globally minded. In an increasingly interconnected world, future nurses must value and respect cultural diversity. They should develop cultural competency, which involves understanding and appreciates the beliefs, values, and practice of individuals from different cultural backgrounds. Having a global perspective allows nurses to work effectively in diverse health settings and contribute to global health initiative. As I mentioned earlier by the earlier presenter, Nurses now works in a global setting and with the racial populations and also nurses. So they have to have an open cultural practice, okay, which they are open to other practices, and they be able to nurse and mix around with other nurses and colleagues from other countries, other cultural backgrounds. Okay, so therefore they need this cultural competency. They also need technological proficiency. Technology plays a crucial role in the healthcare delivery and global health efforts. Future nurses should be comfortable and proficient in utilizing various digital tools, electronic health records, telemedicines, and other technologies that enhance patient care, data management, and communications. They should be a strong advocates for health equity. Future nurses should be strong advocates for health equity, social justice, and the reduction of health disparities. They should actively address systemic barriers that hinder access to quality healthcare, work towards eliminating health inequalities, and promote equitable health policies and practices. They should be a collaborative team players. Healthcare is a team effort, and future nurses must excel in collaboration and interprofessional teamwork. They should have a strong communication skills and the ability to work effectively with other healthcare professionals, patients, families, and the communities to deliver patient-centered care and address complex health challenges. They also should be resilient and compassionate caregivers. Nursing is a demanding profession that requires resilience, compassion, and empathy. Future nurses should be equipped with emotional intelligence skills to provide holistic care to patients and their families, considering not only their physical needs, but also their emotional, psychological, and social well-being. On top of it, future nurses also should be critical thinkers and problem solvers. Global health challenges are often complex and multidimensional. Future nurses should possess strong critical thinking skills and the ability to analyze information, make sound judgments, and develop innovative solutions to address these challenges. They should be able to integrate evidence-based practice, research findings, and ethical consideration into their decision-making processes. Lastly, future nurses also should be a leader and change agents. Future nurses have the potential to be leaders and change agents in the healthcare. They should be empowered to influence healthcare policies, advocate for patients and communities, and lead initiatives that promote sustainable development, improve health outcomes, and shape the future of nursing practice. By nurturing and empowering our future nurses with these qualities, we can ensure that they are well prepared to tackle global health challenges, contribute to sustainable development, and provide high-quality, patient-centered care in a rapidly changing healthcare landscape. Our future nurses refers to the upcoming generation of nursing professionals who will play a crucial role in shaping the future of the healthcare. As the healthcare landscape evolves and also healthcare challenges persist, the preparation and development of future nurses become increasingly important. Nursing education must be transformed to meet the global health challenges and contribute to sustainable development. Therefore, the nursing education should focus on educational development and access. All nurses should be given the opportunity to continue the education from bachelor to master and doctorate level. We should move the nursing education from traditional methods to nursing program that focuses on global health. Developing an educational program from global health requires careful consideration of key components necessary to prepare healthcare professionals to address global health challenges effectively. Here are some steps to develop an educational something is wrong. It's wrong. It's wrong. It's wrong. Developing an educational program for global health requires careful consideration of the key components necessary to prepare healthcare professionals to address global health challenges effectively. Here are some steps to help to develop educational program focusing on global health.
Ma'am, just a quick thing, ma'am. We're hearing some echo from your other device, ma'am. Can you just mute one of the devices because there's strong echo?
Yeah, something is echoing.
Yeah, even we got one comment also, the sound quality is very poor, so for everybody. Yeah, and participants also, please make sure that you're on mute at all times, okay? Otherwise, it's very disturbing for everybody. So please make sure you're on mute. Ma'am, can you try now? Can you unmute and try speaking, ma'am?
Is it okay now?
Yes, it's good.
Thank you.
Thank you, ma'am. Please go ahead.
Some of the key steps to develop educational programs that focus on global health includes: first, conduct a need assessments. Begin by assessing the specific assessing the specific global health challenges and the needs in your target region or population. Identify the priority areas where healthcare professionals require knowledge and skill to address these challenges effectively. Second, define learning objectives. Based on the needs assessment, establish clear and measurable learning objectives that align with the identified global health challenges. These objectives should outline the knowledge, skills, and attitude the learners should acquire through the educational program. Third, design the curriculum involving core knowledge. Develop a curriculum that covers essential global health topics such as epidemiology, health systems, determinants of health, infectious disease, non-communicable disease, maternal and child health, humanitarian health. These are some of the important perspectives in global health. Integrate interprofessional education. Emphasize interprofessional collaboration by incorporating opportunities for healthcare professionals from various disciplines to learn together, fostering teamwork and a comprehensive approach to global health. These will encourage and enhance their communication and collaborative skills. Foster experiential learning. Include practical experience such as field placement, clinical rotation, case studies, stimulation, and research projects to enhance learners' understanding and application of global health concepts. Integrate culturally competency training to ensure learners are equipped with the skills to navigate diverse cultural contexts and provide culturally sensitive cares. Utilize innovative teaching methods, whereby include problem-based learning, engage learners in active problem-solving exercise that stimulates real-world global health challenges, encourage critical thinking, and collaborate decision-makings. and includes technologically enhanced learning. Leverage technology tools such as online modules, virtual reality, and telemedicine to enhance the access to education and also provide realistic learning experience. Involve guest lecturers and also collaborations. Invite experts from various global health organizations, academia, and NGOs to deliver guest lectures and facilitate collaboration, providing learners with diverse perspectives and also networking opportunities. Incorporate global health experience, whereby learners should be exposed to international experience. Offer opportunities for learners to participate in community health projects or research initiatives in different countries or low resource settings, allowing them to gain first-hand experience in addressing global challenges. This can be done through the mobility programs like inbound and outbound experience. Encourage local community engagement. Engage learners in local community projects that focus on addressing health disparities, promoting health education, and working with marginalized populations, fostering a sense of social responsibility. Assess and evaluate the learning outcomes. Develop the assessment strategies that align with the defined learning objectives, including written exam, case studies, presentations, research projects, and practical demonstrations. Regularly evaluate the educational model to ensure its effectiveness and make necessary improvement based on the feedbacks and learners and faculty. Lastly, facilitates ongoing professional development, offer opportunities to engage in continuing education, attend conference, participate in research projects, join research professional networks focused on global health, encourage a culture of lifelong learning, and support their career advancement in the field of global health. Remember to collaborate stakeholders in the developing of the nursing curriculum, such as healthcare organization, educational institution, policy makers, global health experts, to ensure the education program reflects the current best practice and addresses the specific needs of target population. Flexibility, adaptability, and commitment to continuous improvement are essential in developing effective education and global health. While some may say all this already been integrated into the nursing curriculum, however, most of those elements that we integrate in our curriculum currently is based on local needs or local context. Now we have to look more beyond that. In the era of increasing geographic mobility, the emergence of emerging infections that cross national borders, technologies and communication advancement, and the growing of interdependence of the world, there is a need to move a focus on the local and national health programs to ensure that all nurses are prepared to address local, national, and global health needs. Therefore, the future nurses should be prepared to address global health challenges, contribute to sustainable development, and to make a positive impact on health and well-being of populations worldwide. Aligning curriculum, fostering interdisciplinary collaboration, promoting experiential learning, encouraging research and innovation, embracing a global perspective, and nurturing advocacy and policy engagement are some of the key elements to consider when developing an educational program for future nurses.
लंच में जाने अभी नहीं जाने.
Some of my
Thank you, ma'am. Thank you so much for your presentation, ma'am. Um, At this point, we are completing all the keynote lectures. I once again thank all the keynote speakers for taking out their time and joining us in this conference. And we'll be starting the scientific sessions in about 5 to 10 minutes. So just like yesterday, you have to be joining your particular breakout rooms. So please make sure that you're aware of which breakout room you have to be joining. And we'll be starting in 5 to 10 minutes. So participants who are presenting under the session Innovative Integration in Nursing, really stay back in the main hall. You do not have to go anywhere. But if you have any other sessions that you're going to present in, you have to find a particular breakout room. So you can find it in the panel list itself. So it'll say breakout rooms. So click on that and you can join the particular. If you have any questions, let me know.
Can I try once by sharing the screen? Joe, I am the third presenter.
Sure, ma'am.
Okay, thank you. Is it visible? Hello?
Yes, ma'am.
Okay, thank you. Thank you. Okay, I'm stopping.
But not on slide share.
Yeah, true. I have not. Thank you.
Yes,
ओके ल मेरो त ल्यापटपमा कनेक्टै हुँदैन के भएको
Hi, just saw the question. So we're just trying to allot everybody to their respective halls because the breakout rooms are not yet filled. So if all the participants know which session you're presenting, it would be really helpful if you can find that particular breakout room and you can go. And as of now, we're just allotting the people. So if you're getting any request from us that you have to join a particular room, please accept it. Within 5 or 10 minutes, I hope we can start the presentation session. Completely appreciate your patience. Just bear a little longer, please.
lunch.
National Hi everyone, we'll be starting with the paper presentations. This is here Sushmita. I'll be moderating the session. I hope everyone is ready with your paper presentation slides. This is a note of information that Innovate Integration in Nursing participants will be staying in the main hall. There are allocated rooms for health and technology poster presentations. The 17 members allocated there can go to the breakout room. In the laptops, you'll be finding it in the down column, and in phone, if you're joining, you'll be finding it in the left upper column. Please join. And role of pharmacology in nursing, evidence-based practices, and nursing research too. I'll give 2 to 3 minutes for assigning yourself in the rooms. We'll start with the first presenter of the day of the main hall. I'd like to also welcome Dr. Chong Mei Chan, Head of Department, Associate Professor, Gerontology, Department of Nursing Science, University of Malaya, Kuala Lumpur, Malaysia. She'll be here to evaluate the session. Welcome you, ma'am. Ma'am, are you there?
Yeah, I'm here.
Yes, ma'am.
Okay.
I hope you have got the evaluation forms.
Yes.
Yes, sir. Here is a note of information that each participants will be given total of 10 minutes. 9 minutes you can present, and 1 minute will be the question session between Dr. Chang. She will be asking certain questions based on your research that you presented. Can we start?
Sure.
Yes. Now I move on to the next first presenter, Dr. Professor Vijay Lakshmi will be presenting an oral presentation. She's from Al-Karim College of Nursing, India. The title of the presenter will be a quasi-experimental study to assess the effectiveness of video-assisted teaching program on knowledge and attitude regarding prevention and management of varicose veins. Over to you, ma'am. Ma'am, you can start with the presentation.
ഇതിലിട്ടിട്ട് നടക്ക് കാലെവിടെയെങ്കിലും വേദന ഉണ്ടോ ചെക്ക് ചെയ്യണം.
Please make yourself unmuted or you'll be taken out of Zoom. Sorry for that. Please make yourself muted.
ഇത് ഷൂ ഇട്ട് നോക്കട്ടെ നല്ലയാണോന്ന് എപ്പോഴും ഇടാൻ പറഞ്ഞു ഡാഡി. ബർഗൂർക്കും
Dr. Vijay Lakshmi. Dr. Vijay Lakshmi, are you there? I hope she's not here. We'll wait for her. We'll skip her and move on to the next presenter. I'd like to call upon Sunita K from Cartes College of Nursing, India, to present her oral presentation. Yes, Sunita.
Yes, ma'am, I am here. Thank you,
Yes.
ma'am.
Yes, you are audible. Please present your screen.
Yes, ma'am. Can you see my?
It is still on started screen sharing. We are waiting for your screen. Yes, it is visible. You can start with your presentation.
No. One minute, ma'am, please.
Sure.
Okay, ma'am.
Yes, please start with the presentation.
I can. In this side, ma'am, I am covering with this sharing. It is very difficult for me, ma'am.
No, that
Please,
is
ma'am.
not a problem. We can see your introduction slide. You can start with your presentation.
That because of that covering, I can't read fully. That covering that my writings and all, ma'am.
Kindly sort it out and start as soon as possible.
I will, ma'am. Yancy, please come fast.
Can we give you 2 or 3 minutes and go to the
Yes,
next
ma'am. Yes, ma'am.
presenter?
Just I will arrange.
Okay. We'll move on with the next presenter then. You can stop sharing your screen.
I can.
Yeah. Can you please stop, Madam Sunita?
Continuation I will. Ma'am, next I will present, ma'am. 1 minute, please, ma'am. Please excuse me.
Yeah.
No
But
problem.
if you can stop.
You can stop your screen sharing.
Okay.
Is visible my screen?
Yes, ma'am. Is it?
Then
It is Prita
yeah.
Sarkar from
Yeah.
Amity University.
Yeah. I'm putting on my slideshow.
Yes, ma'am. It is visible.
Is it visible? Can I move
Yes.
to the next slide? It's going.
Yes, ma'am. We can see your need of this study. Yes.
Okay.
You can proceed.
Thank you for the opportunity to present, and I'm thankful to my judge. Yes, incidence and awareness of venous thromboembolism among Indian population, an overview which myself, Dr. Sunita and Dr. Anil Kumar has done a detailed review, because we have found that deep vein thrombosis is very alarming and is a silent killer And the thing is that earlier it was thought that Western countries only having, but now for last decade only we are finding, yes, that formation of venous thromboembolism, which is a collective term of DVT and pulmonary embolism, is not rarity in India. That is why we aim to have a detailed review to understand the incidence, so that in acute care, lots of, occurrence, if we know, we can know the common risk factor, and public awareness is very important. With those objectives in mind, we started this review. Now, we did extensive survey on our Scopus and PubMed databases from 2000 onwards till the recent studies we have found. We have gone through 57 research publishers in India only, which we have done in details about case study and about this research in single center, multi-center, and not only that, also the review literature we have taken care. Then we started sorting it. We have excluded the detailed analysis of the clinical manifestation, but we use the Prisma flow. In the Prisma flow, we have done the details, and ultimately we landed in 27 of the studies, of which 12 studies are very key studies, which is telling about incidence, and rest are review, and some are case studies. So this is what we found, and we found that ortho, neuro, cardiac, gastro, and even your overall, some studies has done. In ortho, predominantly we have found, say for example, in Agarwala, we have found it is predominance, you can see almost near about 50%, whereas, just a minute, I'm taking my pointer. Yeah, whereas you can find it very less in case of abulopathy, which is in 2019. But yes, neuro and cardio is also there. But in cardio, especially in this case of Singh et al., they have taken 330 patients who are showing more signs and symptoms near to this DVT and PE, and of that they have found 303. So you should not think that 330 is the only one which has been taken, and out of it 30, because it looks a very big figure in that way. Fine. Next is, yes, some studies have particularly tell about proximal and distal DVT, which you can see Lee et al., Nagbi et al., which is a 25-year continuous study in Aligarh University they have done, Singh et al., Basantapa et al., where we can see the proximal DVT is more, because it is also very alarming, because proximal DVT can cause more pulmonary embolism, which can be a silent killer. Some of the studies which we have highlighted, 12 major ones which we are highlighted, of which average you can find the age group of 35 to 43 if you go through. But some studies, say for example, Singh, they have taken average of 50, whereas in Agarwal is 62. Now, some common risk factor which I wanted to share in this presentation is the surgery. Yes, ortho surgery, as you can see the data here by S. Agarwal is more, but some surgeries are also mixed surgery. That is why I have not specified, like Nagbi, Kamerkar, then Bodhi and Rajinder. Then malignancy, yes. Sometimes a patient comes to with the signs and symptoms of DVT, but later they are diagnosed as oncology, because oncology patients are very risk for DVT formation. Obstetrics, yes. Obstetrics we have found quite less, but 2 studies, especially in Nagbi, we have done a 25 years continuous study. Postpartum patient they have done. Out of 293 patients, 126 they have found is more, predominant. Then past history of DVT also has a recurrence. Here you can see this is little alarming, which has proved in 2016 study by Kamerkar. Then, yes, immobility, more than 3 days of prolonged immobility, as you know, it is an hospital never events. Then history of contraceptive pill is also we have found in some key studies. Long distance travel, yes. Some case study also has been identified. In this context, I would like to share that some long travel from London we have found one lecturer has come and he has been immediately shifted to Delhi hospital soon after landing, after a 12-hour journey, and I found that patient is having a pulmonary embolism. In discussion phase, I like to highlight one key one, that is endorsed study, Epidemic International Day for Evaluation of Patients at Risk for Venous Thromboembolism in acute care setting, where the predominant is 68,183 patients was enrolled in Cohen et al. 358 hospital, they have done pan world, and there they found that in acute hospital, more than 50% are risk, of which this 50%, only 50% receive ACCP, American College of Chest Physician guidelines. In India, same thing has been done. We have participated, that is Pinjala et al. In 10 hospitals from various corners, and they have found the scenario is, yes, more than 50% at the par with this world study, but 20% only is receiving American College of Chest Physician guidelines, which is very concerned. And you can say by seeing this study is also make us a motivation that yes, something has to be understood, which we can share. That is Parak et al. Has done a detailed study. We have hardly find very review which is gathering all this data. That is why we have found this Parak et al., which I wanted to highlight one of them, where all core group leaders has met and they try to formalize that what is the current guidelines, how relevant for Indian patient. Nursing awareness. Nursing awareness should be highlighted because I myself has done study in one cardiac hospital in 2018, and also there is another study to highlight it. The found nurses' knowledge in deep vein thrombosis is very less, and the practice also. That is why nowadays, recently we are finding, even in fact, in this year, as for my work culture, I have finding it that many SOPs has been formulated. Many chain hospitals are focusing on that well-scored implementation. Some are doing some hospital improvised their risk assessment tool. But okay, that is fine only. But we should know that how to early detect the DVT signs and symptoms, that is most important, and also what are the risk factors, so that in history taking, we should not miss any chance. Lastly, the public awareness recently, which is prevailing in India, which I found, honestly, some YouTube videos is very not is there, but what we can found that many newspaper agencies, social media, really they are faced for the public alertness, especially long-term journey. Then for e-thrombosis, we have found some, like, and let me highlight that that one Dr. Subiraj John, he has told in post-thrombotic, in World Thrombosis Day. Then Dr. Jyoti V. Sharma has told that how long-term sitting can be also provoke DVT formation. Then lastly, very important one I wanted to highlight, the Bra and Saha, he has done a review study. They are from PGIM and Chandigarh. They have found that airlines, especially they have identified Indian airlines for long-term journey, they are not having any guidelines for, for the passenger, how they should take preventive steps in prevention of deep vein thrombosis. What are the minimum criteria they should maintain, that is an proper in between flight exercises, in between, keep them hydrated, not take much alcohol, etc. So as a recommendation, various studies can be done. In fact, I myself is doing a study on corporate travelers who, due to work, they are traveling, frequent travelers. And I'm trying with the identification, wanted to give a new guidelines in U2, so that preventive steps can be taken. Because travel thrombosis and also e-thrombosis is a concern. If public awareness is there, then it can be really an eye-opener. That is what we aim, because we know 13th October is Dr. Rudolph's virtue. We celebrate, worldwide, but I think more and more, if we can create awareness, that will be really good. These are some of my references which we have done in details. Thank you.
Thank you, Prita. Ma'am, do we have any questions?
Okay, thank you very much, Madam Prita, for your interesting presentation. Yeah, the presentation is very clear, and the review is very extensive. Yeah, you have covered most of the thing. I would like to know why is it you choose to select the literature from year 2003 until today, because 2003 is like 20 years ago. Yeah, usually preferably we review the recent literature. But why do you need to take it until 20 years ago? Thank you.
Yeah, yes, ma'am, because to be very honest with you, as I am in this field, I was finding very less literature present in India. Previously, whenever we used to discuss with clinicians, they tell, no, it's not happening in India. But right now, slowly things are getting, and that is why I have to go a little back. Recent studies, I tried, but
right.
Some I am getting, but which I have excluded for this review is the details intervention. But that is in thrombosis in general, not specific to different thrombosis.
Right. So do you think the literature from out of India, right, whatever people have done in Western country and maybe in ASEAN country, do you think the evidence can be practiced in India to come up with guidelines?
Yes, ma'am. In fact, it is very relevant, and we found one review only, that which I mentioned, that Dr. Parak, he is actually currently practicing in Medanta. He had his all from all departments. They tried to summarize, but to be very practical, that how much is implemented, as we saw in the first session today, that academic and practice has to be coincident.
Okay, thank you for your question. Thank you very much. I don't have any more questions. Thank you.
Thank you, ma'am. Thank you. So I'm stop sharing. Hello.
Thank you, Dr. Chong and Ms. Prita. You can stop sharing. Okay. Now I'd like to call Dr. Vijay Lakshmi. Are you there? Dr. Vijay Lakshmi? Okay, we'll move on with the next presenter. Shishil Matthew from Father Muller College of Nursing, India.
Yes, ma'am. Good afternoon, ma'am.
Yes, ma'am. We can see you.
Yeah, let me share my slide.
Ma'am, a quick thing. Your background banner is in mirror image. Is it able to change it?
Is it okay, ma'am, now?
Now we can't see you, ma'am.
Oh. 1 minute, ma'am.
Yeah.
How is it, ma'am?
Yes, ma'am, you can start presentation.
Yeah, thank you, ma'am.
Be a problem.
Yeah, yeah, thank you, ma'am. Thank you so much. Yeah. Is my slides are changing, ma'am? Yes. Ma'am, can I start?
Yes, ma'am, I can see your slides changing. You
Yeah.
can start.
Yeah, thank you so much, ma'am. Very good afternoon, madam and Madam Judge. Herewith, I will begin with my scientific oral paper presentation. Myself, Shishil Matthew, Associate Professor, Father Muller College of Nursing, Mangalore, India. Moving to the title of the study, are menstrual pattern associated with the body mass index of university students? A descriptive study in Mangalore, Karnataka, from India. Moving to the introduction and need for the study. Menstrual cycle irregularities and anovulation have been found occur with increase in frequency in women who deviate considerable from normal weight. Menstrual cycle irregularity is highly influenced by body mass index. Ovulation abnormalities may also be caused by fluctuations, weight, such as overweight, being overweight, obese, underweight, which is hypothesized to disrupt the energy balance. Continuation, the prevalence of menstrual disorders in India has been recorded as high as 87%. Numerous studies have demonstrated that irregularities adolescent menstrual cycle may persist into adulthood and ultimately be linked to subfertility. Menstrual irregularities are mostly neglected by the society due to unawareness regarding the irregular menstrual pattern and their problems. Moving to the aim of the study. The aim of the study was to find out the association between menstrual pattern and body mass index among university students. Moving to the objectives. To assess the menstrual pattern among university students, to determine the body mass index among university students, to find out the association between menstrual pattern and body mass index among university students, and the last to find out the association of menstrual pattern and body mass index of university students with the selected demographic variables. Moving to the methodology. A quantitative research approach with a descriptive design was adopted, and it was conducted from selected health science deemed to be university at Mangalore, and the target population was female students of selected health science university, was selected by stratified random sampling technique and with the sample size of 222. Moving to the inclusion and exclusion criteria. Students were included with the age group of 17 to 25 years and unmarried female students, and attained menarche and students those who are willing to participate in the study. Whereas in the exclusion criteria, students who are on oral contraceptive pill, who are on the treatment of already with the menstrual problems, who had undergone pelvic or other pelvic organ related surgery and had a history or currently on chemo or radiation therapy. Moving to the instruments used in this current study, socio-demographic proforma with the 14 number of items, and second tool self-reported menstrual pattern questionnaire with the 12 items, which consists of first part consists of menstrual characteristics and second part consists of menstrual problems. Moving to the third, anthropometric measurements, and it was classified and based on the WHO BMI classification scale with the Asian population. Moving to the results. In the section 1, regarding the baseline characteristics or demographic performer, which can understand that more than half of the subjects were in the age group of 20 to 21 years and with the mean age of 20. Majority of the subjects, that is 97.7% will consume mixed diet, and majority of subjects consume 50.5% 3 meals per day. And also we can see that 56.3% of them ate junk food 2 to 3 times a week. Out of 222 subjects, 74.8% have skipped their meals sometimes. The majority of the subjects, 74.8%, did not perform any physical activity in their day-to-day life, and also found that 83.3% had not taken any pills during their menstrual pain. Moving to the section that is menstrual pattern among university students. Table 1 depicts that the categorization of university students based on the menstrual characteristics. From this, we can understand that the majority of the studied subjects attained their menarche with the age of 11 to 13 years. And in terms of regularity of menstrual period, majority, that is 50.9%, had irregular menstruation, whereas severity of pain, majority had moderate level of pain. The continuation of the table 1, the number of days the period lasts in terms of duration of menses, majority, that is 4 to 7 days, that is 48.2% had duration of menses, that is 4 to 7 days. Moving to the average length of menstrual cycle, majority 54.1% had 21 days to 27 days of cycle. In terms of menstrual flow, majority had a normal menstrual flow. Moving to the second section under the menstrual pattern, which is table 2 depicts that distribution of subjects based on their menstrual problems. In terms of dysmenorrhea, majority had dysmenorrhea with a percentage of 68.5%, whereas 85 number of total subjects had oligomenorrhea, and very few number of subjects had polymenorrhea, that is 7.7%. Continuation of the table 2 in terms of menstrual problems. Hypomenorrhea also was found with a very few number of studied subjects, and also we have seen menorrhea with the 21 studied subjects out of the total sample size, and also amenorrhea also was noticed with the 5%. Moving to the section 3, BMI status of university students. Table 3 depicts that distribution of studied subjects based on their BMI status. From this, we can understand that majority actually belongs to the normal weight category, whereas also noticed that 23.9% were identified with the underweight. Also, it is noted that overweight and obese 1 and obese 2 categories also found in this among the studied subjects. Moving to the section 3. It is about the association between menstrual pattern and body mass index of university students. From this table 4, we can understand that we have found a significant association between menstrual pattern and BMI status in terms of dysmenorrhea, oligomenorrhea, and polymenorrhea was significantly associated with body mass index with a p-value of less than 0.05 level of significance. Continuation of that, irregular menstrual cycle were more frequent among underweight with 90.5%, in terms of overweight category 62.4%, and obese.
That you're wrapping up.
Yes, yeah. Yeah, students with compared with the normal weight students. Madam, should I need to do anything?
You can finish and wrap it up, ma'am.
Yeah. Thank you. Yeah, moving to body mass index is significantly associated with the dysmenorrhea, more among that is underweight students, and however, both overweight and obese students suffering from dysmenorrhea, which is accounted for 54.3%, while polymenorrhea was more frequent among obese students compared to the other weight categories. Oligomenorrhea also was more frequent among overweight students and compared with the other weight categories. And last section, there was a significant association between type of diet and with the period of menstruation, that is menarche, with the skip of meals, and during pills during menstrual pain with the severe pain, that is all significantly associated with the selected demographic variable. And also BMI status also was, there is a significant association with the place of stay and skipping meals at P is less than 0.05 level of significance. With the other demographic variable, there was no significant association. Moving to the conclusion. From the present study, it can be considered that most of the students reported dysmenorrhea. This was the most common menstrual disorder among study subjects, whereas oligomenorrhea was as the second most menstrual disorders. And also we have found a significant association between dysmenorrhea, oligomenorrhea, and polymenorrhea with BMI status of university students. In this case, we have to assess nurses or being of nursing profession, the lifestyle modification and nutrition counseling for the female students could alleviate this menstrual problem, which is related to altered body mass index. We have a major role with this related issues, which is under-recognized and not bothered many of the people. So I would like to acknowledge my co-authors, Asiya Banu, Ms. Ashudi UK, Atul K, Atulya Matthew, and Professor Girish G. These are some of the references. Thank you, ma'am. Thank you, all of you.
Thank you very much, Ms. Saucy, for your presentation.
Thank you,
for your presentation. All well stated, well presented in terms of your research methodology. I would just have one query, because looking at the student with dysmenorrhea, the percentage is quite high. It is about, it is about, okay,
152, madam.
152.
Yes.
So what are you going to do with these students subsequently? Is it too high?
Yeah, it is too high. Actually, we can do it. Actually, my next study I'm planning to have with the yoga. Actually, non-pharmacological method is best. Actually, every time with the going with the pharmacological measures, because the motto behind this to begin with the study was many of our students, not only nursing students, many of the students frequently absent during the reason of dysmenorrhea and their attendance shortage. And with this, actually, even we can do yoga, non-pharmacological methods. So that is why as a faculty, So personal skill development, even in our institution, we have begin with the yoga modality.
Yeah.
Thank you.
You are proposing yoga because your current study is on diet, obesity. Yeah, obesity.
Yes, madam.
And you
Yes,
look
ma'am.
at
Yoga have multiple benefits, madam.
Yes, since you are doing on obesity and you also explore on their diet, maybe you can think of diet before yoga. Yeah, because yoga might have more difficulty to comply compared to diet, because the presentation by you, some of the diet is not very balanced. They eat junk food, right? And some of them some of them skip their meal. Yeah, maybe by skipping meal also can cause
dysmenorrhea and underweight.
Will affect their well-being. That also will cause dysmenorrhea. Or maybe they are university student. I don't know. Yeah, maybe stress also can cause dysmenorrhea. But in future, you can explore more on that. Thank you.
Thank you so much, ma'am, for your valuable suggestion.
Thank you, ma'am.
I will stop sharing, ma'am.
Yes, ma'am. Now we'll move on with our next presenter, Ms. Harpreet Kaur from Desh Bharat University, Mandi Gobind Nagar, India.
Good afternoon, ma'am.
Presentation. Yes, ma'am. I can hear you.
Good afternoon, ma'am.
Good afternoon.
You can share your screen.
Yes, ma'am.
A kind note of information to all the participants. I can see certain number of participants who are not assigned yourself to the breakout rooms. Please assign yourself to the breakout rooms which you are allocated for your presentation. Then only they will be calling out your names. I can see more than 60 to 70 participants are still in the main hall.
So shall I start, ma'am?
Yes, you can.
Good afternoon. My title is a pre-experimental study to assess the effectiveness of structured teaching program on knowledge regarding pregnancy-induced hypertension and its prevention among antenatal mothers attending antenatal OPD in a selected hospital of Mohali, Punjab. Generally, hypertension is one of the common medical complications of pregnancy and contributes significantly to maternal perinatal morbidity and mortality. Pregnancy-induced hypertension that is also
sorry,
been noted as...
I can't see your slide.
Ma'am, I have shared my slide.
No, ma'am, it is not visible.
Okay, ma'am, I'll do it again.
We can see your video, but not your slide, ma'am.
Okay, ma'am. Ma'am, now is my visible? My screen?
No, not exactly. No, ma'am.
Ma'am, just give me a moment. Just a moment, ma'am.
Yes.
Yes, ma'am. Now is it visible, ma'am?
Yes. Yes, ma'am. It is visible.
Okay. Thank you so much, ma'am.
Try to change the slides now.
Yes. So, ma'am, introduction. Hypertension is one of the common medical complications of pregnancy and contributes.
Excuse me, ma'am. Move on with the next slide. It is on e-oral presentation only.
Okay, ma'am. So, objectives to assess the pretest level of knowledge regarding pregnancy-induced hypertension.
I can't see your slides moving. It is still in the e-oral presentation.
Ma'am, actually, I'm moving it from here.
I think Susmita, I think maybe the data problem, internet data problem. Like
ma'am, now is it okay?
No.
We can't see your slide, ma'am, actually. We'll wait for 2 or 3 minutes. Just sort it out, ma'am.
Okay,
just
ma'am.
share your slide and put it in the slideshow mode and you can move it.
Ma'am, I'm doing that only, but I don't understand why it's happening like this. Ma'am, now is it visible? My slide is visible?
No. Yes, it is showing, it is sharing.
Okay.
Please Yes, now it is. Yes, you can move on.
Now it is visible, ma'am?
Yes, now I
Need
can
of the
see
study page.
need of the
Yeah,
study.
yeah, yeah.
Yes.
Yes, ma'am. Hypertensive disorders complicate 5 to 10% of all pregnancies. In India, pregnancy-induced hypertension accounts for about 50,000 deaths per year. As per WHO 2014 report, hypertension is accounted as the second most common direct cause of maternal mortality worldwide. About 76,000 pregnant women die each year from preeclampsia and related hypertensive disorders. That amounts to be nearly 200 women every day. Next, objectives of the study are to assess the pretest level of knowledge regarding pregnancy-induced hypertension and its prevention among antenatal mothers, to develop and administer structured teaching program on knowledge regarding pregnancy-induced hypertension and its prevention among antenatal mothers, to post-test the level of knowledge regarding pregnancy-induced hypertension and its prevention among antenatal mothers, to evaluate the effectiveness of structured teaching program on pregnancy-induced hypertension and its prevention among mothers, and last is to evaluate the pretest level of knowledge on pregnancy-induced hypertension and its prevention among antenatal mothers with their selected socio-demographic variables. Hypothesis, first hypothesis, there is a difference in the pre-test and post-test level of knowledge at the level of 0.05 significance. And H2 is there is an association between pre-test level of knowledge and the socio-demographic variables at 0.05 level of significance. Next is review of literature. I have divided into 4 sections. First section, studies related to pregnancy-induced hypertension among antenatal mothers. Section B includes studies related to risk factors of PIH among antenatal mothers, and section C includes management of PIH among antenatal mothers, and section D includes the effectiveness of structured teaching program on PIH among antenatal mothers. Next is research methodology. I have used quantitative research approach, pre-experimental one-group pre-test post-test research design. Research setting was antenatal OPD at Dr. B.R. Ambedkar Institute, State Institute of Medical Science, Phase 6, Mohali, Punjab. Target population was antenatal mothers attending antenatal OPD at the same hospital. Sample size taken was 60 antenatal mothers, and non-probability convenient sampling technique was used. Variables, independent variable was structured teaching program, and dependent were knowledge of antenatal mothers. Inclusion criteria, the antenatal mothers who were attending this antenatal OPD of the mentioned hospital, those who were interested to participate in the study and able to read and write Hindi. Selection and development of tool include section A was social demographic data, and B include the self-administered structure knowledge questionnaire on pregnancy-induced hypertension and its prevention among antenatal mothers. Next, validity of tool, it was given to 7 experts. Reliability calculated was 0.82, and pilot study was conducted on 10%, that was 6 antenatal mothers, to find out the feasibility. Next, data collection procedure, self-administered structure knowledge questionnaire was used, and it was given to experimental group on one day, and on the same day the pre-test was also given, and after 1 week the post-test was conducted using the same questionnaire. Ethical considerations, principle from permission from the director principal of Dr. B.R. Ambedkar State Institute of Medical Science was taken, and verbal and written consent from the antenatals was also taken. Data analysis plan, coding sheet was present for data analysis, and data were analyzed by using descriptive and inferential statistics. Next, analysis and interpretation. Section 1 contributes towards the distribution of the antenatal mothers according to the social demographic variables. Here, the maximum antenatal mothers belong to 24 to 29 years of age, that was 30 mothers. Religion, 26 mothers means highest belong to Hindu religion. Type of family was joint family maximum, and educational status was all mothers were mostly graduated, and monthly income of the family was majority showed that it was between 5,000 to 10,000. Occupation of most antenatal mothers were private, they were private employees, and source of information was mass media. And next table, that is comparison of pre-test and post-test level of knowledge regarding pregnancy-induced hypertension among antenatal mothers. This shows that in pre-test, 20% mothers have inadequate knowledge, whereas in post-test, none of them showed any inadequate knowledge, and in pre-test, 0 were having adequate knowledge, and in post-test, 27 mothers were having adequate knowledge. And next is section 3 shows the effectiveness of structured teaching program by using paired t-test method. So here the post-test mean score that was calculated was highest than the pre-test. So this shows that the paired t-test value, that is 29.038, was highly significant. It means my structured teaching program was effective to enhance the knowledge of the antenatal mothers regarding pregnancy-induced hypertension and its prevention. Next is association of pretest knowledge scores with selected socio-demographic variables, as it is displayed on slide that age, religion, and educational status had an association with the level of pretest level of knowledge of the mother. Next, conclusion. Antenatal mothers were having moderate level of knowledge on pregnancy-induced hypertension and its prevention. There was significant improvement in the level of knowledge on antenatal mothers after administration of structured teaching program. Structured teaching program is one of the best methods of teaching to enhance the knowledge of the antenatal mothers on pregnancy-induced hypertension and its prevention. Age, religion, and educational status showed association with the knowledge of antenatal mothers on pregnancy-induced hypertension and its prevention before its intervention. These are my references, and thank you so much, ma'am.
Thank you very much. Thank you very much for your presentation.
Thank you, ma'am. Dr. Chong, do you have any questions?
Harpreet, yeah. Okay,
Yes,
Ms. Harpreet, thank you very much.
Thank you so much,
it's a good study, but however, you are just measuring knowledge. Usually,
yes.
how long you measure the knowledge after you teach them?
Actually, ma'am, it took me 3 months. Like to
after 3 months.
Yes, ma'am. It took me 3 months because the mothers who were visiting antenatal OPD, certain sort of problem was created. Right, in post-test, ma'am, I faced some sort of knowledge problems.
Yeah, fine. How are you going to improve on your if in future you are going to conduct a study on this again? How are you going to improve to see the effect, the real effect of your study?
Ma'am, I will definitely ask my students to produce some sort of banners as well as pamphlets and all to distribute to the mothers, so that in the initial stage only she can know about the pregnancy induced hypertension, because generally the women who face it, they were normotensive earlier.
Right. All right. If we are measuring knowledge, if they have very good knowledge, does it mean the maternal outcome will be better? Because you are not measuring maternal outcome, right?
Yes,
because you are looking at hypertension in pregnancy. So perhaps when you teach them, you give them knowledge, you would like to measure whether they can control their hypertension or then it is more meaningful. Yes. Yeah, because obviously when we teach the mother, obviously their knowledge will be better than a person that we never teach at all. Yeah, because that cannot convince us it is your effect of your teaching. Right, and then if in future you are going to do this again, I propose you may need to have a control group.
Okay, ma'am, definitely, ma'am.
To see the real effect of your teaching, because you just have pre and post may not be enough, but otherwise the step of your study is in accordance.
Sure, ma'am. I'll definitely, ma'am.
Thank you.
Thank you so much, ma'am. Thank you so much. Thank you.
Thank you, Ms. Harpreet. Now we call upon Anjali Kaushik from Rufida College of Nursing, Jamia Hamza, Delhi, for her oral presentation.
A very good afternoon to Honorable Dr. Chong Mei Chan and my dear friend. I think I am audible.
Yeah, very clear.
Okay, so first of all, I would like to thank the organizers for giving me this opportunity to be here, and a very special thanks to Ms. Sushmita for her kind cooperation and coordination. So let me share the screen. I guess the screen is visible to all.
Yes.
Yes, ma'am, we can see your slides.
Okay, thank you. Thank you so much for responding. So the topic of my today's presentation is improving practice of nurses to deliver respectful adolescent care, a psychological interventional study. So regarding the introduction, we know that nurses in any hospital, they are the backbone of that particular system, and adolescence is such an important stage in the human development when we lay the foundation of good health. Therefore, health system should take the responsibility to fulfill the different demands of adolescents by focusing on improving the standards of healthcare facilities And these healthcare facilities should be friendly to the adolescents and should be acceptable, effective, efficient, equitable, and should keep safety aspects for adolescents. We cannot deny the role played by the nurses in the prevention of diseases and the promotion of health. And nurses are responsible to a great extent for supervising the adolescents under their care, and it should be done without hurting their feelings and sentiments, as adolescents during this period undergo rapid physical, psychological, and psychosocial growth, which further affect the feelings, thinking, decision making power, and how they interact with the others in the surroundings. Regarding the background of the study, we cannot say that adolescents are older children or younger adults. They are unique individuals. They with individual difference in them, and they have unique requirements. They understand information in a very different way because of various factors like interpersonal factors, social factors, institutional factors. Therefore, it is important to understand how much information they can absorb, which help us to provide information in the same way which they can understand. And healthcare providers should respond to the adolescents' needs in a respectful manner. And for this, they need to develop competencies like knowledge to understand their age-wise growth and development. They need to develop communication skills to communicate with adolescents effectively. Healthcare providers should be skillful enough to practice the respectful adolescent care. And adolescents with special conditions need to be provided timely and effective care. There is a need to develop programs regarding adolescent health, and programs should focus on the enhancement of performance of health workers. Therefore, the aim of the present study is to assess the practice of nurses regarding respectful adolescent care before and after an interventional program on respectful adolescent care, and also aims to improve nurses' performance in delivering respectful adolescent care. WHO Adolescent Health Framework was referred for preparing the training program, and the effects of educational intervention on competencies of nurses in promoting adolescent health care was assessed. This study is one of first in India where practice of pediatric nurses were assessed before and after training on respectful adolescent care, and thereby improving their performance in promoting adolescent health. So objectives of this study was to assess and compare the practice of nurses regarding respectful adolescent care before and after an interventional program on respectful adolescent care, and to evaluate the effectiveness of training program on RAC. Methodology: quantitative research approach with pre-experimental research design was used. 30 registered nurses working in selected healthcare setting were selected for the study, and sampling technique was non-probability, that is purposive sampling. Administrative approval was obtained from respective hospital to conduct the research study. Informed consent was taken from each study subject, and they were assured of anonymity and confidentiality of the information provided during the study. Tool used for data collection was structured observation checklist. An intervention program on respectful adolescent care was introduced to them, and on 7-day post-test was done. Practice was categorized as poor, that is less than 50%, moderate 51 to 75%, and good, that is more than 75%. Regarding the result, when we look at the frequency and percentage distribution of nurses in terms of their demographic profile, we can see here that 60% of the nurses were in the age group of 20 to 29 years, and all the nurses were female. Then 40% of the nurses were post-basic BSc nursing trained, and 18, that is 60% of the nurses were unmarried, and 50% of the nurses, they had an experience of 5 to 9 years, and none of them, they have heard of RAC or attending an in-service education program on RAC. And regarding the pretest level of practice score, we can see here that 60% were having a range of, were in the poor range. Then 40% of the nurses, they were in the moderate range, and none of them, they were in the good level of practice score. When we look at the post-test level of practice scores, here we can clearly see that 70% of the nurses, they scored good, and 30% they scored 9, and none of them, they were in the poor range. When we compare the pre-test and post-test practice score of nurses, here we can see that there is a difference in the mean and the standard deviation also. So mean difference was 5.40, and I used the student pair t-test for the comparison. Here we can see here the p-value is less than 0.01, that is highly significant at 0.01 level of significance. Regarding the effectiveness of intervention on respectable adolescent care and generalization of practice scores of nurses, here we can see clearly that there is a mean practice gain score with 95% confidence level 5.40, and percentage of practice gain score with 95% confidence level is 27, which is highly significant. It shows that yes, the intervention on respectful adolescent care, it worked, and it improved the performance of nurses. So we can say here, professional knowledge and skill of nurses are vital in providing care to the patients, especially the adolescent, as this phase is the most transitional one. Nurses need to be skillful enough to tackle health issues and in providing care to the adolescents. Nurses may acquire skill from various areas such as basic professional training provided during professional education, practical training, experiences from day-to-day life, and clinical observations. In this regard, their performance can be improved if provided training or some intervention related to the topic which they are not aware of. This study is an attempt to improve the practice of nurses related to respectful adolescent care by introducing an intervention on RAC. In a study done by Coase-Selman et al., it was found that after training on basic life support, knowledge scores and practical skill scores were raised as compared to scores before training among student nurses. These findings are similar with the findings of the present study, where post-test practice scores of nurses has been improved significantly after intervention on RAC. Research findings of the present study shows that there is an increase in the post-test practice score of nurses regarding RAC. Similar findings were observed in a study done by Ranimol P. and et al., where practice score of nurses regarding CPR was improved after intervention. In a study done by Sharma A.K., where knowledge and practice score of nurses were raised significantly after administration of training program on nosocomial infection, which are in line with the findings of the present study, where post-test practice scores increased significantly after intervention on RAC, although knowledge aspect was not assessed in the present study. In another study done by Lee R.L. Wang, J.J., there is significant improvement in the performance of pediatric nurses. After attending the 3-week training program, they concluded that post-test scores were significantly higher and it had effect on competency of the nurses. These findings are consistent with the findings of the present study, where enormous improvement has been seen in the post-test practice score of nurses after intervention on respectful adolescent care. It can be deduced from the present study that if an educational intervention is provided to nurses, this can bring a change in their knowledge, attitudes, and practice. This is evident then as the nurses in this study exhibited improved practice score in providing RAC after partaking 3 intervention program on RAC. The implications can be, the research can be done to explore the opinion of adolescents regarding what they want from the healthcare industry and also the various counseling centers from where they can seek help. And in nursing education, more content should be there and it should be included as a part of nursing curriculum, especially in pediatric nursing. So we can conclude that in the present study, after intervention, post-test practice score of nurses improved significantly, hereby confirming that intervention on RAC was effective in improving performance of nurses. And pediatric nurses, when fully equipped with the skills of providing RAC, they can help the adolescent population in recovering from their physical, mental illness, as well as help them in retaining their faith in the healthcare system. Empathetic practice of the pediatric nurses can help in increasing satisfaction among adolescents and thereby reducing or preventing the occurrence of several diseases. Respectful adolescent care is a concept that every pediatric nurse should be aware of so that she can deal with adolescents in a respectful manner. So these are the references, and thank you so much for your patience listening.
Thank you, ma'am. Dr. Chong, any questions?
Thank you very much for the interesting study. Right. I don't have a lot of questions, but my concern is just like the previous presentation. Right. Perhaps in future you may need to have a control group, yeah, to see the true effect of your intervention. Okay, and perhaps you need to explore the right effect side for your study to claim that your intervention is really effective, right? So just a very minor comment on the presentation. Perhaps in future, the presentation should be less wordy. Yeah, the slide need to be less wordy, very wordy. You get what I mean? Okay, thank you very much.
Thank you so much for your question. And that's a very good question, ma'am. Actually, this is a part of my pilot study. The main study of my PhD thesis will be a pre-experimental study where I have included both control and experimental.
Okay, very good, very good. All the best in your PhD study.
Thank you so much, ma'am. Thank you, ma'am.
Thank you, ma'am. We'll move on with the next presentation. I'd like to call our first presenter, Dr. Professor Vijayalakshmi from Al Karim College of Nursing, India, for her oral presentation. Dr. Vijayalakshmi, please unmute yourself. Sorry, we are not able to hear you.
Pardon, ma'am?
Yes, I can hear you. Kindly move on with the presentation. Dr. Vijayalakshmi, can you hear me?
Yeah, yes, ma'am. This is Dr. Vijayalakshmi Hannakkamale. I have completed my PhD from the Himalayan University, Teerthanker, India, in the 2022. Statement of the problem is a quasi-experimental study to assess
Dr.
the.
Vijayalakshmi, sorry for the interruption. We are not able to see your slide.
Ha, ma'am. 1 second, ma'am.
A kind note of information to the participants. Make sure that you are in the assigned slides.
Ma'am, now?
No, ma'am, we are not able to see. We can see your video, but not your presentation. I would like to repeat, those who are in Innovate Integration in Nursing, please stay in main hall. Other members, if you are not presented, please go to the assigned halls in the breakout rooms. There are parallel sessions going on in your rooms. If you are not presented, please. Dr. Vijayalakshmi, have you sorted it out?
1 second, ma'am.
Ma'am, are you using a second device or in the same device?
Laptop I'm using, ma'am.
Yes, ma'am, you can share your slide. You can see share screen, green icon on the bottom.
Why I'm not getting, wait, ma'am. Video, my video is on. Yeah.
Yes, your video is on, ma'am, but your presentation slides, you have to share your screen. I mean, can you see any icons in the down? Okay, we'll give you 2 or 3 minutes to sort it out. I'll move on with the next presenter, ma'am. Can I? Ma'am, can I move on with the next presenter? You please keep it sorted out. I hope I'm audible. Hello.
Miss Sumita, I think we move on to others presenter first. Is it okay? Because there were so many.
Yes, ma'am, sure. We'll move on with the next presenter. The second presenter, Sunita, Curtis College of Nursing, for our oral presentation. Sunita, please unmute yourself and speak up. Yes, Sunita, your screen is visible. Can you unmute yourself and speak? Sunita, can you hear me? If you're not responding, we'll be moving on to the next presenter. Please proceed with your presentation. No, we are not able to hear you. We are not able to hear you. Ms. Sunita? Okay, we'll move on with the next presentation. Sorry, Ms. Sunita, kindly, we'll be calling you up at last. Kindly try to present. I'd like to call Ms. Divya from Sikkim Manipal College of Nursing, India for her oral presentation.
Yes, ma'am, I'm there. But
Yes,
I
I'll
think at
stop.
first.
Yes, I'll stop her.
Okay, okay, thank you.
Yes, you can proceed.
Okay. Is my slide visible?
Yes, you are. Kindly place it in the slide format and try changing your slides so that I'll confirm whether it is changing or not.
Okay, sure.
Yes, it is in the full screen.
Okay, thank you.
Try changing your slide, please.
I'm changing my slide. It's not being changed.
You have to change in the full slide.
Yeah.
Yes, now it is changing. You can proceed with your presentation.
Okay, thank you. So a very good afternoon to respected Madam Chong Meng Chang and our fellow participants. Today, I, Divya Chapagai, am here for my research oral paper presentation. This research was conducted by myself as a fulfillment of my MSc Nursing curriculum, and my research guides are Mrs. Reshma Tamang, Professor, Sikkim Manipal College of Nursing, and Mrs. Arkirupaya Shadab, Associate Professor, Sikkim Manipal College of Nursing. Introduction, background of my study. Nursing education is undergoing significant changes in response to society's continuously changing demands. A good education system is essential for any country's and nation's progress. Teachers can employ more effective and efficient approaches in planning and implementing new training courses if they are aware of new teaching methods and can compare their outcomes. Hand hygiene practices used correctly can help to reduce microorganism cross-transmission, nosocomial infections, and the danger of occupational exposure to infectious illnesses. Direct patient contact, however, is not the only way for pathogens to spread. Bacteria can also be acquired on the hands of healthcare personnel by coming into contact with contaminated surface in the patient's surroundings. Thus, the importance for the knowledge of hand washing is very important for every individual and most importantly to the healthcare workers, as they are the ones who are susceptible to infections. The nursing course also underwent a transition from campus-based education to distant learning using digital tools because of COVID-19 pandemic. The year 2019 to 2020 was finished via online classes. Educators started finding new ways to make the students understand what they are teaching, like practicing different lighting and sound setups so that the students get the most out of the videos, having online hours to speak with the students, and many more. Thus, the purpose of finding out the effective method for teaching came into play, which serves as the need of the study. The objectives for my study: to develop and validate the tools to be used for online pre-recorded video. Sorry, I missed the problem statement. So I would want to state the problem statement. Effectiveness of learning through online mode, pre-recorded video, and traditional mode among first-year BSc Nursing students of Sikkim Manipal College of Nursing, Gangtok, Sikkim. So the objectives for my research study were to develop and validate the tools to be used for online, pre-recorded video, and traditional mode, to assess the baseline knowledge among all three groups of first-year BSc Nursing students before exposure to the learning. And third, fourth, and fifth objectives are to assess the effectiveness of online mode learning, pre-recorded video learning, and traditional mode learning among group 1, 2, and 3 among first-year BSc Nursing students. And the sixth objective was to compare the post-test knowledge score among all three groups of first-year BSc Nursing students. Hypothesis: all the hypothesis was tested at 0.05 level of significance. Hypothesis number 1. Here, there is a significant difference between the level of knowledge between pre-test and post-test score among the students. Hypothesis 2. There is a significant difference between online, pre-recorded video, and traditional mode of learning through among all three groups of students. Methodology: research approach was quantitative approach. Research design was pre-test, post-test study design. Research setting: the study was conducted in Sikkim Manipal College of Nursing. Population: in the study, the population consists of BSc Nursing students from Gangtok, Sikkim. Target population: in this research, the target population is BSc Nursing students of Sikkim Manipal College of Nursing. Accessible population: in this research, the accessible population is first-year BSc Nursing students of Sikkim Manipal College of Nursing who is available at the time of data collection. Sample size according to the calculation was 93 students, that is 31 each in all three experimental groups. Tools used were Tool 1, Section A, Demographic Socio-Demographic Profile. Tool 2, Section A, was Structured Knowledge Questionnaire. Plan for data collection: formal permission was taken from Principal SMCon, that is Sikkim Manipal College of Nursing, and respective class coordinator. According to the calculated sample size, the total number of samples were 93. After the noted suggestion of the respected experts and after careful consideration, the researcher was asked to take all the students in the selected classroom as sample size. Since the total number of the students in first year BSc Nursing was 97, the 2 students were not present at the time of data collection. The final sample size was 95. The sample was divided into 2 groups, that is 68 students who were hostelers and 27 students who were day scholars. Here, why I'm mentioning that is because there were restrictions about COVID-19. So the researcher was asked not to mix the hostelers and day scholars, and they were kept in 2 different classes priorly due to COVID-19 restrictions. So in order not to mix the hostelers with the day scholars, 27 students were selected for online mode learning and 34 students each were selected for pre-recorded video and traditional learning, respectively. Informed written consent was taken from the participants. Self-introduction, establishment of rapport with the participants was done to gain their cooperation. Assess the pretest knowledge on all three groups of the students through the structured knowledge questionnaire on hand washing. Provided intervention, that is, to each group of the students about hand washing using three forms of learning. Conducted a post-test comprised with a self-structured questionnaire related to the hand washing. The effectiveness was measured to the knowledge score. The score that was used for the measurement of the knowledge was 0. The scores are shown here, that is 0 to 5, it was rated poor, 6 to 11 moderate, and 12 to 16 was adequate. These are some of the pictures that this is the picture for video learning. I had prepared a video regarding hand washing, and it was validated by 7 experts. And then after the validation, I was allowed to present in the form of use this video as a method, as a tool. So on online mode, this is the picture. And this is for the traditional mode. Similarly, for the online mode, the PPT that I prepared was been validated by 7 experts from in and around the institute, that is outside the institute as well and inside the institute as well, regardless of my guides. The guides were excluded. And traditional mode, I had prepared the lesson plan that was also validated by 7 experts. Now, the analysis and interpretation of the data, descriptive statistics, frequency and percentage distribution, mean and standard deviation, inferential statistics contained pair t-test and ANOVA test. Findings, frequency and section 1 contains frequency and percentage distribution of demographic variables. Here we can clearly see that I've segregated it online, video and traditional. That is online containing N27 number of students, and video containing 34 and traditional 34. So here we can clearly see that 17 to 19 years of age were maximum in all 3 groups. In the religion, Hinduism was maximum in all 3 groups, and percentage aggregate in high school, 75% and above for the 2 groups, and 66 to 75% for 1 group, that is online. Now, occupation of the parent, most of the parents belong to a professional background. So income per month was 10,000 to 20,000 maximum in 1 group, and in the other 2 group was 20,000 to 30,000 maximum. So type of family, basically they were belonging maximum to the 85.3% to the nuclear family. Here, when we were assessing about the knowledge of the hand washing, some of the people, many of the people, that is majority, had prior knowledge about hand washing, but when they were asked about how they practiced hand washing properly or not, then the number of people reduced in the demographic performer, that is 88.2 in 1, 91.2 and 74 in 1. So here, the next, this one, the bar graph shows section 2. So in this bar diagram, we can see distribution of pre-test knowledge on hand washing among first-year BSc nursing students in online, pre-recorded video and traditional group. We can identify that 97.1% and 97.1%. We can see that video and traditional mode, they have maximum number, that is moderate knowledge about hand washing before the test. Before the intervention, So in the section 3, we can see distribution of post-test knowledge on hand washing among first-year BSc nursing students in online pre-recorded video and traditional group. So here in online mode, we can see 33.3%. In video, we can see 5.9%. And in traditional mode, we can see the amount raising, that is adequate. The moderate knowledge, minimum of the people have moderate knowledge, and maximum, it has been increased, the knowledge has been increased to adequate, that is 76.5 in traditional mode. And then
Divya, kindly wrap it up.
Yes,
The time is over.
So sorry. Yes, ma'am.
Kindly conclude, okay?
Okay. 94.1 in moderate, and then we can also see that 66.7, it is adequate now. Okay. So in section 4, we can see that the p-value is 0.001, that is less than 0.05 level of significance, and pre-test and post-test, we can see the mean standard deviation and mean difference. So here we can see in the next section also, we can see pre-test and post-test scores 0.001, that is less than 0.05 level of significance. And here in traditional group also, pre-test and post-test, when done separately, we can see that it has been tested at 0.001. The p-value is there, and it has been there that it is less than 0.005 level of significance. So when compared, we can see that the p-value is 0.001 and less than 0.05 level of significance. Here we can clearly see that the video knowledge has been increased. So in the when we compare the three on modes, that is compare the post-test knowledge on hand washing among first-year BSc nursing students in online pre-recorded video and traditional group, then the video is showing more effectiveness. So results, the present study attempts to find out the best learning method, which is learning through online mode, pre-recorded video and traditional mode, which among the three method is more effective. So out of all three methods of learning, all three methods, that is learning through online, pre-recorded and traditional mode, showed effectiveness, but when compared among three, then the more effectiveness was shown in pre-recorded video. So there were certain limitations in my study. I would quickly want to state that the study was confined to only first-year BSc nursing students of Sikkim Manipal College of Nursing. So it was limiting the generalization of the findings. The study was conducted with a purposive sampling technique, hence the generalization of the findings were limited. The study did not include other colleges of the institute. Recommendations also, based on findings of the present study, a comparative study can also be done to assess the effectiveness of learning through different modes in a larger population to find out more effective learning method. More newer and innovative approaches of learning can be included in the studies, and the study can be replicated on a larger sample of the students in different areas of Sikkim and India as well, and other countries as well. So conclusion, I think I've already cleared all the results. So these are the references, and thank you. Thank you so much, ma'am.
Thank you, Ms. Divya. Do we have any questions, ma'am?
Just one question, because you are comparing three different types of learning on online
Yes,
mode, pre-recording and the traditional mode, right? Because education is very difficult to control, because
yes,
if the others can access to pre-recording, and maybe the traditional type of learning, the student under the traditional type learning, they might have access to YouTube. There are a lot of online resources on YouTube and other form of from internet, internet learning, online learning. They might have exposed to that as well. So it's very difficult to say the outcome is based on the intervention. Okay, that's all from me. Thank you.
Ma'am, quickly, I would want to answer your question. Ma'am, actually, for this reason, the ethical committee of the institute, they decided that I would finish my research in one particular day, not giving the students exposure to any outside materials, so that after I give my pre-test, after 1 or 2 hours, I had to give post-test, ma'am. After the intervention, 1 or 2 hours, I had to give post-test. That is, my research was limiting only for 1 day. So I had to conclude everything in 1 day, ma'am.
Okay, thank you for your explanation. Do you think when a student are exposed to such few hours of teaching and 1 day, do you think it will be effective and it will be sustained for a longer period?
Yes, ma'am, that comes under my delimitation. Sorry, ma'am, limitations, ma'am. Sorry, ma'am.
Okay, thank you. Thank you. Yeah,
Thank you.
otherwise,
Thank you,
very
ma'am.
good presentation. Thank you.
Thank you so much, ma'am. Thank you.
Thank you, ma'am. I'd like to call upon our first presenter, Dr. Vijay Lakshmi. Dr. Vijay Lakshmi, kindly unmute yourself.
Good afternoon, ma'am.
Yes, ma'am. We can proceed.
Good afternoon, ma'am. Myself, Mrs. Vijayalakshmi Vannakamble. I have completed a PhD from the Himalayan University, Itanagar, India, in the year 2022. My statement of problem is a quasi-experimental study to assess the effectiveness of video assisting teaching program and knowledge and attitude regarding prevention and management of varicose veins among nursing officers working in ICUs of selected hospitals of Belagavi, Karnataka. Objectives of the studies are to determine the knowledge score of pre-test regarding the prevention of and management of varicose veins in the both experimental and control group. Second one is to determine the attitude regarding preventive measures and the management of varicose veins in nursing officers working in ICUs in experimental and the control group. To develop and administer video assisting teaching program regarding the prevention and management of varicose veins among nursing officers working in ICUs in experimental group. Next one, to evaluate the efficacy of video assisting teaching program regarding prevention and management of varicose veins among nursing officers working in ICUs. Next one, to determine the relationship between knowledge and attitude scores regarding prevention and management of varicose veins among nursing officers working in ICUs in experimental and control group. Next one, to find out the pre-test and the post-test scores of knowledge on varicose veins among nursing officers working in ICUs with selected socio-demographic variables. Introduction regarding the study. Nursing people or the nursing fraternity face a number of professional healthcare difficulties while performing their jobs, which can be classified as a biological difficulties, physiological or psychological stress. In among all the difficulties, varicose vein is one of the medical issues. Varicose vein constitutes one of the most common preventive disorders, which is connected to the veins. It is a very dangerous and threatens the life of the person, and it is a if suitable and effective treatments are not done. So varicose veins can cause wearing, the feet and discoloration. And the need for the study is, according to investigation findings, the
Dr. Vijayalakshmi?
Hello, ma'am.
Yes. Are you continuing with your presentation?
Yes, ma'am, continue. And these studies, I have added some of the review of literature. So I have made some of the categories in this. So first category is a review of incidence and the frequency of varicose veins among the medical professionals. So related to this is 21 studies I have added, and the overview of varicose veins, long-term complications. So 15 studies I have added. Next one is examine how well the informed and the prospective medical professionals are about varicose veins. Regarding the 16 studies I added, and evaluation of the impact of educational initiatives on students' understanding and attitude on varicose veins. 6 studies I added. These are some of the operational definitions, such as video assisting teaching and the knowledge, then attitude, prevention management, and the nursing officers. And some of the assumptions of these studies are: first one is nursing registered nurse professionals are a class at risk for the impact of varicose veins. And second one is nurses staff members are somewhat knowledgeable about the impact of varicose veins. And third one is the video assisted teaching program the best to develop the knowledge as well as the attitude among the managed and preventive varicose veins. And some of the hypotheses of these studies are, so nearly 6 hypotheses I have made, and the delimitation of these studies are the nurse research is delimited to the nursing workforce members, all of the whom are employed by certain institution in the Belagavi, Karnataka intensive care units. Second one is healthcare professionals among the ages between 23 to 45 years. And the concept framework I added here is King's goal attainment theory. This is a goal conceptual framework which I modified in this theory. That is a conceptual framework based on the modified Imogen King's goal attainment theory. So here is nurse investigator and the nursing officer communication. And the nurse investigator, she said that perception of the nurse investigator is nursing officers may have the some of the knowledge, and the judgment is so video assisted teaching is one of the best way to give the knowledge, and the nursing officer's perception is desire to acquire the knowledge, and the nursing officer judgment is ultimation to video assisted teaching program will help us to get the knowledge as well as the attitude. And the nursing investigator action is develop a structure knowledge questionnaire and the preparing the video teaching program. Now nursing officers action is nursing officers express their readiness to gain the knowledge and improve their attitude regarding the prevention of varicose veins. And the pre-test is through the questionnaire. I have given a pre-test with around 40 questions, and the interaction is so they have answered for that, and the transaction is at the post-test the result has come, and in the evaluation is adequate and the moderate gain in the knowledge and the attitude as also. So if the inadequate knowledge is there, then the feedback to the again communication between the nurse investigator and the nursing officer. And the research design is the post-experimental pre-test post-test design. Some of the variables, independent variable, dependent variable, and the sociodemographic variable I prepared. And the populations are, the population selected for the present study is nursing officers working at the critical care units. Sample and the sampling method is nursing officers working at the critical care units. The sampling technique is a non-probability purposive sampling technique. Inclusion criteria are the nursing officers who are working at the selected hospitals and who are willing to participate and who are available at the time of data collection, who able to read, understand, and Kannada in English. Exclusion criteria are the nursing officers who are not present during the time of data collection, who are working at managerial level, who are not able to understand Kannada and English, who are not meeting the inclusion criteria. So data collection techniques is through the self-structured questionnaire or the self-report. So in that 40 questions I prepared. In that I have made a part. Part 1 is a demographic profile. Part 2 is a structured knowledge questionnaire. And the next one is a scoring for the knowledge questionnaire. It will be lies between the poor, average, good categories I have made. So poor knowledge will be the answers are lies, the results will be lies between 0 to 10. Then the average knowledge is lies between the 11 to 20, and the good knowledge is lies between the 21 to 30. And the third part is structured attitude scale. This is prepared by the investigator. And in this also made categories for the data analysis. That is if the results or attitude scale is lies between the 16 to 36 is non-favorable attitude, 37 to 58 means favorable attitude, and the 59 to 80 means that is a positive attitude. The reliability of the tool is R equal to 0.82 and 0.83 respectively. So pilot study I have conducted, that is a 1/10 of the main studies, and the data collection I have collected between the in the year 20 January to the 21 to the 30th January 2021. So many problems I have faced.
Try to wrap it up with the conclusion.
Yes, yes, ma'am. Conclusion of the study is here the investigation was to be evaluate the impact of a video assisted teaching program on healthcare officers on a duty in the intensive care units of a particular situation in the Belagavi's attitude and the knowledge towards the varicose vein treatment and the avoidance. And the summary of the study is the article has effectively summarized in the research, that is, this section means the body distilled philosophy and provided a quick summary of the significant research findings and the recommendation for the professional nursing on nursing education, healthcare organization, and the registered nurse and the challenges. So future scope is on the nursing impact, nursing practice, then the nursing education, nursing administration, nursing research, and this is the references.
Thank you very much, Dr. Vijaya, for your presentation. This is a very comprehensive study, but I'm not too sure because is this study is on student nurses or staff nurses?
Pardon, ma'am? Study is
your study sample is on student nurses or registered nurse?
Registered nurses.
Because along your presentation, sometimes you give me the impression it's student nurse, sometimes it's a staff nurse. So it's a staff nurses, is it? It's a registered nurse.
No.
Yeah. Can we be because because not very clear.
From the
okay, it's okay. Yeah. Because the sound not so clear from your side, I can't really listen to your content. But just to clarify whether it is for staff nurses or student nurses.
Registered nurses who are working in the intensive care units.
Okay, right. Okay, right. So you do have control group.
Yeah, ma'am. We have the control.
All right. Okay, that's all. Thank you. Okay, thank you.
Okay. Thank you.
Thank you, ma'am. We'll move on with the next presenter. I'd like to call Pabalpreet Kaur from University College of Nursing, Baba Farid University of Health Sciences, India, for a oral presentation.
Good afternoon, ma'am.
Yes, ma'am. Good afternoon.
Ma'am, my PPTs are visible?
Yes, ma'am. It is visible.
Okay. Good afternoon, ma'am. Myself, Pabalpreet Kaur. I'm working as nursing tutor at University College of Nursing.
Ms. Pabalpreet? Ms. Pabalpreet, can you hear me? Ms. Pabalpreet? I hope you're facing some issue with the presentation. Your video is also stuck. We could not hear you. Okay, fine. Then we move on with the next presenter, Ms. Dipti Shubha from Purmanchal University School of Health Sciences, Nepal, for an oral presentation. Ms. Dipti? Ms. Dipti, are you there?
Hello. Hello.
Yes.
Yes. Can you hear me?
Yes, I can hear you. Yes, I can hear you. You can start with your presentation. Yes, we can see your slide.
Good afternoon and namaste. Greetings from Nepal. I'm Dipti Shubha. I'm currently working as a lecturer in Purvanchal University School of Health Sciences, that is situated in Province 1 of Nepal. The study title that I'm going to present is on perception of academic incivility. Among nursing colleges of Province 1 in Nepal. Coming to the background, academic instability in nursing education is communication in any form that can disrupt the harmony of the teaching learning environment. Academic instability can occur in both ways to the fact among the faculties and as well as to
Sorry,
the
your slide is not moving.
Hello. Hello. Am I audible?
Hello, yes.
Okay, thank you. Okay, so the faculty-induced instabilities can be exerting superiority to
Miss
setting
Dipti, your slide is not
students
moving.
and not allowing for the open discussions and so on. And because of the instability by nursing faculty, the students might have also complained of stress, anxiety, exhaustion, and sleeplessness, depression, anger, and so on. So the need for this study in this subject is that instability in nursing education is a silent, unnoticed, challenging, escalating problems, which is very difficult to address and may have negative consequences on both the faculties and the students. Many studies have also highlighted that the various outcomes as a consequences of instability can lead to low self-confidence of the students and negative attitudes towards the nursing profession as a career, lack of interest, and lack of interest during the communication effort. On the other hand, faculties have also encountered sleep disruptions and lack of confidence in the teaching ability and the decreased of self-esteem. So the objectives of the study was to find out the demographic variables of the faculty and students, to find out the perception of faculty and students on academic incivility, and to correlate the perception of faculty and students on academic incivility at nursing colleges of Province 1. So these are the operational definitions that I have defined in my studies. The main thing that I want to highlight here is the nursing program that I have chosen, both PVNS nursing and BSc nursing students, and the nursing colleges that I have chosen is the only constitute and affiliated college under Purvanchal University, and the nursing students, those who were studying in second year of BSc and PVNS. Now, coming to the methodology, a mixed method was used. Cross-sectional research design was employed, and for the setting of the study, nursing colleges of Province 1, target population was faculty and students of nursing colleges. Sampling technique, non-probability process sampling technique was used for the sample nursing faculties, and second year of UG nursing students were chosen. And although I have employed the census method, and the questionnaire was distributed to 159 students and 25 faculties. That would be altogether 184 participants, but only 153 total respondents have written the survey. Now coming to the criteria, the inclusion criteria was nursing faculty who were teaching second year students and students of second year undergraduate nursing program. For the exclusion, those who were not willing to participate in the studies had been excluded. Now, coming to the variables, for the faculties and student independent variables were different, whereas for the students second year of nursing program, the marital status and family type were chosen, and for faculties program, marital status, total year of experience, and the total of experience in that current organization, nature of the job, which means that whether they have been given other responsibilities as well or not, and coming to part-time or full-time job they are doing. And the dependent variable was to incivility in nursing education. For the tools and techniques, the incivility in nursing education survey INE tool was chosen, that was developed by Dr. Cynthia Clark. A written permission was obtained, and the INE survey has 3 sections. So section 1 described about the demographic questions. Section 2 was further divided into 2 subsections, that is behavior that are potentially uncivil and behavior that are known to be threatening. In the third section, it has 4 open-ended questions, which were considered as open-ended questions or qualitative data. And the tool was valid and reliable, as the inter-item coefficient ranged from 0.808 to 0.889 for student behavior, and for faculty 0.918 to 0.955. And the ethical clearance, institutional review board from Purvanchal University School of Health Sciences was obtained, and the permission was taken from the colleges, and also written and verbal both consent was taken from the teachers and students as well. The survey was distributed to the nursing faculty and the students at the same time on the same day, so to prevent from the contamination of the data. For the analysis of the data, Sapilo-Wilk statistic was performed to check the normality, and descriptive statistics was used to summarize the participant perception of nursing faculty and student incivility, whereas the independent samples like t-test and chi-square test were also used to find out the differences. The data was not normally distributed, so manually U test was also performed. Now coming to the okay. So coming to the findings, the students selected the demographic characteristics revealed that there were 63, a majority of the students were from post-basic Bachelor of Nursing Science. Majority of them were unmarried, and they were from single family background. So the second table describes about the frequency distribution of nursing students on the perception on faculty incivility, and I have only I mentioned some of the items and or the behaviors which are considered highly incivil by the students above 50. So punishing the entire class for one student's misbehavior, unfair grading, making discriminating comments, threat of physical harm against others, property damage, making threatening statements about weapons were the nursing students' perception on faculty incivility. So second, these were the behavior that has been perceived by the nursing students, often, rarely, sometimes, and never. These are also some of the behaviors that I have highlighted, which accounts for majority of the percentage. So now coming to the severity and intensity of the incivility that has been perceived by the students. Most of the students have perceived that incivility in nursing education is mild problem, and they have also perceived that incivility is about equal among the students and faculties. So, so this table shows the relationship between demographic variables and incivility, where you can see that with the program only there was positive association found. Now coming to the distribution of faculties and selected demographic characteristics, most of the faculties were teaching both the programs, and only 19 of the faculties responded to the survey, and most of the faculties have less than 5 years of experience, and they were working in the current organization for 1 to 5 years. Coming to the distribution of faculty perception and student incivility, when faculties have identified two behaviors: demanding a passing grade when a pass grading has not been earned, and making threatening statement about weapons.
Kindly try to wrap it up with your conclusion.
Okay, thank you, ma'am. Similarly, faculties have also identified that incivility is a mild problem, and when both were asked to rate the incivility in a rating scale, students have rated minimum 5, maximum 100, whereas faculty have rated minimum 10 to maximum 90. Coming to the summary, most of the faculties and 36.6% of the students mentioned that incivility is a mild problem, and 59.9% have reported that incivility is about equal among nursing students, but faculties perceive that students are a little more likely to be incivil in nature. The highest mean score of nursing students' perception of faculty incivility is on cancelling classes by the faculties or other scheduled activities without the warning. Similarly, the mean score of nursing faculty perception on student incivility was cheating on exams, and there was no difference. There was a difference in incivility among students, but no difference was found among the faculties. Item analysis of the questionnaire ICC was 0.97 and Tondax alpha was 0.97. And similarly, when the students were asked about the strategies, then they have agreed that the reward civility and professionalism on both groups, and they have also agreed that discrimination should be avoided, and lack of experienced teacher and communication were also identified by the students. Majority of faculties perceived as highly uncivil behavior of the students are demanding a passing grade, and from the faculty perspectives, they have suggested that improving the level of civility in nursing education is to establish code of conduct that define acceptable and unacceptable behavior, and to reward civility and professionalism. Furthermore, coming to the conclusion, incivility in nursing education is an alarming issue which requires an immediate action. Nursing faculties are responsible and expected in maintaining the conducive learning atmosphere and academically shaping the behavior of the students. And also it is of paramount importance that the faculty should set good examples of civility and a well-cultured academic environment. Thank you.
Thank you, Ms. Dipti. Do we have any questions, Dr. Chan?
No question, because basically the slide never moved at all. I'm at the first slide. Can you hear me?
Okay, is Dr. Chong?
Yeah. Can you hear me?
We'll move on with the next presenter. Thank you, Dipti.
Okay, yes. Thank you.
Okay, thank you, ma'am.
I'll call upon Pabalpreet Kaur from University College of Nursing, Baba Farid University, for her oral presentation.
मेरो स्लाइड देखेन भन्छ त.
Hello.
Yes, Pabalpreet, we can hear you.
Ma'am, my PPTs are visible?
No.
Okay, ma'am.
Are you sharing your screen?
Yes, ma'am, I'm sharing, ma'am. Please give me some time. Just 2 minutes, ma'am.
Yes.
Ma'am, is my PPTs are visible?
Yes, yes, it is.
Okay, good afternoon, everyone. So my problem statement is a study to assess the prevalence and determinants of malnutrition among under 5 children residing in selected community of district Ambala, Haryana. Background and introduction: under 5 children constitute the most vulnerable segment of community. They are prone for various health issues such as diarrhea, pneumonia, malnutrition, which may ultimately lead to childhood mortality. Under the flagship of Sustainable Development Goal, it was aimed to bring down the under 5 mortality as low as 25 per 1,000 live birth. And in India, as per National Family Health Survey 5, 2019 to 2021, the mortality rate among under 5 was recorded at 41.9%. Malnutrition is one of the major risk factors towards mortality and morbidity among under 5 children. And as per the National Family Health Survey 2019 to 21, 32.1% children below 5 years are underweight, 35.5% are stunted, and 19.3% are wasted in the country. Malnutrition affects the child's ability to grow normally. It makes child more susceptible for infectious diseases by affecting the immune system. It delays the physical, intellectual, cognitive, as well as psychomotor growth of a child. So various factors such as birth weight, exclusive breastfeeding, timely initiation of complementary feedings can affect the growth and development of child. According to WHO, breastfeeding should be initiated within half an hour in normal vaginal delivery and within 2 hours in cesarean section. And as per infant and young child feeding practices, complementary feeding should be initiated after completion of 6 months along with breastfeeding up to 2 years. So the objectives for my study was to identify the malnourished children in the selected community and to identify the determinants of malnutrition in the selected community. So I have selected qualitative approach with descriptive research design. Setting of the study was village Gola and Adhoya in Ambala district of Haryana. Assessable population was children 1 to 5 years and their mother residing in the selected villages. And the sampling technique was total enumeration sampling technique and sample size was 446. Ethical considerations for the prior permission was faculty of nursing and informed written consent was taken from the subject and data was collected by home to home survey from September 2020 to May 2021. Tool and technique. Interview schedule was used to collect socio-demographic data of child and mothers of under 5 children. Assessment of the anthropometric measurement, which include weight, height, mid-upper arm circumference, chest and head circumference were done with the help of weighing scale and tape. And nutritional status of the child was assessed through weight for age chart, which is given by WHO and currently used in Anganwadis of India. Immunization status of the child was checked with the maternal and child protection card, which was taken from the mother during the time of data collection. So the table 1 shows the socio-demographic profile of under 5. So let's know how that is in the age group of 1 to 3 years, whereas 61% were male and only 39% were females. Most of the under 5 in the study, that is 74% was immunized, and in the nutritional status, more than half, that is 52% of the children were having normal nutritional status, whereas 48% were found to be malnourished. And in the exclusive breastfeeding, more of the birth till the 6 month in the birth weight, 44% of the birth weight of the under 5 were between 2.5 to 3.5 kg, and 43% of the children were initiated with the complementary feeding at 6 months. So as I have already told that in the nutritional status, 40% were malnourished, 52% was normal. The table 2 demographic profile of mother of under 5 children, and in this 35% of mothers were in the age group of 25 to 28 years. 27% of mother was having high school qualification. Most of the mother, that is 83%, were housewife, whereas 33% of mothers were belonging from middle class family. And this table shows the socio-demographic relationship of the child with the nutritional status. And in the study, we have found that the age of the child, gender of the child, immunization status, and the exclusive breastfeeding, birth weight, and the timing of starting complementary feeding was significantly, highly significant relationship with the nutritional status of the under 5 children. And table 4 shows the chi-square showing association of nutritional status of demographic characteristics of mother with the under 5 children. And in this, the age of the mother, educational status, and the socioeconomic status of the mother were found to be significantly associated with the nutritional status of the child, whereas occupation of the mother was not having any relationship with the nutritional status of the child. So in the discussion, in the present study, age of child, gender, birth weight, immunization status, exclusive breastfeeding, and time of initiation of complementary feeding was found to be significantly associated with nutritional status of under 5 children. The result of the present study was found to be consistent with the study conducted in urban and rural areas of Maharashtra, India. According to infant and feeding practices, the ideal time to start complementary feeding is at 6 months. Early or late initiation of complementary feeding put a child at a risk of malnutrition. So in current study, timing of initiation of complementary feeding is also one of the major determinant of undernutrition among under 5 children. And this result is consistent with the study conducted in Chandigarh among under 5 children. It was well known that socioeconomic status is one of the important determinant of the well-being of the child and health. Lower the socioeconomic status, higher is the risk of undernutrition. A supportive study done in India reveals that families with low economic status have a significant association with undernutrition. Another important factor affecting underweight was maternal education. Mother is universally first care for the child, and hence mother's education matter. Educated mothers are more aware of health services available. It was observed that low maternal education was a risk factor for undernutrition among under 5 children in present study. Maternal education is significantly associated with nutritional status of the child, and this finding was in line with other studies. And in conclusion, on the basis of the result of the study, it was recommended that the children having malnutrition should be identified in the community, and feeding practices should be assessed time to time for identifying the major cause contributing to malnutrition. Community health nurses and other health professionals working in community should be educate, motivate, and reinforce the mothers of under 5 children for giving exclusive breastfeeding, timely initiation of complementary food, and some strategies to combat malnutrition should be made at local level. And these strategies can be used by nurses and other health professionals working in community. And these all are my references. Thank you so much.
Thank you, Ms. Babelpreet. Dr. Chong, do we have any questions?
Yeah, thank you.
Dr. Chong?
No question for me, Miss
Okay.
Sumita.
Okay.
I think we have to move on because it's going to be 4 hours from we started this session.
Sure. We'll move on with the next presenter. I'd like to call Vitika Devnath from Nurses Training Institute, Tripura, India, for her oral presentation. Vitika? You can start with your presentation. We can't hear you. The presentations are going on flow. The presenters kindly wait for your turn. Ms. Datta, are you facing any issue? Can we move on to the next presenter? Already we are running short of time. We can see your slide. We're not able to hear anything from you. Okay, we are moving with the next presenter. Kindly stop sharing your screen, Datta. Can you hear me? Kindly respond or anything. Ms. Datta, can you hear me? Dr. Chong, am I audible?
Yes, I can hear you, but not Miss Bitika.
Ms. Datta, can you hear me?
So challenging.
I thought I am not audible. Sorry, Bitika, we could not hear you.
Miss Bitika, can you hear me? Am I audible to you? You can't hear me too.
Oh my God. Ms. Datta?
Maybe we'll move on to another presenter.
Yes, Ms. Datta, we are moving on with the next presenter. I hope this also she is not hearing. We'll move on with the next presenter. Sorry for that. I'd like to call Noor Asia from School of Mathematics and Applied Science, Sriyakola University, Indonesia, for an oral presentation.
Okay, good afternoon, ma'am. Thank you very much. Can you hear me?
Yes, I can hear you.
Okay, good afternoon.
Good afternoon.
Ma'am.
I think so. It is good evening in Indonesia.
Okay, good evening. Yeah, good evening, Indonesia. Nice to meet you all. I'm from Aceh, Indonesia. Okay, may I share screen? Can you see my share screen?
Yes, we can see your screen.
Okay.
Can you try changing your screen?
Yeah. Yeah. Okay. Is it okay? Can you see my screen?
Yes, I can see your first slide.
Yes. Okay.
Can we try changing the slide so that there is no stocking this slide?
Okay. Okay, I will present my, sorry.
Yes, now we can see your slide changing.
Okay.
Now we can proceed. Yes.
Okay. Thank you very much. I will present my article about adolescent understanding breast cancer early detection, a literature review. As we know that breast cancer is a disease in which normal cells develop into bad cells and grow of control in breast tissue. Nowadays, breast cancer has become one of global health problems and leading cause of death for women worldwide. From data in Global Chan 2020, we can see that breast cancer is the most cases in the cancer in the world. The data from American Cancer Society 2022, we can see that breast cancer has estimated new cases about 400,000 cases in the world. From the data from the Ministry of Health in Indonesia show that breast cancer is the first cancer in Indonesia that leading cause of the death for women in Indonesia. The incidence of breast cancer occurs in women in their middle years and older tend to develop breast cancer. The average age of breast cancer diagnosis is 62 years old. This indicates that when breast cancer is discovered, half of the women who get it are 62 years of age or younger. According to the American Cancer Society 2022, a small percentage of women with breast cancer are under 45 years old and at least at 25 years old. The prevalence of breast cancer in adolescents is determined by the fact that while it typically develops in people who are older, it can also do so in some circumstances, including in teenagers. Adolescent understanding about breast cancer is good, but adolescent understanding about the factors and early detection of breast cancer is not good in Indonesia and outside countries, especially developing countries. The method of this article is literature review. The source of data is from international and national articles. It's included from PubMed, Simago, Elsevier, national article from media published by Google Scholar. And I use prism flow diagrams we used to select and sort the 126 articles collected, resulting in a total of 15 papers being reviewed. The result, the 15 result publication that match the defined criteria, including the inclusion criteria connected to teenagers' awareness about early diagnosis of breast cancer, have been chosen for this literature review preparation. Studies on adolescent awareness of early breast cancer detection include from the research of Abo, Al-Sheikh et al., Rahman et al., Sabah et al., Dinesh et al., Istiak et al., Jos et al., Juarez Garcia et al. From the 15 publication and description of teenage knowledge will be explored. The knowledge-related topics are about the research article. Under review is first knowledge of breast cancer, second knowledge of breast cancer risk factor and or symptoms, third knowledge of breast cancer early detection, which focuses on breast self-examination or BSE. The result of the 15 articles that were reviewed regarding the knowledge of whether or not they have heard the breast cancer or are obtained in the in-person basis. Especially between 50% and 85.5% of teenagers have heard of breast cancer, and information which is primarily obtained through social media and a little bit from television and school bench. This proportion demonstrates that many people have at least casually heard about breast cancer. The finding of in terms of percentage show that between 30% and 14% were aware of the risk factor and sign and symptom of breast cancer, according to data gathered from 3 articles. Since teenagers are uninterested in researching health topics online and believe that this cancer only affects in women, there's a lack of knowledge in this area, which result in apathy toward learning more about anything pertaining to this cancer. Most young individuals generally are not interested in learning more about any condition, including breast cancer. In the table below, different percentage result that knowledge challenges and the practice of BSE, the self-examination in adolescent is show bad knowledge and adolescent about early detection of cancer on 15 practical analysis. Based on ever heard of it or not awareness, the percentage of people who have knowledge about breast self-examination is rated as bad, good, or average. Because of how little is heard and understood about breast self-examination, it is considered common knowledge. The percentage of teens who refrain from practicing breast self-examination while having information in this is determined by the reason given by those teens. The causes include a lack of knowledge of the process, a lack of time for performing breast self-examination, and lack of will to act. The discussion, breast cancer understanding among adolescents. The general level of awareness about breast cancer in adolescent was evaluated from several articles. However, in none of the 15 articles did the knowledge go below 50% less, between 68.7% and 99% of adolescents have some knowledge of breast cancer. This indicates that a large number of youngers can quickly define breast cancer. The development of the time has led to a lot of information being contained on social media, and social media is where most people learn about breast cancer, followed by television, radio, magazines, and newspapers. Discussion, the second is understanding of breast cancer risk factors and or symptoms. According to 3 studies from Rahman et al., Didej et al., and Tiak et al., it was discovered that 26.6, 38.4% and 5% and 38% of people had pure knowledge of breast cancer risk factors and symptoms. This is only known to teenagers who major in medicine and nursing. Teens are not interested in learning more about breast cancer, therefore only a limited amount of information is obtained from social media. Boring and interesting content causes teens to defer to amusement instead of learning more, which contributes to this low knowledge. Because it is stigmatized, it is strange to learn more about breast cancer. Next, teens' awareness of breast cancer early detection. Teenagers may assume that the category of adequate based on the 15 articles reviewed about early detection of breast cancer that leads to breast self-examination, as there are only 6 articles of 15 whose general knowledge is below 15%, denoting less or bad. However, the practice of breast self-examination, which is not commonly understood about the proper technique and the right time, is affected by the knowledge that they have just heard about without additional in-depth study or finding out more. And next, only one of 15 publications that were reviewed by Juwita and Prabhasari had strong knowledge and high level of practice, as opposed to the other 14 which had good knowledge but pure breast self-examination practice. The theory is inversely proportionate to practice apart. The finding of research on the gap between theory and practice, which is frequently widely disseminated and become an open secret for everyone, in line with the actual state of affairs. Kurniawan, 2020. Adolescent understanding of early detection of breast cancer is low due to interest in information that is influenced by education, environment, and geographic location, as well as experiences that affect adolescent lack of understanding. That one reason why they realized they had not done it, namely not known how and when to do it, not having the time, having the wrong stigma against breast cancer, forgetfulness, and feeling that they had no problem with the health of the two adolescent breast cancer. This, the conclusion, due to three factors: education, environment, and geographic location, as we experience knowledge about breast cancer, knowledge and practice of early detection of breast cancer, and risk factor, sign and symptom of breast cancer are currently in the pure and pure categories both in Asia and abroad. While the reason why adolescents don't practice early detection of breast cancer, despite having knowledge in theory, are because they don't know how and when to do it. Like time, they believe that they have no problem with their breast and are stigmatized for having received inaccurate information about breast cancer up until they finally found the correct information provided by health professionals when conducting direct education to adolescents. Recommendation: it is suggested that health workers work together with the government to disseminate information more evenly and go directly to school on a regular basis to educate on early detection of breast cancer rather than just through in social media. Okay, thank you very much.
Thank you very much.
Thank you, Ms. Noor. Any questions, Dr. Shah?
Okay, just one question. Thank you very much, Ms. Noor Asia, Madam Noor Asia, for your presentation. It's a very comprehensive literature review. May I know what type of literature review you are using for your review? What type of literature review?
Excuse me.
May I know what type of literature review you are employing for your search?
Hello?
She's asking what type of literature review you are using. Literature review. Review of literature. Review of literature, she's asking.
Literature review?
Yes, exactly.
Doesn't matter. We move on to another one. It's okay. Miss Sumita, maybe we move on. Yeah. It's okay. Yeah. Thank you. Miss Sumita, maybe we move on to another presenter.
Yes, ma'am. We'll move on with the next presenter. Thank you, Ms. Noor Asia. I'll move on to the next presenter, Monica Devi from Government AMT School, GMCH, Jammu, UT, India, for her oral presentation. Ms. Monica, are you there? Okay, I hope she's not in the room. I'll move on to the next presenter. I would like to call Ms. Vani R. from Sri Devaraj URS Academy of Higher Education and Research Medical College, India, for her oral presentation.
Good afternoon, madam.
Yes, ma'am.
Madam.
We can hear you. Yes, ma'am.
Yes, ma'am.
Hi, good afternoon. Yeah.
Yes. Good afternoon to all the organizers, delegates, and especially Shushmita, madam. To present with my study, I am Miss Vani. Is it visible, madam? Slides?
Yes, the slides are visible.
Yes, madam. Thank you. So I am Mrs. Vani. I'm working as an assistant professor and a PhD scholar under the guidance of Dr. Zeenat Karina, madam. And the title of my study, it is Impact of Multimodal Intervention on Quality of Life of Geriatric Clients regarding health promotional outcomes at selected hospitals, Kolar, Karnataka, India. As we all know that aging people or the elderly is one of the vulnerable population and they have been neglected So aging is a natural phenomenon with lots of opportunities and also with the challenges, which cannot be prevented, but it can be learned we can learn how to deal with the arising conditions to achieve the greater health among the geriatric and to lead a healthy life, to enhance the highest quality of life among the elderly, to have the good health, dignity, economic independence, and find a peaceful death. As we all know that as per the WHO UN standards, it has been declared as International Day for Elderly. It is celebrated every year on 1st of October. And the theme for the 2022, as we are waiting for the 2023, so the theme for it is resilience of older persons in a changing world. And the lacuna of study, which I have felt as a researcher, as per the WHO report, it has been said that between 15 to 2050, the population of 60 years will nearly double from 12 to 22%, and 20 to 50 in 2050, we can expect 80% of older people will be in low and middle income countries. So India's elderly population is projected to touch 194 million in 2031 from 138 million, which was there in 2021, as per National Statistical Office elderly. So we have seen as a researcher, as I was doing the literature review, most of the researchers was lacking in the interventions which is focusing on holistic health promotional outcomes among geriatric clients. Hence, the investigator felt the need to promote the holistic health promotion outcomes by creating a multimodal intervention which was prepared by the researcher, where in order to enhance the quality of life among the geriatric clients, to create an opportunity to foster healthy aging. The objectives of the study are to assess the quality of life regarding health promotional outcomes among geriatric clients by using the WHO quality of life standardized scale, and to evaluate the effectiveness of multimodal intervention on quality of life, and to determine the association of quality of life scores on health promotional outcomes with the selected demographical variables of the geriatric clients. And the hypothesis of my study are there will be a statistical significant difference in mean pre-test and post-test scores of quality of life among geriatric clients between the experimental and control group. Among geriatric clients on health promotional outcomes, there will be a statistical significant association between the quality of life scores with the selected demographic variables of geriatric clients. Coming to the research methodology, the approach which was used for the study, it is quantitative approach, and the design which is used is a quasi-experimental interventional control study with pre-test, post-test design and the follow-up study. The area which is selected for the study setting, it is IPDs at RL Jalapa Hospital and District SNR Hospital, Government Hospital setting at Kolar. The study population comprises of geriatric clients, which was selected as a two groups, where an experimental group consists of 60 and a control group consists of 60. And the tools which was used, it is socio-demographic proforma containing 10 items, and the biophysiological parameters of nutritional status, visual acuity, hearing acuity, bowel and bladder pattern, about their physical activity, all those things which consists of 10 items. And the main assessment of quality of life, which is used by the WHO standardized questionnaire, and all these tools which has been validated and the reliability found to be highly reliable. Firstly, the researcher provided the pretest to the experimental group in the RL Jalapa Hospital and the control group which was given in the SNR Hospital, where pretest has been given to the experimental group and followed by the multimodal intervention. As it is mentioned, it's not only a single intervention which is given to the experimental group. It consists of a multi-modes which consist of educational PowerPoint video presentation, which emphasizing on the holistic health promotion measures which they have to take up, and an informational pamphlet, and one more, it is snake and ladder game which was been built by the or created by the investigator to have a learning through play to the experimental group, whereas the control group received the routine care. And post-test 1, which was conducted at the first month and the 30th day of the intervention, and then second post-test, which was conducted on the 60th day, where data was analyzed by using the descriptive and inferential statistics by using the chi-square, frequency percentage, mean, standard deviation, repeated measures of ANOVA, Bonferroni, post-hoc test was used, independent t-test, and then paired t-test, and the chi-square values was found and correlation was been calculated. These are the statistics test which was being used by the researcher. And coming to the objective of 1, to assess the quality of life, by seeing this graph where it is depicting the quality of life of geriatric clients in the experimental group, where we can see the percentage in the pre-test, it is poor. During the pre-test, it was shown to be poor. It is 35%. And later on, after the intervention provided by the researcher, the multimodal intervention, it has been proven to be effective. By seeing the statistics, it has been later on increased to 63%, and highest quality of life has been experienced in the experimental group with 37% and 42% in the post-test 2, which was calculated at the second month. Whereas in the control group, where you can see the poor high quality of life and the moderate quality of life, it remains the same, as they have received only the routine care. And coming to the raw facet scores and transform facet scores of the quality of life has been calculated by using the WHO scoring interpretation, which was done, where sensory abilities, autonomy, past, present, and future, and social participation, death and dying, and intimacy. These are the areas or the domains which was been covered. You can see that the transformed facet scores in the experimental group, which keeps on increasing from pre-test to post-test 1, post-test 1 to post-test 2 in the experimental group. That is from mean of 27.18 to 59.47, then 57.18. Whereas in the control group, it's not the same, like it has been increased. It's not increased, it remains the same without any change. And the mean scores or the transformed facet scores in the control group. And while comparing the overall mean and standard deviation of the quality of life and health promotional outcomes among geriatric clients between an experimental and control group during the pre-test, post-test 1 and post-test 2, where we can also see there is a significant linear line which can be seen in the experimental group, where it keeps on increasing in the experimental group from 54.5 mean to 73.9, and whereas during the post-test 2, it has been increased to 78.2. Whereas in the control group, where we can see the mean of 55.6, 55.7, and 51.2. It doesn't change in the control group. It is not changed. And also we can see there is a linear increasing line in the experimental group, which proven to be an effective intervention which was developed by the researcher. Hence the hypothesis 1, it has been accepted. And coming to the repeated measures of ANOVA, which has been calculated, as the researcher has done the repeated test in the 3 tests which has been done, pre-test and post-test 1 and post-test 2. Here also there was a significant increase in the mean scores of experimental group from 54.76, 74.15 and 77.71. Whereas in the control group, it is not changed, as it remains 55.85, 55.46 and 52.31. And the Bonferroni post-hoc test also was used to do the multiple comparisons of groups at same time in order to determine exactly where the differences has been felt between the time interval and the groups, which found to be significant in the experimental group, which has been statistically significant at 0.005 with a p-value of 0.005 at 95% of the confidence interval. Coming to the distribution of association between the post-test quality of life of geriatric clients with the socio-demographic variables. Yes, ma'am.
Try to wrap it up with the conclusion.
Yes, ma'am. Yes, ma'am. Another 2 minutes, ma'am. With regard to the association, it's found that An experimental group which found to be chi-square value, it is found to be significant with the age and educational status, whereas in the control group, we can see that it's been found to be significant with the socioeconomic status of in the control group. With this, the correlation found to be significant, positive correlation was found in the experimental group, and moderately negative correlation was found in the control group. This is the graph which is representing the perfect positive correlation in the control group and moderately negative correlation in the control group. And what is the outcome of my project, and I wanted to conclude, is geriatric group became the biggest beneficiary with my MMI intervention, that is multimodal intervention package, and needs more emphasis on the geriatric research projects, and also to incorporate exclusively geriatric wards in all the specialty hospitals. When I was collecting the data, where I can see that only the persons with the geriatric clients, they have to wait for longer periods of time, and they have to take appointments, and they don't have the separate geriatric wards to get the specialized cares. So I felt that it is needed to incorporate the exclusive geriatric wards in all the hospital, and to focus on health schemes and pension schemes, especially for the geriatric age group. These are the references of my study, and these are the interventions which are developed by the researcher. This is the game of snake and ladder health promotional strategies, which is focusing. And this is the glimpses of data collection and the training, which is given to the participants. Multimodal intervention. Thank you. With this, I wanted to conclude. Seniors are the ones who bring out this best in you, not the stress in you. So I thank all the organizers for giving me an opportunity. Thank you, madam.
Thank you, ma'am. Dr. Chong, any questions, or we can move on with the next presenter?
Yeah, congratulations to Wani. Yeah, a very comprehensive study, and all the research methodology are very sound. And thank you.
Thank you, ma'am.
We'll move on with our next presenter. Do we have Sunita here? Are you ready with your presentation? This would be the last call. Sunita?
Ma'am, can I hear you?
Yes, I can hear you.
Okay, ma'am.
Kindly start with your presentation.
Yes, ma'am, I will start.
Yes, I can see your presentation. Kindly proceed with the same.
Okay. Can you see, ma'am, my presentation?
Yes, I can.
Okay, good afternoon, everybody. I am Sunita, a lecturer, Caritas College of Nursing, Kottayam, Kerala. A problem statement of my study, pardon me, excuse me. A study to assess the effect of planned preoperative nursing instructional package on short-term postoperative outcome and selected postoperative behaviors among patients undergoing hysterectomy in a selected hospital, Kottayam. As an introduction of my study, women's health is an integral part of overall health system of any country. It is well said that the hands that rock the cradle rule the world. Women experience unique health issues and conditions from pregnancy and menopause to gynecological conditions. For that, hysterectomy operation is one of the major kinds of surgical treatments in gynecology and is helpful to save lives of women. So, preoperative teaching is an effective way of communicating information which aid in relief from postoperative problems, quick recovery, and improve fitness. The need of my study is according to the study conducted by Daniel L. Clark, Pearson, Elizabeth J. Geller in 2013. Infectious complications of hysterectomy are ranging from 10.5% for abdominal hysterectomy to 13.0% for vaginal hysterectomy and 9% for laparoscopic hysterectomy. So, if preoperative education readily and effectively enables patients to cope with their surgery, reduce the duration of hospitalization, elevates satisfaction, and minimizes post-surgical complication. Objectives of my study, first one is evaluate the effect of planned preoperative nursing instructional package on short-term postoperative outcome among patients undergoing hysterectomy. Second one, determine the effect of planned preoperative nursing instructional package on selected postoperative behaviors among patients undergoing hysterectomy. Last one, find the association between selected short-term postoperative outcome and selected postoperative behaviors with the selected socio-demographic and clinical variables. Hypothesis of my study is first one is there is significant difference in short-term postoperative outcome among patients undergoing hysterectomy in experimental and control group. There is significant difference in selected postoperative behaviors among patients undergoing hysterectomy in experimental and control group. Next one, there is significant association between selected short-term postoperative outcome and selected socio-demographic and clinical variables. Last one is there is significant association between selected postoperative behaviors and selected socio-demographic and clinical variables. My research methodology is quantitative quasi-experimental approach and quasi-experimental non-equivalent control group Kottayam population patient undergoing hysterectomy. An independent variable planned preoperative nursing instructional package, dependent variable short-term postoperative outcome and selected postoperative behaviors. As a sample 60, 13 experimental and 13 control group. Sampling technique, non-probability convenient sampling. And sampling criteria and inclusion, patients who have undergone abdominal hysterectomy and who are willing to participate in the study. Then I have used the tool which are structured questionnaire, numerical pain rating scale, short-term postoperative outcome performer and self-reported practice checklist. As a result, the result of my study is, the study has revealed that there was significant difference in postoperative outcomes and of additional analgesics, status of elimination, and early ambulation when compared with the experimental group and control group. And the mean pain score was constantly lower for the experimental group than control group on all 3 days. T-value is 2.298, 3.912, and 7.188. The mean score of selected postoperative behaviors was good in experimental group. P-value is 0.000. As a discussion part, comparison of short-term postoperative outcome in experimental and control group, and that is demand of additional status of bowel elimination, status of urinary elimination, 6 to 12 hours, and postoperative pain on all 3 days was significant difference in my present study. And in the discussed study, no significant difference in status of bowel elimination, urinary elimination, and postoperative pain on all 3 days. Findings discussion, the findings of present related postoperative behaviors in experimental control group, which reveals that there is significant difference between experimental and control group with regard to post-test postoperative behaviors. And association between postoperative outcome measures in selected postoperative behaviors among patients undergoing hysterectomy with the selected demographic and clinical variables. There is significant demographic and clinical variables with the postoperative outcome and postoperative behaviors except education and age. So the above things were support study conducted by in 2022, Meghe Krishnaswamy in 2017, and Selvam in 2017. As a conclusion of my study, the study concluded that planned preoperative nursing instructional package on postoperative outcome and selected postoperative behaviors was more effective in improving short-term postoperative outcome and behaviors. Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am. Dr. Chong, can
Yeah.
you move on with the next presenter? or
Yeah,
do you
yeah,
have
sure.
anything?
Thank you for the presentation.
Thank you, Sunita. Now we have Bitika Devnath. Bitika, are you there? Bitika, this would be the final call. Bitika Devnath from Nurses Training Institute, Tripura, India. Are you there for the oral presentation?
But she did put in the chat box saying she is ready to present.
Yes, ma'am. I hope she's not here in the Zoom. Okay, we'll move on with the next person who have missed this session. Monica Devi from Government AMT School. Monica? Okay, we don't have Monica also. We do have 3 pre-recorded presentations. Now we'll see Dr. Sweta Hitnal's pre-recorded presentation. from BLDEA Sri B.M. Patel Institute of Nursing Sciences. It is an oral presentation.
Good afternoon. Myself, Dr. Shweta Hitner, Assistant Professor, Department of OBG Nursing, BLD, Sri B.M. Patil Institute of Nursing Science. Title of the study: to assess the effectiveness of syringe technique versus nipple shield technique to latch on early breastfeeding difficulty among primipara mothers at selected hospital, Vijayapur. Background of the study: breastfeeding has been important since the beginning of mankind. Nipple abnormalities are commonly encountered in clinical proforma, particularly in relation to lactation problem of postnatal period. The abnormality of the nipple includes short nipple, inverted and flat nipple, cracked nipple, etc. Most of the primipara mothers are not able to breastfeed their babies properly due to inverted nipples. During the clinical experience, the investigator come across certain mothers having flat or inverted nipples, and there was a difficulty in latching for the baby. Objective of the study: to identify the early breastfeeding difficulty among primipara mothers in selected hospital. Second, to find out the effectiveness of syringe technique on management of early breastfeeding difficulty. To find out the effectiveness of nipple shield technique on management of early breastfeeding difficulty among primipara mothers. Fourth objective: to compare the effectiveness of syringe technique versus nipple shield technique on management of early breastfeeding. Research approach. An evaluative research approach was used. Research design. Pre-experimental research design was used for this study. Population: primipara mother with early breastfeeding difficulty. Sample: the sample consists of 120 primipara mothers with early breastfeeding difficulty from selected hospital, Vijayapur. Sampling technique: purposive sampling method, and are randomly assigned to group 1 and group 2. Setting of the study: BLD, Sri B.M. Patil Medical College Hospital, Vijayapur. Variables under the study: independent variable. Independent variable in this study is syringe technique and nipple shield technique. Dependent variable: early breastfeeding difficulty. Demographical variables in this study are postnatal type of delivery, postnatal day, breastfeeding difficulties, problems in breast, gestational age at the time of delivery, birth weight of the baby. Comparison of pre-test and post-test pain score in the nipple shield technique. It reveals that severity of pain level in nipple shield technique was highly associated with the pre-test and post-test results of nipple shield technique, with chi-square value 6.54 with p-value 0.01, which was highly significant at 5%. Comparison of pre-test and post-test latch score in nipple shield technique. Level of latch score in nipple shield technique was highly associated with pre-test and post-test result of nipple shield technique, with chi-square value 9.50 with p-value 0.001, which was highly significant at 5% level. Comparison of pre-test and post-test level in syringe technique. The mean pre-test pain level was 9.1 with the standard deviation of 0.78, whereas mean post-test pain level was 2.8 with standard deviation of 0.87. The mean pre-test and post-test difference in the pain level was highly significant, as t-value is 43.44 and p-value is less than 0.01. Conclusion: syringe technique significantly reduced the pain level. Comparison of pre-test and post-test last score in syringe technique. The mean pre-test last score was 2.76 with standard deviation of 0.92, whereas mean post-test last score was 3.6 with a standard deviation of 0.48. The mean pre-test and post-test difference in the last score was highly significant as t-value minus 7.34 and p-value less than 0.01. Syringe technique had improved latch score significantly among study participants. Comparison of the pre-test and post-test pain level in nipple shield technique. The mean pre-test pain level was 3.63 with standard deviation of 0.50, whereas mean post-test pain level was 2.8 with a standard deviation of 0.97. The mean pre-test and the post-test difference in the pain level was highly significant as t-value is 5.72 and p-value less than 0.01. Conclusion: the nipple shield technique was effective in reducing the pain level significantly among the study participants. Comparison of pre-test and post-test last score in nipple shield technique. Mean pre-test last score was 3.2 with the standard deviation of 0.74, whereas mean post-test last score was 8.78 with the standard deviation of 0.79. The mean pre-test and post-test difference in the last score was highly significant as t-value is minus 44.3 and p-value less than 0.01. Conclusion: nipple shield technique was effective in improving the latch score among study participants. Comparison of syringe technique and nipple shield technique in terms of pain score. Mean pain score in syringe technique and nipple shield technique was found same. Conclusion: syringe technique and nipple shield techniques were equally effective in reducing the pain among study participants. Comparison of syringe technique and nipple shield technique in terms of latch score. Mean latch score in syringe technique was 3.6 with standard deviation of 0.48, whereas mean latch score in nipple shield techniques was 8.7 with standard deviation of 0.79. The difference in mean latch score between the syringe and nipple shield technique was highly significant as t-value is minus 43.09, p-value less than 0.01. Conclusion: nipple shield technique was found to be more effective in improving the latch score in comparison with the syringe technique. Discussion: both syringe technique and nipple shield technique were effective in reducing the pain level in improving the latch score, but when compared between the effect of syringe technique and nipple shield technique, it was seen that the effect of syringe technique and nipple shield technique do not differ significantly in reducing the pain level among study participants, whereas nipple shield technique significantly improved the latch score in comparison with syringe technique. So conclusion: nipple shield technique would be better choice over the syringe technique. Thank you.
Now I'll move on with the recorded presentation of Sandhya Meghe from Himalayan College of Nursing, SRHU, Jolly Grant, India.
Time wishes to everyone. Myself Sandhya Negi. Today I am going to present my research related work. which is sleep problem and sleep practices related to sleep hygiene among adults admitted in selected hospitals. The introduction of my study is sleep is a natural state of rest in which our eyes are closed, body is inactive, and mind does not think, with reduced muscle and sensory activity and less interaction with the surrounding. Sleep hygiene practice is one of the most important variables that affects sleep quality. Inappropriate sleep behaviors are harmful for sleep. The need of the study is, according to the latest sleep data, insight from across 18 countries, India's are the second most sleep deprived with an average nightly sleep of 7 hours and 1 minute. They rank who get an average sleep of 6 hours and 47 minutes. Therefore, researchers decided to assess sleep hygiene among adults. The aim of the study is to explore sleep problems and sleep practice related to sleep hygiene among adults admitted in selected hospitals. Assumption of the study is sample were having knowledge regarding sleep hygiene and sleep problem. Sample were true representative of population. Sample are given their true response. The delimitation of the study was delimited to adult admitted to selected hospital, Dehradun. Review of literature. Review of literature is related to sleep disturbance and sleep practice related to sleep hygiene. The research methodology. Research approach and research design. Research approach for the present study was quantitative research approach. Research design, non-experimental, descriptive design. The variable for the present study is research variables, sleep disturbance and sleep practice related to sleep hygiene. Setting and population. Setting for the study were selected hospital Dehradun. Population adult who were admitted in the selected hospital of Uttarakhand. Sample size and sampling technique. Sample are the adult admitted in a selected hospital of Dehradun who were fulfilling the inclusion criteria. Sample size is 15 adults. Sampling technique, convenience sampling technique were used. Tools were divided into 3 sections. Section A is socio-demographic profile. Section B is sleep disturbance scale. Section C is sleep hygiene index. The criteria for the selection of the sample, inclusion criteria, adults who were willing to participate in the study, who were able to read Hindi language, and who were present at the time of the data collection. And the exclusion criteria for the study is the study sample excluded all those adults who were diagnosed and admitted in the hospital with psychiatric disorder. The ethical consideration. Written permission was obtained from Principal Himalayan College of Nursing, SRH. Written permission was obtained from Chief Medical Superintendent to carry out the study in hospital. Informed written consent was taken from all the participants of the study. Confidentiality of the participant was maintained during the study. Then organization and presentation of the data. Data collected were compiled, evaluated, tabulated, and represented using descriptive and inferential statistics. Data analysis and interpretation are dependent on objective. Objective are divided into 4 sections. Section first is finding related to socio-demographic profile. Section second, finding related to sleep disturbance among adults. Section third is finding related to sleep practice related to sleep hygiene among adults. Section 4 is finding related to correlation between sleep disturbance and sleep practice related to sleep hygiene. The result. Section first, finding related to socio-demographic characteristic of the sample. This table shows the frequency percentage distribution of the socio-demographic profile. In age, we have seen that 34% were in the age group between 31 to 35 years. Weight, 48% were in the weight between 51 to 60 kg. In gender, mostly adults were male. In area 68% adults were belonging to rural area. Types of family, 54% were belonging to the nuclear family. Marital status, majority of the adults were married. Educational status, majority of the adults were having completed their formal education. Occupation, 36% were private employed. Family income, when we ask about the family income, 66% adults were having family income between 10,000 to 20,000. Addiction, when we ask about the addiction, majority of sample had given answer no. When we ask about the specification of the addiction, majority were smoker. Then, when we ask the adult about that they have shared their problem with their parent or spouse, majority of them have given the answer yes. When we ask that they have any family problem in the past 1 year, majority of them give answer no. Then section 2 to determine the sleep problem in adults. This table shows that majority, that is 70% of the adults having mild sleep disturbance, which is followed as 20% have moderate sleep disturbance, 8% have slight sleep disturbance, only 2% have severe sleep disturbances. Then section 3 is to determine sleep practice related to sleep hygiene. This table shows that majority of the adult, that is 84%, were maintaining moderate sleep hygiene practices and 10% were maintaining excellent sleep hygiene practices. Section 4 is to find the correlation between sleep disturbance among adults and sleep practice related to sleep hygiene. When we see the correlation between sleep disturbance among adults and sleep practice related to sleep hygiene, it shows there is a positive correlation which is not significant at the level of 0.05. In discussion, the major finding is most of the adult patients had mild disturbances. Most of the adults had maintained their moderate sleep practice related to sleep hygiene. Similar study was conducted by Abdullah, Mahbuz, Snehta, Suha, Asma et al. To assess sleep hygiene, sleep-related problem and their relation with quality of life in primary population in Southwest Saudi Arabia. A total 401 adults were used. Results showed that sleep hygiene was significantly detected in this group. Then limitation of the study was the small sample size, which affect the generalization of the study finding. Second, sampling technique, that is convenience sampling technique, where there is more chance of sampling bias. Strength of the study was researchers selected the statistical test based on the distribution of the data. Research This all are the references. Then the conclusion of the study concludes that moderate to small sleep problem in adult in sleep practice related to sleep hygiene. It shows mostly adults who are maintaining moderate to fair sleep practice related to sleep hygiene during their hospitalization stay. Although they maintain moderate to fair sleep practice related to sleep hygiene, but there is a need for psychoeducation on sleep practice for the adult that they can maintain sleep and can reduce the occurrence of sleep problem. These all are the references. Thank you.
Now we'll move on with the next pre-recorded presentation by Dr. Grace Medona Singh from Himalayan College of Nursing, Swami Rama Himalayan University, India.
A very warm wishes to one and all. This is Dr. Grace Medona Singh, Associate Professor, Himalayan College of Nursing, Swami Rama Himalayan University, Joligrant, Dehradun. Today I am going to present my original research work, which is related to sleep promotion education program on sleep quality, sleep hygiene, excessive daytime sleepiness, and scholastic performance among adolescents. It is a randomized controlled pilot study. Introduction: sleep is a natural refresher and rebuilder of different systems which enhance our psychological and physiological capabilities in learning new things and coping up with our surrounding. It is that golden chain that ties health and our bodies together. Scientific evidence shows that sleep plays critical role in the optimal execution of learning, memory, executive function, sustain, attention, emotional and mood regulation, all of which are essential for academic success, adjustment, and mental health. In many studies during past century, results that the shortened sleeps is a poor educational outcome and poorer health. National Sleep Foundation and American Academy need of the study. According to the National Sleep Foundation, sleep is as important as water and oxygen to the brain. In short, they say sleep is a food for the brain. Statistics reported that apparently 73% of adolescents who reported that of get less than 8 hours sleep in night. If sleep quality or its duration is lower, our body tries many ways to initiate it. Brain will increase feeling of sleepy. Lack of sleep contribute to reduced concentration, short-term memory, learning abilities, and behavioral self-control. In recent years, changes in sleep pattern occurs in many adolescents that causes decreases in quality and quantity of sleep, resulting in poor sleep hygiene practices and poor academic performance. Purpose of this study to identify the excessive daytime sleepiness among adolescents and enhance the knowledge regarding sleep hygiene and improving their sleep quality by learning relaxation techniques so that they can able to concentrate on their studies and get good scholastic performance. Assumption of the study: subjects will provide their honest answer for the item of the questionnaire. Subjects will have different perceptions about the quality of sleep. Quality of sleep vary person to person. Delimitation of the study: selected yoga postures were used in the research study to promote sleep quality. Participants respond not observing directly by their sleep quality, sleep hygiene practices, and daytime sleepiness, and scholastic performance also obtained through their report card. I have searched review of literature under these three headings: sleep quality, sleep hygiene, sleep practices, and excessive daytime sleepiness among adolescents, effects of sleep quality, sleep habits, and hygiene on scholastic performance of adolescents, and effect of sleep promotion education on sleep quality, sleep hygiene practices, excessive daytime sleepiness, and scholastic performance of adolescents. The research methodology: schematic representation of the research design. Research approach: quantitative research approach was adopted for this study. Research design: quasi-experimental time series research with control group. Demographic variables are demographic variable, age, gender, class, type of family, etc. And independent variable: sleep promotion education program. Dependent variable: adolescent sleep quality, sleep hygiene, excessive daytime sleepiness, and scholastic performance. Population: adolescents of Dehradun. Setting: 4 randomly selected schools of Dehradun, Uttarakhand. Sample: adolescents of class 6, 7th and 8th class of Dehradun district, Uttarakhand. Sample size: 50 adolescents who fulfill the criteria of sample selection. Sampling technique: non-probability quota sampling technique. Tools: baseline data, Pittsburgh Sleep Quality Index, adolescents sleep hygiene scale, Epworth sleepiness scale, for adolescents and children, and a scholastic. This is the study's design. In that, during the baseline assessment, that is on the first day, experimental and control group for both pre-testing was done. And intervention: from first day to 28th day, experimental group got intervention. And second observation done on 28th day, first post-test, that is for experimental and control group for the both group. Then again experimental started from 28 till 56th day for the experimental group, and on 56th day, third observation done for the both group, that is on 56th day. Inclusion and exclusion criteria. Inclusion criteria. Sample who had a problem is determined by Pittsburgh Sleep Quality Index and got written informed consent or permission from their parent. Exclusion criteria. Sample who were undergoing any medical treatment which were directly affected their sleep and were not available during the data collection and not willing to take any part in the research study. Pre-testing done on 30 adolescents, and all items were found to be clear and understandable by the subjects. Reliability done on 20 adolescents, and tools found reliable. Ethical consideration, dissertation, the formal written administrative permission was obtained. Dissertation committee, research committee, and ethical committee, principals of selected schools of Uttarakhand, and informed written consent from the study participants and their parents. Data analysis and interpretation. The data was arranged and illustrated in the tabulation form in the following session. There was a four session. First session is finding related to quality of sleep among adolescents. 581 adolescents participated from 4 randomly selected schools. Out of 581 adolescents, 50 adolescents identified as suffering from sleep issues. Section 2, findings related to baseline information among adolescents in experimental and control group. If you will see, 48% adolescents in experimental group belongs to age group of 14, and same as in control group also 44.4% adolescents belongs to age group of 14. And if you will see class, most of the participant in experimental and control group belongs to class A. Gender, same, experimental and control group, most of the gender belongs to experimental and control group, that is female. If you will see the family in experimental and control both group, they belongs to nuclear family. If you will see living area, most of the experimental and control group belongs to semi-urban. Section 3, finding. If we will see correlation between sleep quality and scholastic performance, here calculated R value is minus 0.835 and P value was 0.001. It's indicate that there is a significant strong negative relationship, whereas in control group there is no significant relationship between the sleep quality and scholastic performance. When we will see the sleep hygiene and scholastic performance, we can see here the calculated R value is 7.85 and P value was 0.001. It's indicate that they are having, in between them, they are having strong positive correlation. And in the control, whereas in the control group, there is a no significant relationship between them. Then if you will see the excessive daytime sleepiness and scholastic performance correlation, here calculated R value is minus 0.617 and P value is 0.002, means they were having medium negative relationship, whereas in the control group there is no relationship found. If we will move to the section 4, here we can see the mean score of sleep quality in experimental group is decreasing, whereas in the control group, the mean remain constant. That means it is the significant at the level of P value. That means sleep promotion education program was effective as it is improving the sleep quality. Same as in the sleep hygiene also, sleep education program is effective as sleep hygiene score is decreasing, whereas here in the experimental group is constant. And in the same excessive daytime sleepiness also, and here in the scholastic performance mean is increasing, whereas it is somewhat constant in the control group. So we can say it that our sleep promotion education program is effective on sleep quality, sleep hygiene, excessive daytime sleepiness, and scholastic et al. And 10E et al. And Hershran S. et al. They have supported my findings, research findings. And second objective to effectiveness, the sleep promotion education program. What result I got in my study, same result supporting study I got Gurbar, Rion et al. 2006 conducted. So we can say hence the null hypothesis was rejected. It was concluded that the sleep promotion education program was effective among adolescents. The limitation of this study, the response of the respondent depend on the memory and intellectual level, therefore many be inaccurate. The second one is that this study was limited to selected schools of Dehradun, Uttarakhand, which limited to generalization. Third one is yoga posture could be observed directly after the intervention since it's been requested to practice at home. Recommendation, a similar study can be done on the larger population for getting better rationalization of the findings. A comparative study of the sleep problem in rural and urban area can be undertaken. The analysis may be repeated on the broad sample size in district, state, national level and in variety of contexts, allowing for the generalization of the result over the larger population. A training module can be developed to convey unity. The conclusion of the study, it was concluded that the sleep promotion education program revealed a significant effect in the experimental group over the control group in sleep quality, sleep hygiene, excessive daytime sleepiness, and scholastic performance. Preliminary evaluation of the brief program to promote sleep health and scholastic performance suggests that it is feasible and acceptable to implement. These are the references of this study, and thank you.
Now we'll move on with the missed out presenter, Mrs. Vanilla from Arubade Veedu Medical College Hospital Vinayaka Mission Research Foundation for her oral presentation.
Very good evening, ma'am.
Good evening, ma'am.
My screens are sharing, ma'am.
No.
My screen visible, ma'am?
Yes, ma'am, your screen is visible. Kindly try to wrap up your
yes, ma'am. Yes, ma'am.
presentation.
Yes, ma'am.
Because you have two presentations. So
yes, ma'am. Yes, ma'am. Good evening, ma'am. Myself, Mrs. Vanilla, Assistant Professor, Department of Optometry, School of Allied Health Sciences, Arubade Veedu Medical College and Hospital Campus, Puducherry. And my topic is comparative study between spectacle wearer and non-spectacle wearer among school children. And my study's aim of the study is find out the spectacle wearer and reason for the non-spectacle wearer. An introduction. The World Health Organization recommended monitoring the outcome of school screening program due to the visual impairment, refractive error, poor vision, childhood affects performance in school, future life of this child. Spectacles improve component of refractive service for school children. Poor follow-up after school-based screening, broken spectacles, loss of spectacles, and forgetfulness, parental and children's prescription lead to the problem. And materials and methods. We have used the check the visual acuity, Snellen chart, and trial box with the help of the refractive error, George's chart to help the near vision testing, Ishihara's chart, torchlight. Site of the study, some of the schools among Puducherry, types of the studies, prospective observational studies, periods of studies, 3 months of to be approximated. Mode of studies through the offline survey only. Inclusion and exclusion criteria. The age group was studies 11 to 17 years and refractive error patients, male and female were included. And exclusion criteria, any child with the congenital eye disease, amblyopia, squint patients, cataract patients, aphakia patients, macular hole patients, macular degeneration patients, retinal degeneration patients, retinopathy patients, and other ocular problems. And these are all the results. Table 1 was gender distribution. Boys were 134 numbers and 50%. Girls, 131 girls, 49.6%. Totally 265 students got refractive error. And table 2, spectacle VRR and non-spectacle VRR among school children. Types of participants VRR, spectacle VRR 151 number of students and 57%. And non-spectacle VRR 114 students and 43%. And table 3, association of demographic factors or non-spectacles of spectacle, non-compliance of spectacle VRR. Non-compliance of spectacle VRR, boys at the age wise 11 to 13 years, 52 numbers, 14 to 17 years, 62 numbers at the percentage of 67. Table 4, proportion of self-reported reason for non-compliance with the spectacle wearer. Last of the spectacles, broken the spectacles, forgot the spectacle at home, used the spectacles sometimes, parents disapproved, teased about the spectacles for friends and public, don't like spectacles, spectacles cause headache, non-comfortable, don't feel spectacles are needed. Are you not used spectacles? Some questions are we raise the students. They are responsible. This is the figure 1% complaints of non-compliance spectacles wearer among primary school. 43% non-compliant spectacle wearer. Spectacle wearer 57%. This figure comparison of percentage of each causes of non-compliance in school boys and girls. The rate of myopic error in complaints of boys and girls. Boys number of students 80. A number of myopics 5, percentage of myopic 6.25%. And number of girls 71, and affected myopics for 4 girls only, percentage 5.63. Discussion: visual impairment and its effects on overall development, especially for children, is associated with complaints with spectacles. The study by MAP Pavitra et al., who found 57.8% for spectacle wearer of school children in South India. Like as our study found spectacle wearer to be 57%. I also agree with the result of MAP Pavitra. This study by Catazon Hollison et al. Have been reported the use of spectacles sometimes among the participants 14.2%. Like in our study, one of the main reason of non-spectacle wearer 73.3%. I also agree this reason of itself. Comparative study between the spectacle wearer and non-spectacle wearer. Students are present more than the non-spectacle wearer students in the study. These are all my reference. Thank you.
Okay, ma'am, you can move on with your next presentation also.
Yes, ma'am. Yes, ma'am. One minute, please. Ma'am, can you visible, ma'am?
No, ma'am, it is not.
Not visible, ma'am?
No, ma'am, it is not visible.
Just a minute. Now, ma'am?
Not exactly, ma'am. Kindly try to wrap it up. Already we are
One
running
minute,
short
ma'am.
of
1
time.
minute. Sorry, sorry. Yes. Yes, ma'am. Now visible, ma'am. Sharing.
Yes, ma'am. It is visible.
Yeah. Thank you. Thank you so much, ma'am.
Please continue.
My topic is impact of watery eyes among college students in Puducherry. Aim of my paper is to evaluate the impact of watery eyes among college students. Introduction. Watery eyes. Watery eyes are characterized by an overflow of tears from the conjunctival sac. It is among the most common lacrimal symptoms. There is a long list of causes that may be responsible for watery eyes. Watery eyes can be caused by one of two things. Hyperlacrimation refers to excessive watering due to irritation of the corneal surface, as in case of dry eye, corneal aberration, or corneal foreign body. The variety of conditions resulting in watery eyes makes it obvious that the symptoms can be found in young, middle-aged, and older individuals. The main aim of this study is to assess the watery of the eye, symptoms and their impact on everyday life, and to raise awareness about the watery. Methods and materials. Present study was descriptive study, cross-sectional studies. Total 711 subjects were given the response to the questionnaires in online form mode. The subjects were questionnaires regarding the complaints of watery eyes, classes, experiencing watery eye, all particular conditions, coughing, sneezing, or cold, irritation, prolonged use the gadget, mobile, laptop, television, computer, etc. Questions like reason of previous experience of watery eye, for example, irritation, using gadgets, dry eye, foreign body. Questions like past month watery eye experience, watery eye associated with mucoid pus like discharge, eyelid abnormalities like proptosis, bulging of the eyes, eyelashes abnormalities, inward turning of the eyelids, trichosis towards eye like entropion. The awareness of and knowledge that reached the subject through this questionnaires were calculated. These are all the results. Distribution of the students, their gender, male 43%, female 57%. And number of respondents age-wise, 18 years 93 number of responded, 19 years 180 students, 20 years 273, 21 110 students, 22 years 47 students. Distribution of students according to type of foreign body that causes watery of the eye. Some causes of dust, eyelashes fall in the eye, insect bite, or insect fall up, insect wings, sand, fall up dust, none of the above. These are all the categories for foreign body sensation. This figure distributing of the students according to the types of gadgets they use most commonly. Like computer used for 12 number of responded, percentage 1.7. Laptop 14 students 2.0%. Mobile 334 response. Television 328 response, not at 123 response. So totally we have examined the 711 students. Discussion, KSL EJ or range of symptoms were reported in association with epiphora. The most common of this was pruritus, followed by redness and irritation, intestine, although the overall of the patients had a history of dryness and foreign body sensation were not commonly reported in their symptoms. Newman et al. That claimed that all the patients who were complaining about epiphora did not have just one problem, and some of the cases could be multifactorial. The causes of epiphora were reported to nasoracrimal duct obstruction, dry eye, secondary hypersecretion, and multifactorial epiphora. Mohan August Ilsori result as watery eyes, significantly hindered outdoor activities. In the analysis on age, younger patients feeling greater discomfort with statistical significance. Similarly, in the study, the majority of us have watery eyes when using a mobile phone, 74%, and television 4%, laptop 2%, and computer 2%. In the study, 46% of students in the study had watery eyes, but only 17% received a treatment. 29% never received the treatment. Conclusion. This study is extremely important as it illustrates that lack of awareness among young healthcare professionals. Similar studies were warranted to analyze the widespread lack of awareness so that it can be effectively addressed. The condition watery eyes and its severity, impact, and how it affects daily life are now known by the participants through these studies. These are all my reference. Thank you so much.
Thank you, Ms. Vanilla. I think that is the end of the scientific session. I would like to heartfelt thank to the Dr. Chong, who has rendered her maximum time for the evaluation.
Yeah,
Dr. Chong, thank you so much.
Yeah, most welcome. Thank you for all the presenters.
Yes,
all the best.
you were always kind,
Yeah.
and we've had a very good question session with our participants. Thank you so much, Dr. Chong.
Thank you and all the best. Okay, bye-bye.
Thank you. Bye. I would like to call upon Mr. Siddeshwar Angadi, Teerthanker, Parshvnath College of Nursing, Teerthanker, Mahaveer University, Moradabad, Uttar Pradesh, India, to give the vote of thanks.
Yes. Thank you, Sushmita ma'am.
Yes.
Yeah. So Siddeshwar Angadi, Associate Professor from Teerthanker Parshvnath College of Nursing, Uttar Pradesh, India. Deem it an extreme pleasure to propose the vote of thanks on this 6th International Conference organized by SFNP. So I would like to begin by thanking the Almighty God, with whose blessings we could make today's conference a grand success. And my heartiest thanks to the Society for Nursing Practices for taking this initiative to organize an international conference with the theme Nurses Together for Global Health Advancements. Next, I would like to extend my gratitude to the scientific partner, BioLeaks, the research partner, United Innovators, and academic partners, Teerthanker Mahaveer University, Srimati Radhikabai Meghe Memorial College of Nursing, and Datta Meghe Institute of Higher Education and Research, Maharashtra, India. My sincere thanks goes to all the keynote speakers from day 1 and 2 who came across the globe, and special thanks to the chairpersons of all the scientific sessions, and also to the moderators who mediated and navigated the sessions in day 1 as well as day 2. And last but not the least, I would like to thank all the participants and the presenters who presented the research papers and works, which made this learning environment and the event very fruitful. And I'm sure this will be a grand, a landmark in your learning process. I wish many such kind of conferences would be conducted in future, not just hybrid, even in the offline mode as well. So I once again thank for giving me this opportunity. Thank you.
Thank you so much, sir. On that note, I'd like to thank everyone. I would like to thank each and everyone for being the part of the conference. I hope this will be a memorable day for each and everyone. And I also hope Society for Nursing Practices I'd like to thank Society for Nursing Practices for organizing such an event. Thank you all for your hard work, dedication, and your involvement for 6th ICNHS. SFNP is so thankful for each and every one, the organizer, chairpersons, committee members, review committee members, like international committee members, international participants, and delegates from each and everywhere. And also the technical assistance provider who worked hard to make this 6th ICNHS a grand successful one. A kind note of information, certificates with the feedback links. Sorry, Regina, what is the issue?
Madam, I haven't presented yet, ma'am. You haven't called me, sorry.
I hope you're not in the main hall.
No, ma'am, I am there. I am there.
She is supposed to enter into the nursing research 2 group. We have been calling her name since a long time.
Yes, ma'am. At the time there was a problem, ma'am. And again they gave me another ID number.
You have to be in the break room, ma'am. You have to be in the break room, actually.
Your
We were
session
calling
was in
your
the breakout room, but you were just
at the time I was not able to join you, ma'am. Then
No,
they
ma'am,
gave me
previously,
another.
half an hour before only we close the breakout rooms.
That's what I told. I am not getting properly the number. But again and again, one of the member from your team told me, this is
That
the
was
link.
me. Actually,
Okay,
that
ma'am.
was me.
And you told me this is a link, you please join. I
Yes, you
joined,
have
and
joined
even
it.
after I joined also, I told you I joined. And
Yes,
that time
ma'am.
also you didn't tell I have to go for breakup room. I
Yes,
waited,
ma'am, you
you
have
see, ma'am,
joined.
3:40 I joined, ma'am. I think
Ma'am, you
3:30.
can present the paper, but there will not be any evaluation because your session chat is different. But you can, if you want, you can present your paper. I can give you 10 minutes for that. That will not be issue for me.
No, you will give me the certificate. No, madam. Presentation certificate is necessary for me to submit to
Yes,
my.
ma'am, I'll give you
Yes.
time for presentation. If you want, you can present. Anyways, the certificate will be mailed to you.
Yes, ma'am. I want to present. It's only abstract, ma'am. It's not a
Yes,
whole
ma'am, you
study.
can present. Yes, you can present.
Now?
Yes, now.
Okay.
I'll give
thank
you 5 minutes time.
Okay, thank you. Thank you for your time, ma'am. My research study is labor supportive measures in improving maternal outcome. This study is guiding by Dr. Umarani and Dr. Anjana Agarwal. I'm doing my second year now. The title of the research is Labor Supportive Measures in Improving Maternal Outcome. The problem statement is effectiveness of labor supportive measures on selected maternal physiological parameters, labor pain, maternal satisfaction. Childbirth is frequently accompanied by pain. Labor pain is a complex phenomenon with sensory, emotional, and perceptive components. It can be regarded as one of the most serious kinds of pain. In 2015, the World Health Organization projected that 830 women died annually from problems related to pregnancy and delivery. The WHO suggested that complementary and alternative medicine and evidence-based practice are the by far significant measure for safe and effective labor and delivery. Maternal position, selective complementary medicine such as effleurage, counter massage, and breathing pattern are useful in the management of pain. In my study, I have included the movements and upright position by birth ball in first stage and birth bar in second stage. Effleurage, counter pressure, breathing pattern in first and second stage of labor. Using all these mentioned supportive measures improved the maternal outcomes. Let me explain the movements and upright position during the first stage of labor. Currently, individual upright positions such as squatting, standing, kneeling, sitting, hands and knee positions are identified, scientifically proved by randomized controlled trials and biomechanical studies. So literature revealed that the evidence had been available to the physiological advantages of different upright position. However, limited studies proved that upright, that is 90-degree position with movement during first stage of labor, and moderately upright, that is 60 to 90-degree position during the second stage of labor for safe and effective delivery care. The physical benefits of upright positions are many: increased uterine pressure, effective bearing down response, the entrance of the baby's head in the inlet of the pelvis is easier through the gravity and imposed fetal positioning. The drive angle of the uterus is greater when the mother is in upright, requiring less effort and quick delivery. Reduced compressions of aorta cava, aorta, that means vena cava and superior vena cava, and pelvic nerves lead to comparatively less duration, no supine hypotension, less pain, and enhances adequate placental blood flow. Pregnant women should change their position to improve the blood flow and oxygenation to the placenta with upright, moderately upright positions. The upright birthing positions can also be benefit for the baby with higher oxygen levels and Apgar scores, mothers with a more positive birth experience and feeling better. As we know already about the birth ball, it gives, these are the benefits. Secondly, birth bar. This is a very innovative thing in my study. That means there are two hand bar can be fixed in the birth table so that the mother can hold that bar and she can maintain the 90-degree position during the transient stage as well as the beginning of the first stage, beginning of the second stage. Then she can maintain 60 to 90-degree position during the crowning stage of the labor to end of the delivery. So this is the innovative which is not done in other places. Only one study which is supported in Finland, that is labor supportive devices have done that. In that, mother have been seated and it was done. Whereas for the Indian mothers, the postpartum hemorrhage and uterine tear is also common. That's why the supportive measure is little bit different with the birth bar, which can give support as well as increase the labor progress. Thirdly, effleurage, which we know already, it is a rhythmic circular motion which gives rhythmic motion which helps to forget the pain. And counter pressure. The counter pressure is helpful for to stop the pain control theory. During the first stage of labor, we have to give the counter pressure with a small ball at the back, that is from T11 to L1 place. And during the second stage, it would be S2 to S4. So when we give this kind of small counter pressure, the mother automatically feel less pain during the labor. And at last, it would be breathing pattern. The breathing patterns are different. During the first stage of labor, it will be slow, and when the labor increases, it would be a deeper breath. Then during the transient phase and all, it would be a abdominal and a deeper breath. During the second stage of labor, it will be expulsive breathing. So these are the important breathing technique which can relax the mother, as well as painless labor can be given. Many studies suggested that the breathing technique helps to relax, as well as maternal self-control, as well as maternal satisfaction is improved. So by far, there is no study proved that complementary medicine like effleurage, counter pressure, breathing technique, as well as upright position during first stage and moderately upright position during second stage is done so far. So this study is supported by our university, and I'm doing this study with the support of my doctors, and it is going on, ma'am. Very soon we'll be completing the study, and we are expecting a very good painless labor as well as maternal satisfaction. Above all, it improves the labor progress. It has so much of effort on the physiological process of labor. So right amount of care needs to be offered at right time and delivered in a right manner that respect, protect, and promotes maternal rights, which in turn promotes the maternal and neonatal well-being around the world. Thank you for listening, ma'am. Thank you for the opportunity you have given to me.
Thank you, Ms. Regina. We'll move on with the thank you note. A kind note of information, the certificates and the feedback links will be sent to you. This is the note for everyone. A kind note of information to all the delegates. The certificate with the feedback link will be sent to you with the 2 days recording to your mail from Tuesday onwards. By next week, you will be getting it. I repeat, the certificates, feedback links, and the 2-day recordings will be sent to you for your reference. You can use it for the future references. Presenters will be notified who are the winners for each session is by Monday through mail, and the winner certificate will be sent to you by next week. Organizers, keynote speakers, committee members, session chairs, moderators, all will be getting the certificate similarly through mail. I'd like to add on a note that SFNP is a platform for conducting conferences, webinars, and educational programs at colleges, universities, and institutes who are looking forward for arranging international conferences, national conferences, can hook up with SFNP. Why take a burden with the college things and academic things? So you can hook up with the Society for Nursing Practices. We will be organizing conferences which can be physical, hybrid, or virtual. Also, we can do national and international journal publication under Scopus, Web of Science, PubMed, and UGC. We do have. You can message to me or you can mail to me if you have anything in assistance for the publication. Society for Nursing Practices is ready to help you. We are looking forward, and we would enjoy hearing thoughts from your feedback, as you can also post your feedbacks as a mail to the conference mail ID. I believe that this is not the end, but the new beginning, as nursing is a building and booming profession with more advancement. With that note, I would like to wrap up and say bye to all the meaningful participants. Until next time I see you. Stay connected with SFNP for future events. Stay safe, stay professional, and stay happy. Here is Sushmita signing off. Thank you.
Thank you, Ma'am Shashmita.
I'd like to switch on the videos of all the participants so that I can take a picture.
Host has to permit to open the videos.
No, ma'am, it is already permitted to all.
It shows me like you cannot start video because the host has stopped it.
Yourself, ma'am. Who's this?
Regina, madam. You off my video, madam.
Regina, right?
Yes, madam.
Yes, I have requested. Kindly accept it.
And even for myself, Lata.
Lata, ma'am. Yes. 1 minute.
Even for me, Susama Varghese.
Anyone else? Ms. Varghese, I have also started your video.
Yes.
Tracy Benjamin, Neeraja, Manpreet, Pabalpreet. If possible, kindly just show your faces so that we can click it up. Jasvinder, Anjali, Nisha.
Excuse me, ma'am. Can you help me for a while?
Who's this actually?
Ma'am, this is Tracy Benjamin.
Yes.
Am I audible, ma'am?
Yes, you are audible.
Ma'am, I'm sitting here from, I think, from 1 o'clock and I have not presented my presentation.
Ma'am, actually, from which session you're talking, ma'am?
Ma'am, the timing which I have given, it's, I think, 1:30 to 1:45.
Yes, ma'am. On which I think so. I'm understandable. You're under
Nursing research 2. She must be in the nursing research 2 group.
I have informed n number of times that the participants has to go to their prescribed rooms.
Ma'am, actually, I was,
Now we can't do anything. We have wrapped it up. Anyways, you will be getting the presenter certificate as you have registered, ma'am. We'll take the end picture and we'll move on because it is already 5 o'clock or something like that. There is no session shares.
Ma'am, will you provide me the certificate?
Yes, ma'am, you will be getting the presenter certificate as you have registered. There are certain unavoidable situations, those who can't present or something, we will be considering it.
Okay, ma'am. Thank you so much.
Kindly, I'm going to take a final pic.
Okay,
On
ma'am.
the count of 3, you can smile for the picture. Yes, it's on the count of 3. 1, 2, and 3. Another. Yes, that was really great. Thank you so much. Thank you, everyone. Certificates will be mailed to you by next week.
Thank you.
Thank you. Thank you all.
Well organized. Congratulations. Thank you.
Thank you.
Thank you so much, ma'am.
Thank you so much.
Thank you. Thank you.
Thank you so much, ma'am.
Thank you, ma'am. Thank you.